everyone. Good evening. السلام عليكم. هل تسمعوني؟ الصوت واضح والصورة واضحة قبل ما نبتدي. Okay, great. طيب فايز, good afternoon. السلام عليكم جميعا and thank you for joining the webinar. أول شيء كل الشكر للمنظمين على الويبينار والدعوة عشان to be a speaker in this webinar. دائما يعني this is our great pleasure to be with you during this webinar. And كل الشكر للدعم الفني للناس اللي already they are supporting us والمنظمين وشكرا لحضوركم. I know some of you are on duty or you are on leave, but we will try our best inshallah to cover the whole topics during the whole day. And we will have two or three part of this webinar. فإذا حيكون الويبينار مقسوم من 3 أقساط. أول قسم حيكون معكم إن شاء الله للساعة 5. ناخد اليوم حنجرب كل بريك ما يكون نص ساعة، لأنه ما أول شيء ما نخليكم وقت طويل. تاليا اليوم في عنا حوالي 9 بوستر. بتعرفوا عند نهاية السنة وبداية السنة الجديدة في كثير من الأخوة البروفيشنال الهيلث كير بروفيشنال بيحبوا يعني they want to present their great job من خلال من خلال البوستر presentation. وطبعا this is a great opportunity to all of us to learn from them. فإذا القسم الأول حينتهي الساعة 5، من الساعة 5 للساعة 5 ونص حنكون مع البريك، والساعة 5 ونص إن شاء الله حيكون معكم دكتور أنطوان للساعة 8 إن شاء الله، والساعة 8 حنكون مع حوالي 9 presentation. بقى thank you for your attendance again, and we will be starting with the first session talking about what are the experience of patient with chronic disease. As you know نحن as introduction وقت بنحكي عن chronic disease أو الأمراض المزمنة، أو ما هي الاستراتيجيات الفعالة للسيطرة على الأمراض المزمنة أو احتواء الأمراض المزمنة. أنتم بتعرفوا يعني by definition وقت بنحكي عن chronic disease like diabetes, like hypertension, and many other chronic disease. نحن بنعرف انه اول شيء شو الفرق بين الكرونيك والاكيوت ديزيز؟ طبعا واضحه. اكيوت ديزيز هي الامراض الاكيوت اللي will happen now. الكرونيك ديزيز هي الامراض المزمنه اللي it will stay for long time whole life. ايش الفرق بين الاثنين؟ نحن وقت بنحكي عن الاكيوت ديزيز ممكن يكون بدايه الاكيوت ديزيز it might be difficult for a people, but when they will start seeing an improvement they will be fine. يعني مريض he came for food poisoning, abdominal pain، أول فترة حيكون عنده مثلا for the first few hours or the first day diarrhea vomiting، طبعا abdominal pain mild to severe، admitted على المستشفى، ببلشوا له بالمضاد الحيوي وبالأشياء الثانية، and sooner or later the patient يعني he will be okay or fine. okay يعني sooner or later the patient he will be fine. مثلا بيبلش بمرحلة من الإزعاج والقلق والألم وإلى آخره، ولكن مع الوقت everything will be fine. الكرونيك ديزيز تختلف، لأن الكرونيك ديزيز المريض ببلش وقت بيكتشف معه مثلا ضغط أو سكري ببلش إجمالا بمعنويات جدا مرتفعة. I don't know if you agree with me. بتكون المعنويات جدا مرتفعة، ولكن مع الوقت ومع طول الزمن ومع العمر وبالاخص اذا بلش كومبليكيشن ممكن هالمريض يبلش نوع من الديبرشن، بيقول انه انا I tolerated 1 2 3 4 5 6 but and what will be the end. فاذا هيدا الفرق، انه وقت بنحكي عن الاكيوت ديزيز الاشياء بتبلش صعبه، ولكن او بتبلش صعبه within a short period of time patient will be fine, especially وقت ببلش بمرحله الريكفري وبيبلش يصير عنده يعني improvement and outcome. compared على الكرونيك ديزيز الاشياء بتبلش ان فيري ايزي واي لانه المريض بيتقبلها، بالاخص وقتها ما عنده ضرر يعني على الحياه دغري. بس مع الوقت مثل ما حكينا، لانه مثلا ديابيتس، مرضى ديابيتس اوكي، ما راح يكون في تريتمنت. يعني الانسولين اتس نوت ا تريتمنت، اتس نوت يعني بياخذوا دواء وبيشفوا زي الاكيوت. لا، this is they are going to use the insulin for a long life. عرفتوا كيف؟ فاذا this is the difference. قبل ما نشوف، فاذا ما بنقدر نتكلم عن الاكسبيرينس of patient with a chronic disease بلا ما نشوف كيف بتكون ردة فعل المريض، إن كان من ناحية الأكيوت أو من ناحية الكرونيك ديزيز. أوكي. and this is the big difference. فإذا الكرونيك ديزيز is the leading cause of mortality and morbidity worldwide. هنعرف إنه يعني المرضى بتموت مع الوقت نتيجة الكومبليكيشن أو الأمراض. يعني مريض وقتها بيبين عنده diabetes hypertension he is not going to pass away، أو مريض عنده stroke or whatever. بس الشغله وما فيها انه المريض اذا هيدي الاشياء المزمنه ما انعمل لها كنترول منذ البدايه وبشكل كتير كويس، ممكن تكون سبب اساسي بالمورتاليتي والموربيديتي. لايك وات؟ جيف مي اكزامبل. كيف الكرونيك ديزيز ممكن تكون هي سبب او هي اهم سبب للمورتاليتي عند الهيومن بين after a short or long period of time. Like what? Give me example. يعني uncontrolled diabetes. ثانك يو. فاذا مثل ما تفضلت اختنا اول، يعني مريض سكري عارف انه diabetes type 1، ولا اهمل الانسولين واهمل اللايف ستايل واكل سكريات وهاي كوليسترول وهاي بلاد بريشر وهاي بادي ويت وما عنده كنترول، طبعا هذا المريض رح يبين عنده مع الوقت ممكن يكون اي اس ار دي، رينال ديزيز ورينال فيلر، وممكن يصير عنده هارت اتاك. فاذا مثل ما شفتوا هيدي الاشياء we need to control it since beginning، لانه it might be the leading cause of مثل ما تفضلتي كمان الاخت غاده اكارديوميوباثي. ثانك يو. يلي تصلب الشرايين، ضعف شرايين القلب. مشان هيك المريض فجأة بيصير في عنده هارت اتاك وعنده يعني، وهيدا بتكون مثل ما حكينا. فاذا دي كنترول سينس بيجينينج. ما عنا بدنا نعرف انه الكرونيك ديزيز ما في علاج، في لايف ستايل. هيدي كثير من الاشخاص ما بيعرفوها، بيفكروا انا عم باخذ العلاج. انت ما عم تاخذ العلاج، انت العلاج وقت بتحكي علاج تتعالج عشان تشفى. انت عم تاخذ الاشياء تتحافظ على الكارنت سيتويشن، وعشان ما يصير في عندك كومبليكيشن مثل ما تفضلت الاخت نوال والاخت غاده. ان كان ان كنترول دايابيتس بيودي لكارديوميوباثي، بيودي لكارديو اي اس ار دي، بيوصل لكثير اشياء عند الانسان، بشرط مثل ما حكينا we need to control it since beginning. فاذا وقت بنحكي عن chronic disease it's equals of lifestyle plus طبعا العلاج اللي مطلوب مقله. كمان patient experience is central to quality of care. يعني كمان دايما we need to find a proper way to improve the outcome and satisfaction. How we could improve the outcome and how can we make our people with chronic disease satisfied. As a first question, how can we improve the outcome of patient with chronic disease? عن أي outcome؟ As in how we could improve it. By improving lifestyle. زي ايش يا اخت نزهة؟ نزهت لو سمحتي. مثلا how to improve the lifestyle. give me example. بعرف انه مريض diabetes type 1. how I could improve exercise. excellent. weight control. خليه يحافظ على وزنه. weight control. food control. diet control. this is a lifestyle. في كثير من الاشخاص، يا نحن بنعرف هذا الموضوع لان هيلث كير براكتيشنر. انا بعرف كثير من المرضى وكثير من الاشخاص اللي هن بيعتقدوا انه عم ياخذوا الانسولين اتس مور ذان انف، وهذا شيء خطأ كبير جدا جدا جدا. لازم نوعي الناس عليه ان الانسولين ليس علاجا، مش شغله بتاخذها وبتصحى من الانسولين. it will improve the life, it will improve the body response. فاذا ثانك يو. فاذا التقبل والتعايش هون كثير مهمه. قالتها الاخت خلود الغامدي، ويعطيك الف عافيه. تقبل. اول مرحله بالكرونيك ديزيز، نحن وقت بيجيني مريض مع الاكيوت بيقول لك انا I'm not feeling well, I want to die, ويعمل فود بويزن، بتقولي له انه it's a matter of time. رح نعطيك المضاد الحيوي ولا رح نعطيك الادويه المصل والعلاج المناسب، وان شاء الله within few hours you will be fine. انا عند مريض الكرونيك ديزيز ما في يقول له within few hours you will be fine. ما بقدر روح على مريض الكرونيك ديزيز واعطيه a false expectation. لازم اقول له انه هيدي حتستمر معك كل العمر. but however كل ما اشتغلنا مع بعض على لايف ستايل معين، كل ما خففنا من الكومبليكيشن ومن العوارض ومن التأثيرات اللي ممكن هي تسبب لك مشاكل بالفيوتشر. اوكي. وممكن يصير في عندك كومبليكيشن. فاذا improve outcome and satisfaction، لانه المريض يعني مثل ما تفضلت الاخت خلود، انه نحن اول شغله المريض لازم يتقبل الحاله. بده يعرف انه this case، هذا المرض ما رح يروح يشفى منه، بس نحن بدنا نجرب نتعايش مع هذا المرض بطريقه ما يصير في اضرار وكومبليكيشن، ونشرح له للمريض عن الكومبليكيشن، لانه ضروري يعرف ايش هي الكومبليكيشن ريليتد. ما يروح المريض انه مطمئن البال انا عم باخذ الدواء وانا لا. بدنا نعرف انه الكومبليكيشن ريليتد it might happen at any time and the patient he needs to be totally aware about it. فاذا this is what we are going to. اهم الشغله we need to understand that more than that. يعني انا بدي اعرف انه المريض مش رح اشتغل على الساتسفاكشن بس. انا I need to build a relation of trust, empathy and empowerment. ببلش بالنقطة الأولى trust. وقت بيكون في ثقة، تذكروا إنه المريض هذا نوعية المرضى الكرونيك ديزيز it's long life. يعني هذا المريض by default he is going to do a full life follow up. يعني أنا أوقات بروح عند طبيب ما يعجبني، بقول أنا هذه أول مرة آخر مرة، أو أنا بقول خلص خليني أخلص من المرض وبلا الطبيب وبلا المستشفى وبلا التمريض وبلا اي شيء. بس احنا هون تختلف الحاله. وقت بنحكي عن الاندرستاندينج اوف chronic disease patient experience تختلف، لانه هون اهم شيء بدي we need to build a relation of trust. trust and empathy. empathy يعني انا ما بدي حسس المريض بنوع من الشفقه، انه انا عم بشفق عليه او انا I am giving him like a favor. I need to empower him. أهم شيء ما نروح على المريض إنه نتعامل معه بشفقة. بشفقة بأي معنى؟ يعني أنا ما حسس المريض إنه أنت عندك مرض مزمن وأنت حياتك تتطور وممكن يصير بدي أنا بالعكس، أنا I need to talk to the patient in a way of empowerment. كيف يعني؟ How we could empower our patient in case of chronic disease. Tell me. Or to go with life, or to stay his life with a chronic disease. Like what? فعشان how I could empower my patient with a chronic disease. فإذا what type how we could empower our patient with encourage the patient to fit excellent what else excellent فإذا نشجع أول فترة نظرية جدا مهمة أول فترة ما بروح على الكومبليكيشن بمعنى ما بقول له إنه أنت إذا ما أخذت الدواء رح يصير في عندك هارت ديزيز وإذا ما أخذت الدواء رح يصير في عندك فشل كلوي وإذا ما اخذت الدواء ممكن يصير في عندك دايابيتس مش هيدي استراتيجيز empowerment بقول له it's very important to control اول مرحله it's very important to control your weight it's very important to take your medication on time it's very important to do exercising 2 or 3 times per week for example في نص ساعه فاذا يعني this is very important فاذا مثل اوكي اكيد اخ عبد الله you need to confront the patient giving them advice to be more aware on baby excellent بس انا اللي عم بقول لك ايه يا عزيزي انه نحن اهم الشغله ما نروح دغري يعني المريض زي ما بنقوله ما بنخبره الخبريه دغري زي ما هي عرفت علي شو تذكر هذا المريض كرونيك ولونج لايف انا ما بقول له انه انت اذا ما اخذت الدواء رح يصير في عندك رينال فيلر مثلا انا بقول له انه اتس فيري امبورتنت ناخذ الدواء اون تايم وناخذ الاشياء اون تايم والدواء والفولو اب مع المريض كل 3 شهور او كل 3 اسابيع حسب ما هو تطلب وانتبه على الاكل وانتبه على شيء لانه ما بدنا نفوت باشياء ممكن نحن تسبب لك ضرر بالمستقبل يعني انا ما بيجي مريض اليوم بين عنده عم بلش دواء الهايبرتنشن او الانسولين وبقول له انتبه اذا قفيت الجرعات رح يصير في عندك دايابيتس فوت ورح نروح على الامبيتيشن ورح نروح على الجانجرين يعني عرفت كيف يعني الاشياء بدنا مثل ما نحكي بدنا ناخذها بالسياسه زي ما بنروح in a very politics way بطريقه انه ما ناذي شعور المريض وبالعكس we need to empower him اوكي لانه بساعتها مع الوقت هو المريض يعني بيعرف كل الاشياء بس انا هين عم اقول انه اول مرحله نحن كثير نعرف كيف بدنا نعمل ابروتش للمريض اكيد نشرح ايجابيات الالتزام بالدواء والنظام الصحي لتجربه اكسلنت كمان فاذا انا بروح ما بروح على هذا اللي عم جرب اقوله لحضرتكم انه انا ما بدي اروح على دغري على السلبيات بروح على الاشياء حتى شويه شويه اذا المريض حسيته ما في التزام ولا الموضوع ولا معبر الموضوع بساعتها انا اي نيد تو warn بساعتها بقول له لا هون بدك تنتبه انه يعني النيجليجنس او عدم الاكتراث او هذا هالموضوع يعني هذا هالشيء له سلبيات وهيك هيدا بساعتها يختلف الموضوع. Some patient came to me and مثل ما الأخ عبد الله came to me and tell me that I didn't take my medicine for 4 months my God or 1 year and I have high BP or diabetes يعني هذه كيف بناء على خبرتك عزيزي كيف تفسري هالموضوع طيب ليش المريض قعد حسب رأيك 1 year بلا الدواء و how he could survive or how he survived 1 year with no medication يعني هذا المريض how they survive this is a question how they survive 1 year with no medication oh my goodness ضغطه شفت 200 over 130 طبعا الأهل يلعب دور في تشجيع المريض أكيد الأهل هن الأساس بهذا الموضوع وهن اللي على يد المريض على طول بالكرونيك ديزيز المريض بموضوع الكرونيك ديزيز يعني المريض ما بيضل بالمستشفى الاكيوت ما بيطلع لتكن شفي الكرونيك لا بيمضي العمر واكثريه الوقت بيكون بالبيت هذا الفرق فمثل ما تفضلت وحكيت انه الاهل طبعا يلعبون هن الاساس بهذا الموضوع اكثر المريض لانه مثل ما قلت لكم المريض مع الوقت هي ويل بي ديبرست في كثير من المرضى بيلجأوا لوسائل مش مضبوطه انت بتعرفوا الديبرشن وانكزايتي والى اخره بفوتوك باشياء كثير يعني سلبيه بس الاهل الدور الاساسي بهذا الموضوع اذا هم طبعا هن الدور الاساسي بهذا الموضوع إذن it's very important to empower our patient مثل ما حكينا من خلال التكلم عن إيجابيات الالتزام بالدواء وإيجابيات الالتزام بالحمية الغذائية وبالاكسرسايزنج قبل ما فوت. وإذا المريض حسيت إنه ما استجاب والى اخره بساعتها بفوت بالاشياء. اكسلنت. فاذا مثل ما تفضل، اعجل لسن تتعب نفسك وانت باتصال واحد تقدر تخلي الادويه توصلك. طبعا هيدي اهميه الامباورمنت، وهيدي اهميه هذا اللي عم نتكلم عنه يا عزيزي ويا اخوان ويا اخوات. هذا اللي عم نتكلم عنه. كل ما شجعت المريض كل ما كانت في شغله كثير مهمه. يعني throughout the year، اذا بنحكي من سنوات، بنرجع لسنوات يعني أقله 10 سنين وما قبل، نحن بنعرف إنه مثلا هنا بالمملكة كان نسبة أمراض السكر كتير كتير عالية compared to now. ليه؟ شو السبب؟ لأنه التشجيع والإمباورمنت والتشجيع على الأشخاص والتشجيع على الرياضة والمأكولات الصحية والمأكولات اللي فيها كالوريز تروح على. يعني أنت مثلا إذا بنروح نحن 10 سنوات بالمرة، يعني أنا بعطيكم مثل ماي اكسبيرينس. أنا بروح مثلا على اي فاست فود او اي مأكولات، اطلع اعجبني الشغله روح اخذها بغض النظر، يمكن تكون 10,000 كالوري اكلها ولا اسال، قول بعوض. على الحين فعلا هذا كان كثير عليه تاثير. نحن ك ك كاشخاص نعيش في المملكه سواء مقيمين او مواطنين. الحين اي مطعم بتروح عليه بتشوف حاطط لك كالوري. انت وقتها بتشوف يو هاف تو عندك اثنين اوبشن، وحده فيها 10,000 كالوري والتاني فيه 2000 كالوري. فاذا if you have two kinds of food nowadays, this is what I'm saying, that nowadays our Saudi population, they are very supported in order to avoid the chronic disease like diabetes. For example, if you will go to a restaurant, always you will see two type of you will see also, or always you will see two types of food, or sorry, in the food it's written calories. Why they wrote this calories? You will have two meals, and I'm telling, before years I was going directly take any type of food, regardless it might be 10,000 calorie, and I was taken. Nowadays I'm sharing my experience. I will go in the any restaurant you will go, you will see that you have in front of each meal there is calorie. Which one you will go by default? You will say, okay, I have this one 2,000 calorie and I have this one 10,000 calorie. Why I should go for this 10,000? I will go by default. They push us in an indirect way to work on our diabetes, yes or no, and on our body weight. مظبوط ولا لا؟ Again, if you will go to the supermarket, yes, to control obesity. This is what I'm saying, which is the one of the leading cause of diabetes type 2. Type. If you will go to the supermarket as well, and you are going to take an orange juice. For example, for me, years ago, when I was going to the supermarket, I was going to some of the very favorite name of juice, taking any juice and drinking. Now, what did you notice? That all food, you will see it there, free of sugar. Yes or no? How they support the people in the kingdom to prevent and to control weight and to control diabetes, or to avoid diabetes by these measures. Another things, you remember that from time to time, so Ministry of Affairs will tell you if you will have 10,000 steps per day, even in your hospital, I'm sure there is always the willingness for the employee saying that more you will have steps, you will the first person who has who have extra steps, he will have, for example, iPad. This is it will happen. Why? Why this organization or the Ministry of Health or Saudi community, they invest on this? For what reason? Because this is one of the reason or the best reason to control or to avoid the diabetes. هيدي من الأشياء اللي كتير تم اعتمادها بالسنوات الأخيرة من قبل المينستري اوف هيلث بالكينجدوم، ومن قبل وزارة الصحة، ومن قبل الجامعات والمدارس والمستشفيات والى اخره، بالحد من الاشياء اللي ممكن تسبب or it might lead to diabetes والى اخره. فاذا always فاذا الكرونيك ديزيز بيردن يعني دايما this type of patient فاذا they might have a cardiovascular disease or diabetes or COPD or cancer, and they require a long-term care needs. يعني مثل ما تكلمنا, this is, we are not talking about acute cases دي أسبوع أسبوعين it's done. This is a required a long-term needs. وأهم شيء بهذا الموضوع that this patient, this type of patient, they need to have a complete access to care. ما يكون عندي مرضى أنا عندهم high prevalence of diabetes, عندهم يعني كتير يعني عرضة انه يكون في عندهم الامراض الدايابيتس والكانسر والكارديوفاسكولار، وما يكون في عندي برامج توعويه او اكسس تو كير، على الاقل برايمري هيلث كير. نشوف نحن ان ذا كينجدوم من وقت لوقت مثلا بيقولوا لك اليوم في عندنا اليوم التوعوي لامراض السكر وامراض الشرايين القلب والى اخره. بتشوف انه بوست ممكن يكون بمستشفى، ممكن يكون بشوبينج مول، ممكن يكون على اليوتيوب، ممكن يكون على that you receive an email. يعني nowadays بتشوفي مسج تجيك على تليفونك بيقول لك الانتباه من امراض السكر، انتباه المعايير، اخذ الدواء في الوقت المناسب، يعني الانتباه على نوعيه الاكل كلياتها. فاذا وفي سوشيو ايكونوميك امباكت اون بيشنت اند هيلث كير سيستم. طبعا سوشيو ايكونوميك لانه اللونج تيرم ديزيز ات ويل ريكوايرد ا لونج بادجت. عرفتوا كيف؟ بالاخص المرضى وقتها بفوت الموضوع الكومبليكيشن. يعني if I have a patient who is a patient who has a diabetes, uncontrolled diabetes type 1, and after more than 10 years of uncontrolled diabetes, he and being a patient with renal disease وبلش على الدياليسيس. طيب, first of all, there is a impact socio-economic. Why? This patient, he needs to be covered. For sure, he cannot afford it by himself. He needs to be covered. More patient, more budget. And if he is going to buy insurance, the insurance will pay. And if by the Ministry of Health, Ministry of Health will pay. And this is by default, it's going to be an extra budget. هذا مصروف زايد. Luckily, for example, in the kingdom here, alhamdulillah, we could afford يعني الاشياء it's affordable. يعني ما في مريض نحن الحين مرض سكر او مريض غسيل كده وجالس في البيت لانه ما يقدر يغسل. ومعظم البلدان يعني بالوقت الحالي امراض المزمنه دائما بتكون فري اوف تشارج. بس at the end كل ما كثرت هذا الامراض كل ما يزيد العبء المالي على المريض وعلى الجهه الضامنه. حتى المريض بحد ذاته حتى لو كان مضمون، بهذا المريض at the end رح يروح كيف ما كان بالاسبوع 3 مرات على المستشفى. يعني رح يكون اجتماعيا تقريبا صار منفصل بشكل كثير كبير، لانه تيجي من الغسيل يجلس يوم بالبيت يحصل اموره، رح يرجع يروح ثاني يوم على الغسيل من جديد، او ثالث يوم رح يكون عنده. يعني بالسوشيو ايكونوميك اقبل كل شيء يمكن ببطل فيه يشتغل اكيد من الناحيه العمليه، يعني حيبطل unable to work، وبساعتها فاذا رح يكون unable to have income of money، و unable to fit his family، تيظبط اموره، تيقدر يعني يخلص بحالاته الاساسيه. فاذا شفتوا الكرونيك ديزيز في امباكت. او مريض مثلا ممكن يكون مريض يعني هايبرتنشن، وهلا تفضل حدا من الاخوان انه عم بيقول انه بيجيني مريض وضغطه 200 over 130. هذا المريض he's at high risk to having a stroke، hemorrhagic stroke. يس، ممكن يكون مريض شاب، اوكي، عمره 40 سنه 50 سنه وعنده هالضغط المرتفع، وهذا هالشخص ما عمل كنترول على البلاد بريشر، صار في عنده ستروك. وقت صار في عنده ستروك هذا صار خلص، يعني بطل يقدر، لانه اذا صار في عنده ستروك ممكن يصير في عنده شلل او عطب او ما يقدر. one part of his body he cannot move his foot, he cannot move his hand اذا كان very lucky. وطبعا ببطل فيه يشتغل، ما راح حدا يقدر يكون عنده he is unable to walk or to move his hand ويكون يشتغل بشكل طبيعي بأي موضوع. في نوع آخر الغسيل البروتيني يكون بالمنزل بس ما ينفع لكل طبعا. يعني نحن هيدي اشياء واتس انوفيشن تنساعد المريض انه بدل ما، بس بالنهايه نحن عم نحكي ككونسبت انه المريض this is a complication، وما في مريض يبلش بغسيل الكلى ويوقف الا ما كان اذا عمل يعني ترانسبلانت. وهذا الموضوع طبعا انتم مش متوفر، انتم بتعرفوا هالموضوع. آه، فاذا كيف نتعامل مع المريض اللي كده؟ يعني عن وضح لي اكثر يا اخ عبد الله، لانه طرقتك كذا موضوع. على اي شغله بدك تجاوبك عليها لو سمحت؟ اللي ما يهتم. طيب المريض اللي ما يهتم، مثل ما تكلمنا بدنا نروح على الخطه، بدك تبلش تحكي بالكومبليكيشن. انه انت مثلا still you are young، انت عم من خلال اهمال الدواء ومن خلال عدم اخذ الجرعات، وممكن انت you might have a heart attack، ممكن يصير في عندك dialysis، ممكن يعني بدي بساعتها انا يعني بدي اقول له الادويه انت ممكن فور اكزامبل اذا عندك انت الانسولين وما اخذته هال اون تايم، ممكن المريض انت تكون رايح تزور ولدك او تزور والدتك او اي مكان وفجاه يصير في عندك نقص بالسكر، وفجاه تطيح على الارض وتغبى عن الوعي، يصير في عندك. يعني بدي اشرح له انه مش الكومبليكيشن اوف دايابيتس، الكومبليكيشن الاكيوت اللي بتصير على الدواء. يعني ما راح اقول له اذا ما اخذت الدواء انت راح يصير في عندك رينال فيلر، ما راح ياخذه بعين الاعتبار. بيقول لك وينك وين، ممكن ب 10 سنين ما يصير عندي. بس انت بتقول له انه انت الدواء اذا ما اخذته اون تايم، انت اذا ما اخذت دواء السكر اون تايم ممكن يصير في عندك هايبوغلاسيميا. وهذه الهايبوغلاسيميا انت تكون سايق سياره سايق سياره وفجاه تطيح عن الوعي وتصير حادث وتصير بالاي سي يو. او يعني بدي ركز على الموضوع اللي له علاقه بالدواء اللي ممكن انه باي لحظه اذا ما اخذت الجرعات حتطيح. لانه وقت بدي اقول له على اللونج تيرم انه اذا ما اخذت الدواء انت بعد فتره من الزمن سنه سنتين ما راح يقبضني كثير جد. بس انا وقت بقول له انه عدم اخذ الدواء بهذا بالوقت اون تايم باي لحظه ممكن تطيح ويصير في عندك كومبليكيشن. انا مريض دايابيتس تايب 2 ما اهتم. شوف اول شيء اذا انت يعني اذا عم تقلي على نفسك بقول لك سلامه قلبك ان شاء الله، الله يشفيك. مش جميع المرضى يعني مش المرضى اللي دايابيتس بدهم يكونوا ماشيين على بروتوكول من قبل الطبيب. ما مش اي شخص في يقول لك خاض المونجارو او خاض الجلوكوفاج او الانسولين او اي نوع. حتى عم شوف كثير من الاشياء من الادويه نواديز بيقول لك هيدي زي الجلوكوفاج. يعني نفس الشيء. شوف في شغله كثير مهمه، الشخص الوحيد الذي له الحق بتغيير الجرعات او تغيير الدواء أو أي شيء أو إضافة دواء، أو هو أثناء الطبيب المعالج، طبيب السكر الاندوكرينولوجيست. طبعا أخص بسؤال الطبيب برجع بهذا اللي عم بحكيه يا عزيزي. اوكي، اخص بسؤال الطبيب يتحمل هو اللي بيه. برجع بقول لك في طبيب معالج، يعني بس اكبر غلطه انه انت تروح مثلا تروح على صيدليه وتقول له موضوعي كذا كذا، يعطيك مثلا دواء تبلش فيه بلا استشاره طبيبك. طبيبك بده يكون عارف، لانه انت ما فيك تاخذ دوايين مع بعضهم، بتعمل سيفير هايبوغليسيميا مثلا، وبتعمل كومبليكيشن مش مضطر لها. كل تغيير على، مشان هيك اللي بيكون عنده سكري كومبليكيشن، اي عارض صحي بيرجعوا لطبيب السكر اول شيء. اذا صار في عنده مشاكل بالقلب، الطبيب القلب اي دواء بده يعطيه بده يرجع لطبيب السكر. صار في عنده مشاكل بالرئه، صار في عنده نيمونيا، صار في عنده اي شيء، طبيب الرئه حيرجع لطبيب الكلى او الاندو. فاذا اي تغيير على حالتك له علاقه باضافه دواء او تنقيص جرعات او والى اخره، ما حدا بيحق له يمد ايده هالموضوع، يقرب هذا الموضوع الا طبيب السكر المباشر الاندوكراين. هو الشخص الوحيد اللي بيعطي التعليمات وبيقول لك بقى نصيحه. اذا انت هذا الدواء من خلال طبيبك كان به، هو بيعرف حالتك. واذا مش من خلال طبيبك طبيب السكر، لازم ترجع له وتواك، لانه بعتقد ما بيسوى تمشي مع دوايين قد سيم تايم. وضحت يا عزيزي؟ فاذا المسج واضح وكثير مهم نحن نلتزم فيه. طيب، فاذا كثير رول اوف هيلث كير بروفايدر بيلدينج تراست ثرو كوميونيكيشن، مثل تكلمنا عنها كثير، and cultural competency and shared decision making. مثل ما حكينا المريض at the end ما I cannot initiate any treatment, or I cannot stop or start or change the line of treatment without talking to the patient. لانه مثل ما حكينا هذا لونج تيرم. ما عم بحكي مريض حالي طار او اضطريت فور بلاد ترانسفيوجن او اضطريت فور او ار والمريض غير واعي، لا، انا عم بحكي مريض بكامل وعيه العقلي والجسدي ويعرف المرض، واهم شيء اشرح له الحقيقه زي ما هي، وقول له شو الاكسبكتيشن وجات هيز ابروفل. لانه ما بقدر، مثل اي مريض ما بقدر بلش باي موضوع الا ما يكون it's totally يعني approved by the patient. shared decision making مثل ما حكينا، and continuity of care اللي هي أهم عامل بموضوع، هي ال continuity of care. الكير بلان tailored to individual needs. شو يعني for each patient بالchronic disease we need to have a tailored individual needs. Why? What do we mean by a tailored individual needs? واي مش عندنا بلان لكل، ما عندنا لاين لتريتمنت لكل المرضى السكر؟ ليش بده يكون في عندي تailored individual needs؟ اكسل. طيب، كل مريض ردة فعل الدواء مختلفة. excellent. is diabetes not in controlled by certain medicine, so medicine does should lifestyle. excellent. lifestyle الوضع المعيشي مختلف من شخص آخر. excellent. طيب، what do you mean by individual needs؟ في اشياء we need to have basic standard to all، ودائما بيكون في عندي individual plan. فاذا عندي standard plan و individual plan. شو الفرق؟ standard plan ما في انا مريض يكون diabetes type 1 for example ما يكون على الانسولين، yes or no؟ هيدا ستاندرد. يعني اذا انا عندي 1000 patient عندهم diabetes type 1، اوكي، اكيد ال 1000 هن ماشيين على الانسولين، يعني مرض عم ياخذوا انسولين، يس اور نو؟ اكيد المرضى ماشيين على ستايلينج سكيل، اكيد المرضى يعني they have a standard. شو الانديفيدوال كل شخص بيكون عنده بلان. يعني اذا انا مريض ماشي على انسولين صار له، اذا اخذت مثلا 15 مريض ماشيين على الانسولين، تمام، وراقبته على فتره 5 سنين، بين عندي انه اوت اوف 10 في عندي 6 ما صار في عندهم اي عوارض، they are doing very well. في عندي 4 بلش عندهم مشاكل بالكلى، صار في عندهم اي بروبلم، صار في عندهم يعني اليوريا والكرياتين very high I need to start for the dialysis. هون حسب بدي امشي حسب الكومبليكيشن او حسب الاشياء اللي بتبين، عرفت؟ بس الاكيد انه الستاندرد بلان بما انه عندهم ديابيتس بده يكونوا على، طبعا هنا عم نحكي يا عزيزي عبد الرحمن حسب الاستجابه جسم للانسولين. انا اخذت 10 مرضى الاكيد لانه مرضى ديابيتس تايب 1 ماشيين على الانسولين، اتفقنا عندهم ستاندرد، بس الانديفيدوال بيختلف. ومثل ما حكينا الانديفيدوال يعني مريض ما صار في عنده كومبليكيشن وهي از دوينج فيري ويل وعم ياخذ الاون تايم بيدل على نفس البلان. مريض عم ياخذ اون تايم الدواء وماشي على نفس بتبين عنده بعد الكومبليكيشن دايابيتس مثلا، لا دايابيتس بتبين يمكن بعد 15 او 20 سنه صار في عنده مشاكل بالكلى، صار في عنده مشاكل بالنظر، صار في عنده مشاكل بشرايين القلب، صار في عنده، بساعتها انا مضطر على individual بلان. بس مثل ما حكينا دائما الانديفيدوال بلان انا مضطر مثلا حوله على طبيب الكلى، بضطر حوله على طبيب القلب، بضطر حوله على طبيب الشرايين، طبيب، بس دائما ما بينعمل اي شيء الا ما يرجع على الطبيب الاساسي. اوكي، بس انا هيدي شغله كثير مهمه نعرفها. مالتي ديسيبليناري كولابوريشن، فاذا مثل ما حكينا كولابوريشن لانه اتريت كولابوريشن بده يكون في كولابوريشن مع كل الفئات. اوكي، يعني مثل ما حكينا بده يكون في كولابوريشن مع طبيب المعالج، بدي اضطر اعمل كولابوريشن مع الووند كير، بدي اضطر مثلا اذا عنده دايابيتس فود بدي اضطر اعمل كولابوريشن مع طبيب القلب، مثلا كولابوريشن مع طبيب الشرايين، حسب حالة المريض. I need to collaborate. I need to collaborate with the family as well، مثل ما حكينا لانه الفاميلي يلعبون دور جدا اساسي ومهم بموضوع الفاميلي. اوكي، يعني هيدي كتير مهمة انه شو هن we need to know based on the. وضحت الفكرة؟ اكسل. ودائما نحن بتعرف انه دائما بمعظم المستشفيات في عندنا السوشيال وركر او يعني الاشخاص يعني they need فاذا different type of support. ومثل ما حكينا اكثر ناس ممكن support بهالمواضيع الكرونيك ديزيز هن trust me the family are the best people to support. فاذا improving communication it's needed. Why? We need to have a clear and simple language. يعني بدي اسالكم سؤال، اذا انت اجاكم عندك مريض هو diabetes of hypertension وبتقولي له you need to be careful about your medication because of microangiopathy، شو يفهم منك المريض؟ ايش حيفهم منك؟ ما راح يفهم. ليه؟ وقت بنحكي نحن دائما نحن بنفهم مع بعضنا ك health care practitioner، بس المريض we need to use his own language. We need to use a clear and very simple language. اوكي، فاذا هاي الطريقه ما بدنا نروح على الميديكال تيرم. We need to have an active listening by provider، لانه المريض اوقات بتجلس معه طب بتقول والله إيه انا بعرف هذا المريض هيز مريض سكر وضغط صار له اكثر من 10 سنوات و اتس فاين، بعرف شو هو وبعرف ايش الحاله تبعه وبعرف ايش الميديكيشن وبعرف ايش لازم يسوي، ما بعطي اي اهميه، وهذا شيء خطا كثير كبير. انت بالعكس لازم المريض all time uh, all time you need to start with him like this is your first time you saw him، لأنه as we said chronic disease the situation it might change. Sometimes it might be stable, sometimes it might be unstable. We need to actively listen to the patient because he might give you information that it might be needed. It might change the treatment, it might change the dosage. مثلا في كثير من الاشياء الخاطئه اللي بتصير اللي بيعتمدوها الاطباء او الممرضين او اي شخص انه بيقول والله هذا مريض انا بعرفه. Oh we are treating him since 10 years. We know him blindly. نعرفه على العمياني زي ما بنحكي. يعني انا بعرف هذا المريض، بعرف عنه كل شيء وما يحتاج خلص. يعني ما يحتاج زي ما بنقول يعني فوت بالتفاصيل معه، ما يحتاج اضيع وقتي. وهذا الشيء خطأ. بالعكس لازم انت تجلس معه كل مره وتعطيه الوقت الكافي انه يوز اوف انتربريتر مثل ما تفضل الاخ زياد او زايد. يعني بتعرفوا مثلا هون بالكينجدوم نحن في عندنا كثير مرضى they cannot talk in English, they cannot talk in Arabic، وهول الاشخاص ما عنده مشاكل بالكوميونيكيشن. نترك هذه الاشخاص؟ طبعا لا. اذا we need to find a solution that it will fit the patient, it will fit to have a clear والفيدباك دائما من المريض it's very important if في عندي clear feedback from the patient. عم جرب لانه طيب فاذا مثلا let me give you example about يعني how we could have a clear plan for a patient. مثلا patient have diabetes self management program. If you are going to teach دائما بده يكون في عندي انا وقت بيكون في عندي new approach or program بده يكون في عندي outcome. طيب بيجيك مريض he is a long term diabetes and now this is the time for discharge going home and you are going to teach him what he needs to do at home. When انت بتعرف انه your goal was achieved، مريض منوم عندك والحين صار الوقت يطلع على البيت you are going to teach him how to take care. كيف بتعرف انه you achieve your goal؟ انه your goal was met with this patient. Then how you will know that your goal was met with this patient؟ مثلا المريض if you advise him, if you instruct him, if you teach him، وهذا المريض كان عم يجيك كل اسبوعين ثلاثه على المستشفى، الحين صار الموضوع كل شهر شهرين. من استجاب المريض وفهمه ثانك يو يعني. بس نحن عزيزي وئام يعقوب، بس انت how to measure it. المريض كان عم يجيك الكرونيك، كان عم يجيك every one time per month because he has a complication, diabetes food, gangrene, infection, whatever. Now he's coming to you every 3 to 4 months. And this is a great measurement that you could use it, that you achieve your goal and your patient is under control. Okay. Excellent اخ زياد. A1C مراجعات مخزون السكر. Excellent. يعني بيجي مريض عنده المخزون 12 الحين صار المخزون 7. This is a great achievement. اوكي. فاذا مثل ما شفنا هيدي العلامات بتفرجينا انه قال we achieve our goal very well. Excellent. طيب مريض عنده complication of diabetes, عنده heart failure. How you will know that you achieve your goal with a patient with heart failure. كيف تعرف؟ يعني how would you achieve your goal as healthcare practitioner with a patient with heart failure? Echo, ECG, and A1C, A1C. Excellent. Excellent. يعني for example, a patient came to you. You did 12-lead EKG, physical assessment, echo, ultrasound in order to make a file. ما عنده complication بس عملت له كل هودي تيكون في عنده فايل تشوفوا الامبروفمنت. ولاحظتي انه قلت له المريض كل سنه لازم عندك الفحص. قطعت سنه على المريض وما اجى عنده اي complication لها علاقه بالكارت هارت بروبلم. وبعد سنه عملت له نفس الفولو اب وظلت الاشياء زي ما هي. ما ما صار في، ما راح يصير في تقدم، بس ما صار في رجوع للخلف او complication. فاذا you achieve your goal. يس. فاذا انت you achieve your goal. وخلال كل هالفتره مثلا المريض ما صار في عنده اي admission related to a heart problem. فاذا you achieve your goal. Excellent. فاذا just for the, because still I have the next session just to go through. فاذا it's very important to by improving patient experience is central to chronic disease care. يعني نحن مثل ما حكيتكم بالاول ال patient experience with the chronic care it's mandatory. لازم حسن empowerment, trust, communication, follow up, education. It's needed to have a good experience for the patient with a chronic disease. وبدل هيدي الاشياء انا ما بقدر اترك المريض على، لانه مثل ما حكينا with the time patient he will be more depressed. Technology فاذا technology communication how it will help with this. اذا بدنا نحكي عن التكنولوجي، اذا بدنا نحكي عن communication how it will help with the chronic disease. وقت بنحكي مع التكنولوجي والcommunication how it will help with the chronic disease. What are the criteria? فإذا what are the criteria? Yes, exactly. فإذا if you have a patient who already the first year there is no complication on your patient. فإذا this is a great outcome or achievement. Okay. فإذا if there is less complication, you could see that you are doing a great job with the patient. فإذا clear? Any question before going to the next session? Excellent. طيب. فإذا give me a few minutes to change the slide and we will be with the next session. تمام? Thank you. Okay, good evening. السلام عليكم. ثواني بس حنكون معاكم بس عشان نسوي شيرنج. والسلام عليكم. بس ثواني لو سمحتم عشان نقدر نسوي شيرنج. في مشكل بالشيرنج، ثواني بس حكون معكم. اوكي تمام. تقدروا تسمعونا منيح؟ الصوت كويس والصورة كويس الحين؟ Can you hear me؟ واضح. excellent. thank you. طيب حنكون مع القسم الثاني خلال هالفترة، ألا وهو المانجمنت of patient with diabetes and hypertension. نحن وقت بنحكي عن المانجمنت we have different people who should manage. يعني مش دائما المانجمنت هو التريتمنت بمعنى العلاج. اوكي، يعني في عنا different types of management. Management related to treatment, management related to daily life, management for long term, management for acute term, and with support سواء emotional أو any type of support. This is part of management. طيب، فإذا نحن أول شيء إذا بدي أروح على طريقة very very simple وقت بحكي أنا عن المانجمنت، فإذا بدي يكون في عندي الميديكال مانجمنت. يعني فور اكزامبل if a patient he is a hypertension، تركز على موضوع الهايبرتنشن. فور اكزامبل he needs to receive a treatment. في كثير من الاشخاص، اوكي، في كثير من الاشخاص بيعتقدوا انه الانتي هايبرتنشن مثلا ميديكيشن، اوكي، it will have يعني since you have a blood pressure under control، تمام، you could stop it at any time. وهيدا شغلة خطأ، لأنه once you start the anti-hypertension we need to go for it to the whole long life unless يعني هلا بالمحاضرة الثانية ممكن دكتور أنطوان يعطينا بعد معلومة أكثر وأكثر على هذا الموضوع. فاذا كثير مهم نعرف انه نحن اللاين اوف تريتمنت بموضوع الهايبرتنشن انه once we start the treatment the anti-hypertension medication we need to go for it till the end. وننتبه على الاشياء اللي ممكن ترفع الضغط. زي ايش؟ give me example. مثلا اذا بدي ركز على موضوع تريتمنت الانتي هايبرتنشن ميديكيشن like what would you advise على موضوع مثل ما حكينا التريتمنت مش دائما هو الميديكال تريتمنت بمعنى الميديكيشن بس. يعني انت عندك ميديكيشن وعندك كثير اشياء ممكن it's mandatory to for a patient with diabetes or hypertension like what. give me example. like what.
الملح اكسلنت. تقليل الملح الدايت، تقليل التوابل والأملاح في الأكل. تقليل الموالح في الأكل اكسلنت. الحمية الغذائية، كثرة شرب المي، ممتازين. فإذا مثل ما شفنا in addition على الانتي هايبرتنشن ميديكيشن اللي أنا بعطيها، اللي هو المضطر نمشي عليها فور لونج لايف، كمان في اشياء ما بيكفي انه امشي على الميديكيشن واهمل الموضوع مثل ما تفضلت، انه ما بدي يكون في عندي انا اوفرلود، ما بدي يكون في عندي كثير من الموالح، ما بدي يكون في عندي وزن زايد، ما بدي يكون في عندي مأكولات زايدة واشياء تعلي لي الكوليسترول وتعلي التريجليسيرايد، وبعدين اقول انا I am receiving the antihypertension. ابتعاد عن مسببات التوتر. Thank you يا أخ زياد. Excellent. This is one of the leading cause. أكثر سبب بيوصل أو الدبريشن، التوتر والأعصاب وهذه كثيرة. ونحن بتعرف يعني as healthcare practitioner بحكم شغلنا وبحكم daily basis تبعنا، نحن يعني we need to this is بنجرب to control it but still out of control. Next. Next. فاذا نحن وقت بنحكي عن الباثوفيسيولوجي اوف دايابيتس، هون حكينا على موضوع هيك، وبدنا ننتبه يعني نحن this is a complete package. يعني انا بدي بلش بموضوع الدايابيتس، موضوع الهايبرتنشن مثل ما حكينا، ما في ركز على موضوع الادويه لانه بعدين رح يصير في كثير من الكومبليكيشن، واكثر كومبليكيشن هي معروفه ومسببه بهذا الموضوع الهارت فيلر وموضوع الستروك. اوكي، موضوع الستروك اللي هو as you know we have different type of stroke، واكثر شغله or we have two types of stroke اللي هي اسكيميك وهيموراجيك. وطبعا اكثر موضوع له علاقه بموضوع الهيموراجيك ستروك هو وقتها بصير في عنده هاي بلاد بريشر والمريض هي اند يعني بيصير في عنده موضوع الستروك. اوكي، فاذا كثير مهمه انه أعرف إنه أنا what will be the complication of the disease that I will be facing. لأنه المريض هون بهالحالة بدي أقول له أنت you have a hypertension، أنت عندك ضغط مرتفع، we need to be careful لأنه أكثر عارض ممكن يصير في عندك هو موضوع الستروك. وبدي اقول له اي عارض we need to report it as soon as possible. يعني المريض صار في عنده فجأة ارتفاع بالضغط وصار في عنده حصمة النمنس، او مثلا he cannot move his limb or he cannot move his feet or he cannot talk properly or he cannot swallow properly or he cannot tolerate any food or any he needs to report as soon as possible على المستشفى. اوكي، فاذا هيدي من الاشياء كثير انا مفروض انتبه لها، انه حذر المريض على موضوع الكومبليكيشن related to hypertension. كمان we need to talk about the complication related to diabetes. يعني وهيدي الشيء رح اجرب يعني اتكلم عنها بشكل بالاخص موضوع النفروباثي، نيوروباثي اند ريتينوباثي. رح اركز على هيدي الثلاث اشياء الى موضوع الكومبليكيشن. وقت بحكي عن النفروباثي، طبعا المريض بالمراحل الأولى on the first stage of diabetes، بالأخص إذا كان uncontrolled diabetes، ما رح دغري تبين عنده موضوع الأمراض الكلى. It will take a long time. يعني بدها تاكل، يعني مريض ما عنده كنترول على الديابيتس وما بيعمل فحوصات، المخزون السكر عنده جدا مرتفع، بس ولا مرة يعني عذب حاله وشيك كل 3 شهور على مخزون السكر، ماشي على الأدوية اللي يعني ممكن المريض بلش على بروتوكول starting on a oral anti diabetes patient، بس بعدين يصير بيحتاج الانسولين. بس هذا المريض نتيجة الإهمال ما راح عند الطبيب ولا اتكل انه انا عم باخذ هيدي بتصير انا، وانا بعرف كثير من الحالات الطبيب او المريض بيتكل انه خلص انا عم باخذ انتي هايبرتنشن او عم باخذ دواء السكر بتابلتس وما يحتاج خلص يعني اي ام كفر. وهذا هالشيء عم بيعمل له كل يوم مشاكل وأذية للكلى، وبيوصل المريض لمرحلة بعدين فجأة بفوت فور اني كومبليكيشن وبياخدوا له موضوع اليورا وكرياتين، بيبين عنده انه المريض هي از عنده كتير عرضة أو المريض he has a renal failure، بيضطر بفوت بموضوع غسيل الكلى. وهذا موضوع كمان كتير بتشوفوا يعني يعني 99.99 إذا مش 100% مرضى غسيل الكلى هن مرضى ديابيتس. اوكي، مشان هيك الكنترول كتير مهمه. واحده من الكومبليكيشن مثل ما حكينا it will happen to the patient especially for after a years of uncontrolled diabetes هي موضوع النفروباثي. بشو فجأة المريض صار على موضوع غسيل الكلى وبيضطر مثل ما حكينا كل بالأسبوع 3 مرات أو 4 حسب البروتوكول to go، وبساعتها بصير ب complication ممكن لو انعمل كنترول من الأصل ممكن كان بغنى عنها وما يحتاج يوصل لهيدي المرحلة اللي صار بها. النيوروباثي كمان النيرف، يعني المريض نحن كتير مهمة انه to instruct the patient بموضوع النيوروباثي. يعني المريض كتير اللي بده يعرف انه especially على اللونج ران على اللونج تيرم بالاحساس المريض بالحالته بصير كتير خفيف. يعني مثلا ممكن يصير في عنده يحط رجله او يحط يده بمي جدا سخنه وما يحس فيها، او ممكن يصير في عنده كمان يحط يده بمي جدا مرتفعة الحرارة وما يحس، بيصير في عنده burning. أو ممكن المريض يعني هيدي كتير إشياء المريض he needs to be instructed about it on how to be careful on how to take care and how to avoid such things إنه ما يتعرض. وكثير مهمة موضوع الديابيتس فوت اللي هي يعني أحكي عنها الحين. ديابيتس فوت كتير مهم المريض ينتبه لها. ديابيتس فوت هي ما رح تيجي عند المريض بيوم تاني، يعني for many statistics and many things shows انه المريض اللي بيكون على اكثر من 15 و20 سنة على موضوع ديابيتس which is not controlled or out of control المريض بيصير في عنده الديابيتس فوت. Now how we could prevent a diabetes foot for a patient and what to do in case you had a patient with diabetes foot. كيف بنعمل البريفنشن انه ما يوصل لمرحله كيف تبلش موضوع، يعني كيف ببلش موضوع diabetes foot مع المريض and what can we do to treat a patient with diabetes foot. Tell me. يعني what إذا بدنا نعمل موضوع diabetes foot، يعني what are the early signs of diabetes foot for example. شو ال early signs of diabetes foot؟ هل يا ترى فجأة المريض بيوعى he has diabetes foot؟ for sure no. إذن what are the early signs of diabetes foot؟ فإذن إذا بتشوفوا when you will see the foot of the patient you will see it's like there is no proper irrigation، بتحسوها مثل كأنه شريدة البياض. okay and he will start saying that I'm not feeling very well on my feet and when you will look to the feet you will see that it's very dry. بتلاحظوا انه it's very dry. next it's very dry، بتحسوها انه هي جدا يعني مثل منشفة. عرفتوا كيف؟ that it will show that there is no proper irrigation. okay هيك ببلش مع المريض. not treated ما نعطى اي يعني ضعيفة it's for sure، يعني he cannot walk properly، بيقول لك انه انا عندي صعوبة to stand on my feet I cannot feel it very well and I cannot move it very well, and you will see like it's like a glass زي لوح الثلج. عرفتوا هذا التشبيه المظبوط؟ لا بس الفرق انه النشفان بس نفس لون لوح الثلج نفس الشيء. هيك بتبلش عند المريض وبصير المريض slowly he is going to يعني ببلش المريض slowly الحالة تروح أكتر وأكتر. بعدين المريض ببلش عنده نوع من الانفكشن، تحسوا مثل ما حكينا هاي المرحلة الأولى. المرحلة الثانية بيصير المريض عنده التهابات بالرجل، مثلا إذا كان for a simple things الأشياء اللي بدها ريكفري إن one day تاخذ معه 10-15 يوم وبعدين it will not recover. ممكن يعني بتصير poor recovery و infection. هيدي الانفكشن not treated بعدين it will go to a pus، يصير نوع من العمل، ونوع منها بيبلش إفرازات وبيبلش مرحلة الدمج سواء بالعظام أو سواء بالمصل، وبعدين المريض بيروح على مرحلة يعني في ديفرنت بنضطر نفوته على الأو ار عشان يعني ديبرايدمنت. وفي كتير من العلاجات nowadays يعني موضوع الهايبرباريك اوكسجين ثيرابي انه المريض بيضطر ينعطى اوكسجينيشن ات هاي ليفل عشان. طيب what will be your role؟ انت المريض you know that he is on the early stage of diabetes foot. شو هي الانستراكشن that you need to give it to the patient at home in order to avoid diabetes foot or to keep it at the same level? What to do? Next. Question: what to do? إذا مريض diabetes foot, what things he need to look after at home or to take care؟ شو الأشياء اللي لازم ينتبه لها أو وما ينتبه ما تصير معه؟ مثلا while he is cutting his nails, what to do? how to cut nails، كيف بقص الأظافر مثلا. فإذا بده يقصهم بطريقة ما ينتبه ما يجرح، وبده in a way that it won't يعني ما ينتبه ما يضطر يجرح رجله فجأة. the types of socks الجواري اللي يلبسهم المريض it should be not نايل، مرش يكونوا نايلون، حيكونوا cotton 100% لأنه هيديك بتسبب التعرق وبتسبب التعرق وبتسبب انه more infection. الشوز تبع المريض ما لازم يكون كتير شديد على الرجل ويكون كتير طريقة المريض يعني ما تعرضه انه يضغط على الرجل ويفقد الإحساس أكثر وأكثر. طيب if the patient will ask you that I need your advice on how I should perform exercising at home، أو أنا بقول لكم مثل عم نحكي كرونيك ديزيز يعني الحياة حتستمر والمريض ما رح يضل كل حياته جالس بالسرير، وأصلا نحن ما لازم نطلب من المريض يضل جالس على طول. طيب بيسألك أوكي I need your advice on what to do, what can I do just to continue my life, and as per your advice I need to do exercising every day. What would you advise me؟ شو بتنصحني بهذا الموضوع؟ فإذا إيش النصيحة اللي بتعطوها للمريض بهذا الموضوع؟ بموضوع الاكسرسايزنج. Every day walk at least 30 minutes. طيب every day يعني كذا نظرية يعني maybe at least not every day or at least 3 to 4 times per week. Shoes تجنب المشي okay he should walk with his shoes for sure and طيب if you advise the patient to walk for half an hour, what kind of precaution or follow-up or things that he need to notice during this half an hour walking؟ ايش الاشياء اللي لازم ينتبه لها او يشيك عليها or to be careful خلال مشي هذه النص ساعة؟ like what؟ شرب الماء excellent for اوكي تجنب الأماكن الوعرة excellent. فإذا he needs to go to walk on a straight way يعني I wouldn't advise him just to go through a stairs ما يطلع على الأدراج وما يطلع بالجبال. he needs to be keep hydrated بده يكون كتير ياخد يعني water بده يكون معه و very very important the moment when the patient he feel dizziness or blurred vision or he feel tired he need to go back stop walking or go back immediately and always he needs to keep like a sugar with him يعني بده يكون في عنده كانديز او اي شيء بجيبه لانه المريض ممكن يصير في عنده هايبوغلايسيميا ويصير في عنده يطيح او يغيب عن الوعي او يحس حله بدوخان او يحس انه بلورد فيجن. بهالطريقه لازم يحط يعني اي شيء كانديز عشان يرفع السكر and he needs to go back. فاذا هيدي الشغله كتير مهمه that we need to instruct our patient while walking. طيب ايش انواع الرياضات التي تنصحون بها وايش هي انواع الرياضات التي يجب تجنبها؟ فاذا what kind of exercise that the patient he need to do it or what type of exercise that he needs to avoid it like what؟ تمارين الكارديو كنصيحة اوكي excellent. يعني the type of exercising it shouldn't be very heavy يعني طبعا المريض ما بنصحه برياضات الحمل الأثقال مثلا اوكي كتير مهم انه انا يعني بدي اعمل له بدي ركز انه مش الهدف نحن مثلا بالنسبة لنا الهدف من الاكسرسايز يعني الهدف من الاكسرسايز هو انه just to keep your health مش to build a muscle. نحن وقت نروح على رياضات زي رفع الاثقال نحن we are going to build a muscle. نحن هون المريض انا مش طالب منه to build a muscle. انا كل اللي طالب منه انه just to keep him in a healthy way healthy mood. تحسن البرفيوجن تحسن الهارت تحسن عمل القلب عمل الكلى عمل الكل. فإذا كتير مهم هون انه انا ركز على هذا الموضوع على انواع الرياضات. فاذا مثل ما شفنا انه risk factors are similar يعني اذا بنشوف قديش يعني مدى الترابط بين أمراض القلب أو بين الدايابيتس والهايبرتنشن as a chronic disease because they have the same. يعني الأوبيزيتي بتودي لهذا الموضوع اللايف ستايل and they have different aspects. فإذا كثير نحن كثير بنخاف بموضوع يعني أكثر complication. we have many complications but أكثر شغلتين هن very well known عند مرضى الهايبرتنشن هي موضوع stroke complication، وأكثر شغلة هي very well known عند مريض السكر هي موضوع الكدني فيلر. فإذا we need to be careful on this too. هودي يعني الأكثر complication اللي ممكن يكونوا قدوا عند هودي المريضة. next please. وهيدي الريسك مثل ما حكينا الريسك فاكتورز المعروفة اللي هي الايج جينيتكس. what do you mean by the genetics؟ يعني شوفوا مثلا I want to tell you very important information. مثلا بنحكي عن الكاردياك بروبلم. صحيح يعني معظم for your information انه مثلا الكاردياك البروبلم عند الفيميل هي اكثر من الميل باي ذا واي. يعني for you to know نحن اكثر شيء ممكن موضوع يعني الكاردياك ديزيز والكاردياك بروبلم if you will take by genders for example in the male it's more than the female. okay this is for your information. other برجع بقول لكم يتوقف على اللايف ستايلز والاشياء الثانيه. next. A clinical assessment سواء for all type of chronic disease we need to have what we call a comprehensive history and physical exam. الهيستوري first of all إذا بتلاحظوا إنه معظم الكرونيك ديزيز هي related to a family history. يعني من يعني I know you will tell me أنا بعرف مريض أو بعرف شخص هو عنده سكر وعنده ضغط وبس من الفاميلي على مدى السنوات ما في حدا عنده. I agree with you. بس إذا بتشوفوا statistics أو بتشوفوا أغلبية المرضى اللي عندهم diabetes واللي عندهم hypertension هن they have a family history. okay they have a family history. يعني بيكون عنده الوالد الوالدة الجد هيك عندهم دايابيتس وهذا الشيء بيكمل مع العائلة. هاي الكرونيك ديزيز هيدي المشكلة انه they are too much related to a family. بيكون عندهم الفاميلي هيستوري وفجأة بصير الموضوع يعني مع الوقت. وكثير مهم ننتبه له بالاخص اذا له علاقه الموضوع بالسام ديزيز مثلا الكانسر كولوريكتال كانسر مثلا. في كثير statistics بينت انه هيدي باي فاميلي بيكون المريضة مشان هيك بنقول بعمر ال50 مثلا او عمر ال45 وما فوق بدك تبلش انتبه على signs and symptoms اللي له علاقة بالكولوريكتال كانسر. مثلا بالمريض فجأة عم يصير في عنده constipation، فجأة المريض صار في عنده blood بالستول، فجأة المريض يعني لازم يعمل كولونوسكوبي بعمر معين. يعني شفتوا الكرونيك ديزيز الامراض المزمنة كثير تتطلب متابعة ما في اهملها. ما بقدر أنا أهمل هذا الموضوع بشكل كلي. فإذا بدي أعرف الفاميلي هيستوري هل يا ترى كان في عند الفاميلي في هيستوري أوف دايابيتس، هل يا ترى في هيستوري أوف هايبرتنشن، هل يا ترى في هيستوري أوف كانسر، وإيش هو أنواع الكانسر وإمتى بلش. مشان أقدر أنا when I will put an action plan أو بس أعمل أنا follow up عند المريض أعرف إنه this is what do we need to do. اوكي طيب كمان من الاشياء نحن مش دغري بنحط الدايجنوزس. يعني مش يجي المريض فجأة صار في عنده blood pressure دغري بنقول له this is the anti-hypertension medication. yes. فإذا كتير مهمة نعمل يعني بنسميه البلاد بريشر مونيتورينج على القليلة for the first time. نطلب من المريض to have the الكاردياك هولتر مثلا يضل عنده البلاد بي بي ماشين، نراقب عملية الضغط خلال 24 ل 48 ساعة تنشوف هل يا ترى المريض how he is doing with blood pressure. هل يا ترى عم يعلى البلاد بريشر هل يا ترى عم يوطى. in addition بنطلب بعض الفحوصات المخبرية على هذا الموضوع. زي إيش؟ يعني مشان قبل ما نحط المريض إنه he is a diagnosed as hypertension patient، شو هي الأشياء اللي نضطر نطلبها للمريض to confirm diagnosis like what؟ زي ايش؟ انا اعطيتكم اكزامبل كاردياك هولتر، بنضطر نحط مكانة الضغط على يد المريض على يومين تنرقبه، بس كذا شيء ما بيكفي. ملف الدهون اكسلنت، وات ايلس؟ غير شيء. electrolyte CBC complete CBC excellent. weight thank you. شغل كتير مهم. ايكوغرافي بنعمل للهارت وبنعمل للكدني. ليبيد بروفايل اكسلنت. الايكو هارت بنعمل ايكو للكدني كتير مهمة. تايرويد هرمون T3 T4 كالسيتونين. ليبيد بروفايل اكسلنت، بالاخص على باد كوليسترول ال LDL. فاذا هيدي كلياتها وي نيد تو هاف، ما يعني اللي بدي لكم انه ما بيكفي انه المريض يعلى ضغطه مره او يوطى تحطه از انت تو بي دايجنوز خلص از هايبرتنشن بيشنت وبلش له بالتريتمنت. لا، فاذا هيدي كلياتها نضطر نعمل كل هودي الفولو اب قبل ما الطبيب يضطر يعني يوصف الدواء اللي لازم يطلبه. البلاد جلوكوز مونيتورنج كمان، ايش هي الاشياء to confirm that the patient is a diabetes patient؟ ايش هي الاشياء المطلوب نعملها just to confirm if the patient he is a diabetes patient؟ زي ايش؟ like what؟ just to put confirmation. يعني في اشياء انا مضطر اروح عليها وسويها مشان احط الكونفرميشن انه المريض مثل ما قلت لكم على موضوع سكر ترامي اكسلنت. فاستنج بلاد شوجر ثانك يو. 3 months بلاد شوجر سكر ترامي اكسلنت. تحليل السيولة ممتازين ما شاء الله. اليوريا كرياتينين كومبليت بلاد بروفايل. اوقات نضطر على ايكو او سيتي كدني. انسولين فاستنج تيست اكسلنت. فاذا this is all يعني يعني الرينال فانكشن. فاذا هذه كلها اشياء that we need to do it we need before putting the final diagnosis. لانه وقتها بنحط نوصل لمرحله already we have the final diagnosis خلص يعني this patient he needs to have a line of treatment that he need to follow it. Next. فإذا we need to have the clinical assessment. اوكي، الكلينيكال assessment شغله جدا مهمه اللي هي يعني including الفيزيكال assessment بنسميها الهيتو physical assessment including الفاميلي هيستوري اللي بنرجع فيها for a period of time تنشوف what was the family response or what was the family history على هذا الموضوع. Next please. فاذا جولد اوف مانجمنت، انا اهم شيء عندي انا وقتها بدي احط لاين اوف تريتمنت للمرضى. I need to achieve a goal مثل ما حكينا. وقتها بعطي انا الانتي هايبرتنشن ميديكيشن او الانسولين او وات ايفر، انا في عندي جول هدف منه. يشفى المريض 100%؟ طبعا لا، بس انا I need to keep the blood glucose level and the hypertension or the blood sugar or hypertension blood pressure up to certain level. وبدي اقول للمريض انت بتراقب مستوى التراكمي على هذا الموضوع، وبتراقب السكري on a daily basis، وبتراقب ضغطك على daily basis، وعلى اساسها تتصرف. طالما الاشياء under control there is no problem. اذا لاحظت تفاوت علو بالضغط او قشط الضغط او علي السكر او قشط السكر in addition to a clinical symptoms، يعني عالي ضغطك او وطي وبلس عندك clinical symptoms severe headache او مثلا blurred vision او dizziness، you need to contact the doctor or you need to come to the nearest hospital. هيدي اشياء كتير مهمة نحن نعرفها. فاذا انا بدي احط targeting goal مش بيكون لإلي بس، بده يكون المريض بده يعرف المريض انه التارجتنج جول انه على البي بي مثلا we need to maintain your BP. فاذا on a daily basis check your blood pressure، or اذا ما قدرت كل يوم اذا حسيت عندك صداع check your blood pressure، و your BP range should be 130/80. اكتر من هيك you need to report، واقل من هيك you need to report. you need to be careful على الاشياء اللي ممكن هي بنسميها تريجر، هي الاشياء اللي ممكن تعلي الضغط او اللي ممكن الاشياء اللي هي توطي الضغط. فاذا you need to be careful على هيدي الاشياء اللي ممكن تعلي الضغط او توطي الضغط على هذا الموضوع. نفس الشيء ينطبق على موضوع السكر. مرضى السكر في شغلتين مطلوبة منهم on a daily basis check the blood sugar كل يوم، ياخدوا البلاد شوجر بذات الوقت يلتزم بمواعيد الانسولين. في اشياء بتتاخد مره بالنهار، في اشياء بتتاخد بالصباح، في اشياء بتتاخد يعني حسب البروتوكول من الطبيب. فاذا مطلوب الالتزام ببروتوكول الطبيب بنسبه 100%، وبلس لازم يشيكوا على البلاد شوجر every day، وبلس لازم يعملوا مستوى السكر التراكمي at least 3 or every 3 months one time. هيدي الاشياء مفروض تمشي على. فاذا في عندنا مطلوب اشياء on a daily basis، وفي اشياء مطلوبه on a quarterly basis، وبعدين بينطلب فولو اب. مثلا الطبيب يقول لك انا محتاج اشوفك مره بالسنه او مرتين بالسنه او ممكن حسب يعني الاشياء اللي بتصير. but be careful انه نحن في عندنا رينج مفروض ينمشي عليه. بموضوع البلاد جلوكوز بموضوع البلاد بريشر من الاشياء ما لازم تزيد ولا ما لازم تنقص، لازم نحافظ عليها فاذا بشكل كتير كبير. واي شيء مثل ما تكلمنا ينعطى انستراكشن للمريض بشكل كتير مهم انه they need to follow it on time. وكله ما حكينا وقتها بنمشي على يعني النورمال رينج، يعني ان شاء الله الاشياء بتكون اندر كنترول وما بصير في عندنا الكومبليكيشن بنخاف منها سواء كارديوفاسكولار او رينال كومبليكيشن. وات ذا اند يعني مثل ما تكلمنا وزدنا بالموضوع انه نحن اور جول بهذا الموضوع is to improve the lifestyle. وفي كتير من المرضى والاف من المرضى بيكون عمرهم 80 و90 سنه وعندهم دايابيتس وهايبرتنشن وما صار عندنا اي كومبليكيشن. يعني مريض ممكن يكون عمره 90 سنه وبياخذ الانسولين وبيلتزم بالانسولين وما صار في عنده لا ريتينوباثي، حتى ما صار في عنده مشاكل بالنظر ممكن، ولا صار في عنده رينال ديزيز، ولا في عنده كاردياك ديزيز، ولا عنده اي شيء. وفي عندك مرضى بيكون عمرهم 50 سنه 40 سنه وعندهم كل الكومبليكيشن باكج، عندهم من كل شيء. عشان هذا مثل ما حكينا at the end يعني في شيء بيدنا وفي اشياء يعني رب العالمين سبحانه وتعالى، في اشياء بتصير هون واشياء بتصير هون. فاذا we need to do our best، we need to try يعني على اللايف ستايل، على الميديكيشن، على كل شيء and in order to achieve our goal. فاذا هيدي نحن بنكون انهينا القسم الاول. Do you have any question to ask me؟ في شيء بتحبوا تسألوني قبل ما نروح على البريك؟ Still I have 5 minutes for question. إذا أي سؤال بتحبوا تسألوني إياه I am ready to answer your question before moving to the next part. Before moving to the next part If you have any question. فإذا ستيل مثل ما تكلمنا نص ساعة إن شاء الله حتكونوا مع الدكتور أنطوان على الساعة 5:30. طبعا في طبيب قلب معروف وحيعطيكم كتير من السيشن. It's very high importance. وبنرجع مثل ما تكلمنا بعد يعني بعد ما خلصنا بيكون عنا على الساعة 8 وربع إن شاء الله بيكون عنا كمان around 9 poster presentation. فإذا if a 14 years old boy diagnosed diabetes then it will be diabetes 1 and 2. طبعا بنرجع على الفاميلي هيستوري and mainly وقتها معظم الأطفال بهذا العمر بيكونوا diabetes type 1 إلا إذا كان مثلا ما عنده أي هيستوري وعنده very extra weight بيكون وزنه يعني البي ام اي والوزن كتير كتير عالي بالنسبة لعمره ممكن يكون diabetes. بس معظم الأطفال بهذا العمر بيكونوا على diabetes type 1. نورمال ويت فاذا مثل ما تكلمنا هذا الطبيب اللي بيحدد بهذا الموضوع بس at some point it's diabetes type 1 especially it will come يعني at this age with no extra weight no poor lifestyle والى اخره it's mainly diabetes type 1. Any other question? Thank you for your attendance. Now we will give you around half an hour break. مثل ما قلت لنا ما فينا نعطي بريك على وقت طويل لأنه we need to have a long program we need to finish. وإن شاء الله على الساعة 5:30 بنكون مع الدكتور أنطوان. Thank you for your attendance. From my side this is all done. وإن شاء الله بنشوفكم بخير وسلامة next time. Thank you.
Great. Do you see the slides? السلايدز مبينين عندكم على السكرين؟ Okay, great. I will start by my presentations. I'm Dr. Antoine الخوري. I'm a cardiologist. أنا بشتغل بكندا واليوم رح أعطيكم 3 lectures. My colleague Nidal gave you a lecture also about diabetes and hypertension. I will also give you a topic uh, we'll talk about this topic too, but we'll talk about different things. Someone is saying that Dina is saying that she's not seeing my screen. Um, are you able to see my screens or not? Okay, great. So I will start. We'll talk first about diabetes and hypertension. Uh, so, uh, so diabetes, as you know, is a chronic medical condition. It's characterized by elevated blood sugar levels. So we have hyperglycemia, as we call it. It happened when our body doesn't produce enough insulin. So insulin is secreted by the pancreas. And when we don't have enough insulin or when we don't effectively use the insulin, in that case, we will develop diabetes over time. It's a very, very prevalent disease. So around 460 million people worldwide have it. And it's projected that in the year 2045, there will be 700 million people with diabetes. So it's a very, very common disease. I'm sure every one of you know someone that have diabetes. So it's very common. In the US alone, we have 34.2 million people with diabetes, which is about 10.5% of the population. And each year we have new 1.5 million American which are diagnosed every year. So it's really common. It's not just a disease, it's really a life condition which require careful management. So because uncontrolled diabetes can lead to a lot of serious complication, as my colleague Nidal talked about, which like stroke, kidney failure, blindness, and nerve damage. We call these microvascular and macrovascular complications. And the management should start by a lifestyle management before starting the medications. It's not just about taking medication, it's also about taking healthier choices in life like diet, exercise, stress management, and more. We'll talk about these things in details. So for the types, we have three main types like type 1, type 2, and gestational diabetes, but we also have a condition called prediabetes, which can develop before the onset of actual diabetes. I forgot to tell you, if you have any questions, you can ask me while I'm presenting. I can answer you directly if you have any questions. So type 1 diabetes is an autoimmune disease. Um, it's a disease where the immune system attack the pancreatic cells, which we call the beta cells. The beta cells are the cells in the pancreas that are responsible for producing insulin. But in this condition, we have antibodies attacking these cells, so they will be destroyed. So we will not have insulin. And this disease will occur very early in life, in childhood or adolescence, but it also can occur at an older age. But it's more frequent in pediatric patients. And as we said, it's due to absence of insulin because the cells are producing insulin are destroyed. In this case, for sure, we need lifestyle modification, but in this case, we need to start insulin at diagnosis because the patient doesn't have insulin. So we need to give them insulin in the beginning. We can't wait to give insulin. It's very important to start him on insulin at the beginning. In contrast, type 2 diabetes, usually it's a disease occurring at older ages, but we're now seeing it more commonly in young ages. And that is due to the increasing rates of obesity in the population. And obesity is mainly linked to diabetes. So here we have insulin, we have the cells producing insulin, they are not destroyed, but our body is not using this insulin correctly. And we have resistance to insulin. So we have the insulin, but the cells are not able to use insulin, and that's what we call insulin resistance. It's the main mechanism of developing type 2 diabetes. Here, we should focus on lifestyle modification first. We should do aggressive lifestyle modification. Then, if lifestyle modification doesn't work, we can, in that case, shift to oral medications and in later stages, insulin therapy. So we don't start insulin and medications initially. We can wait and see if the patient will respond to lifestyle modification. And if the patient doesn't respond, in that case, we can start medications and insulin. A third type is called gestational diabetes. It's a bit similar to type 2 diabetes, but it will happen during pregnancy. So the body can't produce enough insulin to meet the increased needs. In pregnancy, when you have increased needs of hormones, and the body is not able to produce such insulin. And it will resolve mainly in most cases after childbirth. But women that develop gestational diabetes are at risk of developing type 2 diabetes later in life. And also the baby is at risk of developing complications related to hyperglycemia in his mother. Prediabetes is the initial stage. We need to work on detecting diabetes at this stage. It's a condition which blood sugar level are higher than normal but are not yet in the diabetes range. So we have hyperglycemia, but it's a mild hyperglycemia. I will show you on another slide the range of hyperglycemia and how to diagnose diabetes. Glucose should be above which threshold. But here you should know that in pre-diabetes, the glucose level is a bit high, but not in the diabetes range. And we should really focus here on prevention because at this stage we can slow down the disease. Maybe we're not sure if we can prevent it, but we can really slow it down for years before developing type 2 diabetes if we do aggressive lifestyle modification at this stage. So here is a summary, the three types of diabetes, as I told you, type 1, type 2, and gestational. Usually type 1 occurs in young, type 2 will occur in older, and gestational will occur during pregnancy. Usually patients with type 1 are not overweight. They can have normal weight, while type 2 patients are usually overweight. And in type 1, we said that the body is not able to produce insulin because the cells are destroyed the pancreatic cells are destroyed. While in type 2, we have production of insulin, but we have resistance to insulin. The cells are not able to use insulin properly. Same happens in gestational diabetes. By the way, it's close to type 2 diabetes. Type 1 is rare, but we're seeing it increasing in incidence these years. And type 2 is a lot more common. It's most common type of diabetes. Type 1, as we said, requires insulin at the beginning, while type 2 require diet and lifestyle changes first. Then, after that stage, we can use oral medications and insulin. And usually, it has a family history. It can be transmitted to generations. So now I will talk about how to diagnose diabetes. So we have different scales. No diabetes is when we have the fasting blood sugar. We need to make sure the patient is fasting. We need to measure the blood sugar um, before meals. If the blood sugar is less than 100 milligram per deciliter, in this case we don't have diabetes. But if the fasting sugar is between 100 and 125 milligram per deciliter, in that case we call it pre-diabetes. Here we should act, as we said, on lifestyle modification to prevent the transition to diabetes, which is defined by having a fasting blood sugar above 126 milligram per deciliter. So it's very important to know these numbers because it's very easy to diagnose it. We just need to do a blood test or measure the fasting blood sugar. Another way to diagnose diabetes is by measuring the A1C level. So A1C is the hemoglobin A1C level. It gives us an idea about the range of glycemia and or glucose level in the past 3 months. So when we find a value of less than 5.6, this is a normal case. When we find a value of 5.7 to 6.4, this is pre-diabetes. We should act here. And when we find a value above 6.5, in that case, we have established a diabetes. And usually these stages are hard to reverse, but we can slow the progression and avoid complications. Lifestyle is very important, as I told you, and diet is the main focus in lifestyle. We need to have a balanced diet and balancing blood sugar because carbohydrate in particular will have significant impact on sugar level because carbohydrates are sugar. So, and diabetes is hyperglycemia, so high sugar level. So we need to learn how to manage carbohydrate intake and teach our patients how to manage carbohydrate intake in daily basis. We need to encourage them to replace some of their diet by a diet rich in whole grain and proteins, healthy fats, and fruits and vegetables. And they should avoid other types of food that we will discuss in a different slide. Physical exercise is also important because you know that regular physical exercise will improve insulin sensitivity, so will improve the insulin resistance that we talked about. The body will be able to use insulin in a better way. And in this case, this will lead to a drop in blood sugar level. We should aim to do 150 minutes of moderate to intensity exercise or 75 minutes of low intensity aerobic exercise, of high intensity aerobic exercise per week. So a lot of time our patients will ask us how many days should I exercise a week or how many hours a week. So we can advise them to do like 150 minutes of moderate intensity exercise because you know diabetes patients are usually old patients, so it's not always easy to do vigorous intensity exercise. So we can recommend to do moderate intensity exercise like walking or running or swimming, different type of exercise. It's helpful. Type 2 diabetes is a systemic disease, as we said. Can cause cardiac dysfunction, can cause muscular dysfunction, it can cause vascular dysfunction, so our vessels will be stiff. This will also, the combination of these factors, the cardiac dysfunction, the stiff vessels, the muscle dysfunction, will lead to a decrease in exercise capacity. So, as I told you, it's not always feasible for advanced diabetes patient to exercise. They will be less fit to do exercise because of all these associated condition of diabetes. And at the end, it's a disease that can lead to mortality and morbidity. Why some patients have a barrier to exercise? Not all patients are able to exercise because, a diabetes patient has decreased fitness and are usually overweight patients. So this is really a big limitation to exercise. They are not fit cardiovascularly, so their heart is not able to adapt to increase in demand during exercise. They are always stressed, and stress can lead to cardiovascular events. Usually, as we said in the previous talks, they can have a complication which is nephropathy, so we have kidney damage. So when we develop nephropathy, usually it will lead to anemia because we will have decreased production of erythropoietin, which is a hormone responsible for producing red blood cells and hemoglobin. So we'll have anemia, and anemia will lead to decreased oxygen perfusion. So less oxygen will reach the muscles. So these patients will be less fit to exercise. Also, neuropathy, which will lead to pain and loss of balance, loss of vision, and retinopathy. We'll also have foot disease like peripheral artery disease. All of these conditions will lead to barrier to exercise. So it's not easy to ask them to exercise. Also, these patients will be, most of them will be have a bit of anxiety or depression, as they will be in distress. Some of them have low socioeconomic status, so they are unable to implement all these lifestyle modification tools that we can offer them. So this is a really nice study done to show that exercise is okay. Yes, راح كبر السكرين. Is it better now? عم بتشوفوا أحسن هلأ؟ Okay, good. So this is a really nice study which was done to show the benefits of doing exercise. And if you can see, the black line is it's in patients that doesn't exercise, and the blue curve is for the patients that exercise. And you can see that patients that exercise they have increase in glucose uptake by cells. So when we have glucose uptake, the glucose will drop in the circulation. So we will drop our glucose level. And this was proven in the study in patients that do exercise, they tend to have lower level of glucose. And it's very interesting. I have put this study here. You can see the title. If someone is interested to read it, you can check it. It's uh, it's published on PubMed. Sorry. So, what are the types of physical activities that we should ask our patient to do? We should ask him to do aerobic exercise like brisk walking, swimming, cycling, dancing, if possible, weightlifting, body weight, also advisable if the patient is able to. So we have different variety of exercise that we can offer depend on our patient condition. Stress management is very, very important. We said that stress and depression can lead to uncontrolled diabetes. True. I have a question. لكن لا نستطيع القول أن التمارين الرياضية دائما هي الحل الأفضل. True. It's not just about تمارين رياضية. هي combination of عدة أشياء of different things. One of them is التمارين الرياضية and exercise. Not just this, I'm sure. I will show you on different slide how much like exercise will affect the blood pressure, for example. We'll discuss that. But you're right. It's a combination of things, not just الرياضة. So stress management is very important too. We should advise our patient to seek help if he's very stressed or depressed. See a psychologist or a psychiatrist. Can do meditation, deep breathing exercises, and other hobbies that can help him decrease the stress level. Here is a nice study that proved it. I will also show you studies to prove what I'm saying. here is a study that studied patients with depression, anxiety, and stress. And in this study, you can see that with the increased rate of depression or increase in level of anxiety and stress, you can see an increase in hemoglobin A1C level. It's a linear curve that goes up with the depression, with the level of depression, with the level of anxiety, and with the level of stress. It was published in 2019. You can also check it out. Sleep is also very important. So we said exercise, we said diet, we said stress management. We also should focus on sleep. We should advise our patient to sleep between 7 to 9 hours of sleep each day. And we should advise them to have a regular sleep schedule and have a good sleep environment without noise and limit screen time before bedtime to improve our sleep quality. Here is a study that showed that a lot of patients, around 35 or 40% of diabetes, sleep less than 7 hours. So we said the recommendation is to sleep between 7 and 9 hours. Around 50% of patients will sleep between this range, but um, but around 40% of patients will have less than 7 hours of sleep. And in these patients, the study showed that they usually tend to have difficulty controlling their blood sugar level. Poor sleep is also linked to obesity, and obesity is linked to behavioral changes. They will eat more, they will be more stressed. Behavioral changes also will have physiologic changes like disturbance in insulin levels, in insulin resistance, and all of this will lead to diabetes. So it's mainly linked to obesity and physiologic and behavioral changes. The emphasis is the poor sleep quality. Carbohydrate counting is also important. In addition to all the things we said, we should teach our patient to recognize different sources of carbs, including grains, fruits, vegetables, and sweets. We should advise our patient to do portion control to manage carbohydrate intake. Yes, it's linked to cortisol and insulin resistant for sure. Insulin resistant is a main issue in type 2 diabetes, and we have it's the main cause. So all of these conditions will favor insulin resistant, and that will lead to type 2 diabetes in patients that have the predisposition for sure. So if you can see in the study too, they try to see how many patients are do carbohydrate counting, and they know what they are eating. So around 70% are well educated and they are adherent to carbohydrate counting. They count the calories. They know how much carbohydrates they are eating. But around 30% of patients uh, are not adherent to carbohydrate counting, which is a big number to be honest. So, and you can see here this study to the same study. They try to see the hemoglobin A1C level in patients that are doing carbohydrate counting and hemoglobin A1C level in patients that are not doing carbohydrate counting. For patients that are doing carbohydrate counting, you can see the green circles in the graph, and you can see that as a patient with carbohydrate counting tend to have more controlled and lower hemoglobin A1C levels. While patients that are not adherent to carbohydrate counting, you can see blue circles. These patients tend to have higher and uncontrolled hemoglobin A1C levels, as you can see here on this slide. Also, fiber is very important to stabilize blood sugar level. It will slow the absorption of glucose. So we need to encourage them to increase their fiber. Fiber can be found in grains, in legumes and fruits and vegetables. So you should always encourage your patient to increase their vegetable consumption because consuming more vegetables and dietary fiber and grains was associated with lower mortality in diabetes patients. You can see here in this study that studied the dietary fiber and whole grains in diabetes management. It showed that by numbers and by statistics that these patients tend to have a lower rate of mortality compared to patients that does not follow this diet regimen. As we said, sugar, we should limit sugar and sweeteners because adding sugar will increase your glucose level, and sugar can be found in sugary drinks like juices, candies, and desserts. Also, artificial sweeteners. Some people add artificial sweeteners. Also, these things can be rich in glucose, so they will cause the patient to have hyperglycemia too. This is an example of how portion should be. So we should have food rich in proteins, food rich in vegetables. So we should be rich in fibers, and some carbohydrate food that are also essential. So we have carbohydrate present in fruits, in potatoes, and whole grains, in milk. But we should avoid the carbohydrate that we find in juices and artificial sweeteners, as we said. Yes, Dina, do you have a question? Okay. So we should focus on the consistency of eating. Patient should really have a diet plan. If it's not possible, we should advise them to see a dietitian to help them organize their meal plans. Yeah. Yes, Dina, for sure. You need always read the label of the artificial sweetener because some of them tend to have more level of sugars than others. So it depends on the brand too. So food label, as we said, a patient should read the food label, should know how much protein he's taking, how much sugar he's taking, how much fat he's taking. We can also have hidden sugars that are not mentioned on the description, especially in processed food. You're welcome, Dina. So we'll continue. Now we talked about the lifestyle changes and how we can avoid or delay the progression of diabetes. But if all of these conditions that we talked about, the exercise, the stress management, the sleep, the diet, have failed, we should now move to give the patient medications. So we have different types of medications. The most commonly medication used is metformin. I'm sure most of you have heard about this medication. So this medication will act by increased insulin sensitivity. Um, it will not help increasing the insulin level, but it will cause insulin, it will cause a better response of our cells to insulin that is already present. But it can cause side effects like nausea, vomiting, diarrhea, vitamin D deficiency, and lactic acidosis, which is really rare. And we should be careful when giving it in patients with chronic kidney disease, heart disease, and liver disease. Another medication that is now commonly used, we're really using it more and more. It's SGLT2 inhibitors. We use these medications especially with patients that have cardiac disease and heart failure because it has showed that this medication will decrease mortality in cardiac patients that have heart failure. So one of the medication is called dapagliflozin. We have other names like empagliflozin, but the dapagliflozin is the most commonly used. It comes with a 10 milligram dose. How does this medication act? It will act by decreased glucose reabsorption. So it has nothing to do with insulin. It doesn't increase insulin. It doesn't help increase insulin sensitivity, but this medication will cause decreased reabsorption of glucose from the kidney and will have increased glucose excretion in the urine. So usually kidneys will absorb part of the glucose that is secreted in the urine, but this medication will block this receptor and will help eliminate the glucose in the urine. So in that case, it can lead to urinary tract infection because bacteria will love glucose. So when you have more glucose in urine, this will increase the risk of UTI or urinary tract infection. This is the most common side effect of this medication, and we should avoid it in patients that have significant renal impairment. Other drugs that we use also is sulfonylureas. These drugs you should be careful because they can stimulate insulin secretion, so they can increase the insulin secretion, but you should avoid them in patients that are very old because it can cause hypoglycemia. So this is one of the medications that can cause hypoglycemia. All the other medication will not cause hypoglycemia, but will just drop the glucose level, but will not cause hypoglycemia or low glucose level. But this medication should be used carefully in old patients because of the risk of developing hypoglycemia. And you know, hypoglycemia in old patients is associated with risk of falls and other complications. So we should avoid it in these patients. So let's say now we tried lifestyle modification, we tried medications, a combination of medication. We gave them two of these medication, and the glucose level is still uncontrolled. What to do now? So in that case, we should try to give the patient insulin. We have different types of insulin. We have the rapid-acting insulin. We have the long-acting insulin. These are the most commonly used types of insulin in hospitals. So the rapid-acting insulin, we usually give them before meals or after meals, depends on the glucose level. We have a sliding scale, we call it. So if the glucose level, if it's 250, the protocol will tell the nurse to give the patient, for example, 6 units or 8 units, or depends on the protocol that was prescribed. We also have long-acting insulin, such as insulin Levemir or Lantus. So these types of insulin will act for 24 hours. They will not do peaks, so they will always be present in the body in a constant level, but they will peak at a later stage. So rapid-acting insulin will have the peak effect to drop the glucose in 15 minutes, while the long-acting insulin will have the peak in 1 hour. Not the peak, but will start to act in 1 hour, and it will stay constant for 24 hours. Some people are raising hands. If you have any questions, please write them in the chat. I will answer you. Okay. So I will not talk a lot about the complication because my colleague already mentioned a few of them, but you should know that we have microvascular and microvascular complication, and microvascular complication includes stroke, heart disease, hypertension, peripheral vascular disease, and foot problems. While microvascular affecting the small vessels will affect the eye, so will cause retinopathy, will affect the small vessels in the kidneys, will cause nephropathy, and will cause also the neuropathy, so the decreased sensation in the foot, which can lead to diabetes foot and a lot of problems affecting the extremities. So it's very important to prevent this complication, mainly the heart disease, because the heart disease are associated with mortality, and we already said that diabetes is associated with mortality. And also kidney disease, because chronic kidney disease is a complication of diabetes. As you said, can have nephropathy. So we should be careful. Also, eye problem, we should send the patient to have regular ophthalmologic follow-ups to avoid retinopathy and other complications. Neuropathy also to lead to nerve damage. The patient will have numbness. The patient will have tingling and pain in the extremities. So a lot of time you hear patient asking you that they have pain in the extremities and they have numbness or tingling. Some of them are not diabetic. So the first question you should ask them is, did you measure your blood sugar level recently? Yes or no? Because you can diagnose diabetes in a lot of patients because diabetes is almost um, always silent disease, especially in the beginning. So the patient will not have warning signs. If he doesn't do blood tests, he will never know that he have diabetes. We should not wait to have the complication to diagnose diabetes. We should try to diagnose it earlier on. Here is an example of a patient I did. You can see this is a coronary heart vessel. The patient is the right coronary artery. So we have the arteries that give blood supply to the heart. And this artery was blocked by in a patient that have very advanced diabetes, you can see that there was a very severe narrowing of 99% of the lumen of the artery. The blood is not passing. And we repaired the artery by putting a stent in his vessel, and we treated him well. So this is one of the complication of diabetes, which is heart problems. A lot of patients can have coronary artery disease. You can see that their vessels can be blocked due to diabetes. Any questions about diabetes before I move to hypertension? If you have questions, please let me know. Yes, Nawal, do you have a question? So Nawal is asking me ما هو التحليل الأدق للتفريق بين سكر 1 أو سكر 2. Uh, you can ask for insulin level for this patient. In type 1 diabetes, they will have very, very low insulin level, but usually it's a clinical diagnosis. So you find type 1 more in pediatric patients, and they tend to present in acute setting, while type 2 diabetes are more like a chronic hyperglycemia. And type 1 also can lead to very severe acidosis. So sometimes patients present to the ER as a first presentation of with severe metabolic acidosis. So they can be in a very, very bad condition. So if I want to answer you, I can say it's more like a clinical diagnosis, but we have more and more tests being developed, like to measure antibodies or to measure insulin level, which can also help. Yes, I agree with you. Someone is asking me, is foot tangling? We should investigate diabetes. Yes, I agree. It's very common, and we should always ask for a blood sugar level when we have patient with lower limb tingling. دينا is asking me شو بنصح المرضى السكر يستخدمون بدل السكر العادي للتحلية. فيك تستعملي artificial sweeteners, but you need to be careful of these sweeteners because some of them can include also some sugar. So you always need to look at the brand and read the label. But there are a lot of good products that you can find for that. Neuropathy can be cured. Neuropathy, usually when it happened, it's a very advanced stage. It can be slowed down uh, by uh, by doing a lot of interventions, but cured it depends on the stage. But I don't think it can be cured. But you can slow it down and help avoid its progression. Nawal asking me about سكر stevia. ما بعرفه نوال. I'm sorry. I don't know this product. I will check it out, but I don't know it. We don't have it here where I live. عبد الرحمن asking me هل ممكن السكر التراكمي إذا كان مرتفع جدا لحد مثلا 10 مع استعمال الأدوية يرجع طبيعي. So السكر التراكمي is hemoglobin A1C. عم تسألني إذا كان هالقد elevated إذا في يرجع طبيعي. يس في يرجع طبيعي إذا بتستعمل aggressive lifestyle modification. إذا بتستعمل medication you have need to use combination medications مش بس دواء واحد كذا دواء and insulin. You can drop it significantly, especially if the patient who adherent على lifestyle modification اللي عم تعطيهم وكل شيء. You can drop it a lot, but usually when it's very that advanced, uh, you cannot reverse diabetes and cure it. Diabetes is not a curable disease. You can slow it down, بس ما فيك ما عنا بعد ال possibility إنه نصح من diabetes. It's a chronic condition. Yes, we have some research about stem cells to cure diabetes because, as I told you, stem cell will help regenerate cells, and especially in patients with type 1 diabetes, they have destruction of beta cells. So stem cells will help regenerate these cells, but it's very early on in the development, and we still don't have a lot of data on that. Yes, Nawal. Yes, Nawal. It's good to use it, but it will not drop the glucose significantly. Other tools like exercise or medication will drop the glucose more. But it's better to have a healthy lifestyle as a combination. So diet, exercise, and everything combined. Sorry if I missed few questions. I'm reading the chat, but I think I answered most of your questions. Any more questions before moving to hypertension? Okay, no more questions. You're welcome, Nawal and Abdurrahman and everyone. Okay, you're welcome. راح نكمل. Now I will talk about hypertension. So we will keep the same we will keep the same flow. So if you have any questions, you can ask me. I still have one question. Is it leg moving exercise will reduce more sugar? Are you advised to this point? So as I showed you a study, so studies that in patients that exercise, so any type of exercise, but especially cycling or walking or swimming or running, these type of exercise, which are called cardio exercise, have showed to increase glucose absorption by cells, so drop the circulating glucose in the circulation. So this type of exercise will tend to drop the glucose the most. So I will move to hypertension, which is also a very common disease along with diabetes. It's almost always associated also with diabetes. So the new guidelines about hypertension now we consider if patient having normal blood pressure is when they have a systolic blood pressure of less than 120 and a diastolic pressure of less than 80. Any patient that have a blood pressure between 120 and 129 systolic is called to have elevated blood pressure. We're not yet in the stage of hypertension, but we're in a stage of elevated blood pressure, and we should act here really to avoid the progression. Because if we act here, we can avoid the progression to hypertension stage 1. But if we reach stage 1 or stage 2, it will be very difficult to revert it. But when the blood pressure, mainly the systolic blood pressure, goes above 130, so 130 to 139, or diastolic blood pressure between 80 to 89, in that case we call it stage 1 hypertension. And when the blood pressure goes above 140 or equal to 140 systolic or above 90 diastolic, that case we call stage 2 hypertension, and this is an advanced stage disease. So I'm sure most of you didn't know that, and everyone gets surprised when I tell them that when you have a blood pressure of 125 systolic, this is called elevated blood pressure. So it's very important to detect these patients and implement lifestyle modification at the stage of elevated blood pressure, not at the stage of stage 1 hypertension. If you can see here as numbers, you can see that hypertension can occur at all ages. Even patients that are between 18 to 29 can have hypertension or elevated blood pressure. And in young patients, hypertension is more common in males. So you can see that in patients that have hypertension between 18 to 29, 20% are males, while so we have males more than females in young patients. But as we increase in age, uh, the female hormone will drop and they will be less protective against hypertension, and they will have an equal number of hypertension between males and females. when we are above 45. So mainly when we are post-menopause or near menopause, the hypertension percentage will rise in females and will be equal to males. It can also affect all races, so it can affect white, black, Asian, Hispanic, and others, but it's more common in black patients. We know that black patients have higher prevalence of hypertension, especially African Americans, because these studies are mostly done in African Americans. So it's 56% of them, more than other races. It's very important to measure blood pressure in a correct way. So if we're measuring the blood pressure in the office, so either the doctor or the nurse are measuring the blood pressure. So we should make sure that the patient have avoided caffeine, exercise, and smoking for the last 30 minutes before measurement. He should be avoiding these things before we measure his blood pressure. We should use a validated blood pressure machine. You can check this website. I put it the website. It's called validatebp.org. It has the list of all blood pressure machines, brands, and you can check if the machine you're using is validated, yes or no, because a lot of machines that I see in daily practice are not validated. You should use the correct size of the cuff for a patient, not the same cuff to be used for all patients, because some patients have wider arms compared to other patients, so you should not use the same cuff size to everyone. The patient arm should be placed on a table at heart level. So the patient should always be sitting, having his arm on a table, and his arm should be on near his heart level. The patient should be relaxed, as we said, sitting in a chair for more than 5 minutes. We should not measure his blood pressure if he was walking 1 minute before the measure. Neither the patient or the clinician should talk during the measurement. The room should be quiet, no talking during the measurement, and it should be taken in a temperature-controlled room. We should take not just one measure, we should take two or more measures separated by 1 minute each, and we should do the average. So let's say we measure 230, 140, and 150. We need to do the average, and the average will be the actual blood pressure of the patient. And when we diagnose hypertension, in that case, we need to do blood tests because you know that hypertension can affect different parts of the body. So we need to check the complete blood count, we need to check the electrolytes, we need to check the creatinine because hypertension can lead to nephropathy like diabetes. We need to check lipid profile, screen for hyperlipidemia. You need to check for diabetes by measuring fasting blood sugar and hemoglobin A1C. We need to check thyroid stimulating hormone because hyperthyroidism can sometimes cause hypertension. Urine analysis, urine albumin to creatinine ratio. Urine albumin to creatinine ratio is very important and should be measured in all patients with hypertension because it will give us an idea if the hypertension is affecting the kidneys, yes or no. Because if we find that the hypertension is affecting the kidney, we can give them medications to decrease the proteinuria that is being filtered by the kidney. We can also ask the patient to do home blood pressure measurement. So home blood pressure measurement also, we should ask the patient to check if the machine is validated, to go to this website and check if this machine that the patient is using is validated. Avoid smoking, avoid caffeine, avoid exercise 30 minutes before the measurement. Same thing, he should place his arm on the table near heart level. He should be relaxed, not doing exercise, not doing anything else, not watching TV, not using his phone. And we should tell the patient to do two measurements. So we should do a measurement in the morning and do measurements at night. And we should advise him to do these measurements for at least 3 days, so between 3 to 7 days. Do the measurement, and we ask him to put this measurement on a paper and write the measurements in the morning and at night for 7 consecutive days. And after that, to come back to us in the office to check for his blood pressure. It's a very easy tool to use. Patient can do this at home. No need to go do the measurement at the office. He can do it at home. A lot of machines are not good machines to measure blood pressure. So this machine should be avoided. We call this machine culpless blood pressure devices. We should avoid them because they are very inaccurate and we should not use them in most cases. Some of them are now being developed to be culpless, but you always need to check the website that I gave you to see if the device is good or not. What are the dietary factors that can increase hypertension? So we call these environmental factor, like higher sodium intake. So when we increase sodium, like salt, when you add a lot of salt to our diet, this will cause elevation of our blood pressure. Lower potassium intake. So potassium can be found in bananas and other fruits. So it will also lead to high blood pressure. So we should ask our patient to increase his potassium intake. Low calcium, low magnesium, also low diet intake in fruit, vegetables, proteins, fiber will also lead to increase in hypertension. Also, alcohol intake should be avoided because it will also lead to development of hypertension. We have other factors like genetic factors which are non-modifiable. Some patients have the hypertension at a very young age. These are genetic factors that we can't modify them. Overweight, obesity, these are modifiable factor but non-dietary. Lower physical exercise, also a modifiable risk factor. We should advise our patient to do more exercise. Sleep disturbance, like in diabetes, we should ask them to sleep between 7 to 9 hours. Psychological stressors also, and air pollution. All of these things are non-dietary risk factor to assess hypertension. Nuzhat is saying that screen is not coming. Anyone else having this problem? Are you able to see my screen? Please say yes if you're able to see my screen. واضح. Nuzhat, I'm not sure what is the problem. Maybe try to restart the application because others are able to see my screen. Okay? Okay, so now let's say that the patient came to the office and we measured blood pressure in the office, and the patient also measured his blood pressure at home. Some conditions we can have normal blood pressure in the office and high blood pressure at home, or the opposite. We'll talk about them. But let's say the patient have normal blood pressure at home and in the office. In this case, we can confirm normotension. So we can confirm that the patient have sustained normotension. He doesn't have hypertension. But when the blood pressure is high in the office and at home, this is called sustained hypertension. So we confirm the diagnosis, we can start lifestyle modification, and we can start medications. Masked hypertension is a condition where the blood pressure is low in the office. So when the patient comes to the doctor, he's relaxed. He likes the doctor. So the blood pressure will be low. But at home, he will think a lot about his condition and the blood pressure will go up. So that case is called masked hypertension. It's not very common. While the white coat hypertension is associated with high blood pressure in the office, so when the patient comes to the office to do the measure, the blood pressure is always high. But when we ask him to measure the blood pressure at home, it's normal. So this is called white coat hypertension. It's not very dangerous, but it can lead to sustained hypertension later on. Okay. So let's say we diagnose a patient, especially a young patient with hypertension. Sometimes we need to check if the patient have a secondary cause of hypertension. So it's not essential hypertension. Sometimes a hormone can cause it, an elevation of a hormone can cause it, like primary aldosteronism. So aldosterone is a hormone secreted by the adrenal gland, which will lead to hypertension if the patient have a tumor in his adrenal secreting aldosterone. So when to suspect it? So if you have the resistant hypertension or induced hypertension, so a hypertension that it's very hard to treat, even if we're giving him combination of medications, we need to suspect it. One of the most common clues to see when we have hypertension and hypokalemia. So when we see hypokalemia with hypertension, we always need to suspect primary aldosteronism. And in that case, you need to refer the patient to do the screening and send him to an endocrinologist in order to do the proper tests. And if we don't find hyperaldosteronism, we need to continue as a medication therapy like we treat normal cases of hypertension. So we always need to look when a patient is very young with hypertension and a patient that have resistant hypertension or a patient with hypertension and hypokalemia, because hypokalemia can be due to hyperaldosteronism. So if you have a lot of aldosterone, aldosterone will eliminate your potassium in the urine and will cause absorption of sodium. And when we absorb sodium, will increase our hypertension because sodium is salt. So remember this, resistant hypertension, onset before 30 years of age, and hypokalemia. Always look for primary aldosteronism and send the patient to a specialist. Other things that can contribute to hypertension, which is alcohol, we should avoid alcohol. Caffeine, we should ask the patient with hypertension to limit caffeine to less than 300 milligram per day and avoid more than 1 cup daily in patients with uncontrolled hypertension. So numbers are important, less than 300 milligram per day. Some patients use decongestion because they have blocked nose or have allergies, so they use decongestion. Decongestion can cause hypertension, so we need to replace them with like inhaled corticosteroids or antihistamines. These medications tend to cause less hypertension compared to decongestion like phenylephrine. Some herbs are not good. We should always check for what herb the patient is getting. NSAIDs, which are anti-inflammatory drugs that we take for pain, we should not take them for a long period of time. And we should not exceed 4 grams per day, because exceeding 4 grams per day is considered a very high dose. And we should try to use other analgesics like topical creams or like paracetamol instead of using NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. Some medication used for psychiatry, like antipsychotics and antidepressants, can cause high blood pressure. Cyclosporin that we use for immunosuppression, and also something we commonly use, especially in females, which are oral contraceptives or oral contraceptives. These are associated with higher blood pressure. And if a female is taking oral contraceptive, and with hypertension, we should switch her to other form of contraception, like using progestin only form of contraception instead of using a combination of contraception. So we have different alternative. It's not the focus of our talk, but you should know that. Also, corticosteroids are very commonly associated with high blood pressure. A very common condition associated with blood pressure is obstructive sleep apnea. So, the patient that snores at night, these patients have obstructive sleep apnea. They do apnea events at night. These patients have increased risk of developing hypertension because these patients have endothelial dysfunction in their vessels. They have increase in arterial stiffness. So we should use CPAP, which is a machine we put to give positive pressure to our patient to open their airways at night. And CPAP was shown to be able to delay the onset of medications to treat hypertension if the cause was obstructive sleep apnea. So using the CPAP will drop the high blood pressure. So sleep apnea, as we said, can cause obesity, type 2 diabetes, chronic kidney disease, acute coronary vascular disease. So it's a systemic condition which can lead to hypertension and diabetes too. What is the lifestyle modifications that we should ask our patient to do? The weight loss of more than 5% if the patient is overweight or obese. He should follow a DASH diet. I'll show you the DASH diet later on. He should limit his sodium intake to less than 1,500 milligram a day, so 1.5 gram a day. Limit alcohol, increase potassium, so eat in diet rich in potassium, like some fruits, and do exercise. Like aerobic exercise, like walking, cardio exercise, cycling, and swimming. So this slide is very, very important because I will prove to you that exercise can lead to decrease in blood pressure in patients with hypertension. If you can see weight loss alone, if we reduce weight by 50% in a patient we will drop his systolic blood pressure by 6 to 8 millimeter mercury. So it's a significant drop because when you combine it, for example, to diet, which gives you a reduction of 5 to 8, if you combine weight loss and a good diet, this will give you like between 10 to 16 millimeter mercury drop in systolic blood pressure, which is very significant. Add to it like reducing sodium to less than 1,500 milligram per day will also drop it between 6 to 8. You can see that each measure that we do will cause a drop in blood pressure. And if we combine all of these measures, we can avoid using the medication, especially when the disease is very on and very early on its course. So acting early by doing all of these measures will help us avoid the use of medication until a later stage. So let's say now we said the patient is diagnosed by hypertension, but what level we should start giving them a medication? So any patient coming to the office with a diagnosed hypertension and having a blood pressure above 140 systolic and 90 diastolic, these patients should be put on antihypertensive medications. Everyone should be put, especially if the lifestyle modification failed. So we should put them on lifestyle modification. But some patients need to be put on medication before reaching the 140 threshold, especially patients that have congenital congestive heart disease, stroke, heart failure patients. These patients should be treated when the blood pressure is above 130 systolic and 180 diastolic. Same applies to patients with chronic kidney disease. These patients should be treated when the blood pressure goes above 160 systolic and above 80 diastolic. So everyone should be treated when the blood pressure is above 140 systolic, but patients with heart failure and chronic kidney disease and stroke should be treated when the blood pressure is above or equal to 130 millimeter mercury systolic. So these are very important numbers because it will help us know which patient to treat. And let's say any other patient that have a blood pressure above 130 but less than 140. In these patients, we can try lifestyle modification for 3 to 6 months and then ask the patient to come back at us in the office and do the measurements. If the blood pressure drops, okay, we don't give medication. But if the blood pressure remains above 130 systolic, in that case, we should start them on medications. So just remember these two numbers, 140, 130, and anyone with 140 should be treated, but patients with 130 should be treated if they have heart failure, stroke, chronic kidney disease, or if they have 130 systolic, but we did lifestyle modification for 6 months, but the blood pressure remained above 130. In that case, we should give them medications too. What kind of medication should we give? We have three first-line medications, which are the ACE inhibitor, the angiotensin receptor blockers, the diuretics, and the calcium channel blockers. These are the first-line medications. Beta blockers is no longer a first-line medication to give for hypertension because beta blocker acts more by dropping the heart rate, but it has a modest effect on blood pressure. It can drop blood pressure, but less than other drugs. And it's also advised for patients that have a blood pressure above 140 systolic to use combination drugs. So not just one drug, to use two of these drugs that I already told you about, like using a calcium channel blocker and a diuretic, or calcium channel blocker or ACE inhibitor. So we need to combine drugs, not just using one drug. It's advisable to combine drugs because it has a better effect. And now we have like pills that contain one pill can contain two or three drugs at the same time. So this will facilitate patient compliance with the medication. The patient will not skip doses because one pill can contain uh, more than one drug. We're not going to details, but here is a list of the table of a medication, the brands, and the doses that you can use. You can choose any of these medications to treat your hypertension patients, especially the ACE inhibitor, ARBs, CCBs, and the diuretics as a first line. So let's say the patient, we gave him a medication, a combination of medication, and we ask him to come back at us in a few months. So let's say the blood pressure medication, we gave the medication, we will tell him to come back at us in 1 month, okay? If in 1 month the blood pressure goal is met, okay, we keep him on the same medication and we tell him to come back at us in 3 to 6 months. But if after 1 month after initiating the therapy, we see that the patient is still having uncontrolled blood pressure, in that case, we should tell the patient, we should see the patient again and intensify his treatment or add another treatment or a third medication and then tell him to come back at us 1 month later. So each time we add or we change a dose of a medication, we should ask the patient to come back at our office 1 month later. And if everything is okay and the blood pressure is well controlled, we should tell them to come back at us in 3 to 6 months later on to check if it's still controlled. Sometimes we have something called resistant hypertension when the blood pressure is always above 130 to 80 and we're unable to drop it below this threshold, despite giving the patient three antihypertensive, including a diuretic. So let's say we give him an ACE inhibitor and a CCB and a thiazide light diuretic, and the blood pressure remains above 160, 130 over 80. In that case, you always have to check the kidney function. If the patient has a good kidney function, you need to add a medication we call spironolactone, which is an MRA. It's a class of an MRA. Spironolactone is very effective. It can come with a dose of 12.5 milligram or 25 milligrams, and this will uh, if you add it to this triple therapy that we were giving, the three medication, we can add a fourth one, which is spironolactone. It will help. We can also use a beta blocker, which drops the heart rate, but it can also drop the blood pressure, as I told you. But if the patient have a low kidney function or a bad kidney function, you can't add spironolactone because spironolactone is bad for the kidneys. So you can add other medications like chlortalidone or beta blockers or any other type of centrally acting agents that can act on the brain to drop the blood pressure centrally. We have also tools, interventional tools that we can use. You can reach the femoral artery with a catheter and apply what we call radio frequency energy to ablate the nerves surrounding the renal artery. And this tool was found to be able to drop the blood pressure in patient, especially in patients that have resistant hypertension. So you advance a catheter by going in the femoral artery. You can go the femoral artery, you can go up in the aorta, and then you reach the renal artery, which is here, and you use a radio frequency energy to ablate the nerve surrounding the arteries. And this tool was found to help in dropping the blood pressure, especially in patients that are on 3 and 4 blood pressure medication and still unable to control their blood pressures. So last slide, I will talk about the emergency, hypertension emergency. So for those of you that have worked in emergency departments or seen patients in emergency departments, sometimes patient comes to us with very high blood pressure, like blood pressure above 180 systolic and above 120 diastolic. We call that hypertension urgency. And when it's associated with end organ damage like heart failure, acute coronary syndrome, pulmonary edema, or renal failure, or aortic dissection, we will call it hypertension emergency. So it's very important to know this number 180 over 120 when associated organ damage. We call it hypertension emergency. The patient should be admitted to the critical care unit, to the ICU. We should rule out always aortic dissection or pheochromocytoma. Pheochromocytoma is a tumor producing hormones which will increase the blood pressure significantly. If we find aortic dissection, we should use IV medication like nitroprusside to drop the blood pressure very fast, and we should aim to drop it less than 120 millimeter mercury fast, and then send the patient to surgery to repair his dissection. And if the patient does not have dissection or pheochromocytoma, we have time. We should not drop blood pressure very fast. We should drop blood pressure by 25% in the first hour to reach like 160 over 100. And then over the next 6 hours, uh, we can drop it furthermore and we come back to normal within 24 to 48 hours. So we don't have to be aggressive. But in case of aortic dissection, we need to be very aggressive and drop the blood pressure fast to decrease mortality. So that was my talk about hypertension. If you have any questions, please you can ask me now. No questions? You're welcome. You're welcome, everyone, for your comments. I have a question from Nuzhat. If a high blood pressure patient become a low blood pressure patient, what could be the cause? So yeah, it's very important. We can see this very frequently. Fatima, you're asking me. It's a very important question. Thank you for asking me this question. Usually, when the patient become hypotensive, it's because he's taking uh, a higher dose than what he should take. You should always check what dose the patient is taking. Sometimes you need to, if he's taking two or three drugs, you can remove one of the drugs and recontrol the blood pressure. It's the most common cause of hypotension and hypertension patient is the aggressive treatment of these patients, especially in old patients. Usually, when you have high potassium, you're not worried. You're worried when you have low potassium because, as I said, if you have low potassium, you're at risk of having a high aldosterone tumor secreting, which one can cause hyperaldosteronism and lead to hypertension. Oh, you're asking me if the patient is not taking blood pressure is he not hypertensive or not taking medication, why he's hypotensive? Um, how old is the patient and is he symptomatic or not? And how much is his blood pressure? Because as you know, a lot of patients, especially young female patients, tend to have low blood pressures, and they are always asymptomatic. They rarely have symptoms. Sometimes they can have symptoms when we call it vagal hypotension when they stand up a lot. Uh, it can be due to poor venous circulation, so blood will accumulate in the lower extremity and the blood pressure will drop. So in young females, you can see it a lot, hypotension. Yeah, you're asking about 67-year-old high blood pressure since 20 years now, since 1 year with blood pressure tablets, the blood pressure is low. For me, 105 over 66 is not a low blood pressure. It's a normal blood pressure for a hypertensive patient. He's very responsive to his treatment. If he's symptomatic, you need to stop the medication or decrease the dose. But 105 over 66 is not a high blood pressure. It's not a low blood pressure. Even if he's not taking medication, it's a normal blood pressure. It's not a low blood pressure for this patient. It's a very good blood pressure for him if he's asymptomatic. Okay, I will move now to the next lecture. Fatima, I will respond to your question in the end. I didn't understand it, but I'll try to respond to you after this presentation at the end, okay? I will give you a few minutes to questions. Can you see my slides and can you hear me? Please say yes in the comments if you can see the slides and you can hear me well. كلكم عم تسمعوني وعم بتشوفوا السلايدز؟ إذا إيه please write in the comments. Okay, perfect. رح نبلش بالtopic. We'll start talking about quality of life in chronic disease patients. Our first presentation was about diabetes. Our first two presentations were about hypertension and diabetes. And you know that hypertension and diabetes are chronic diseases that can lead to other chronic problems. So you can see here in this nice picture, you can see that each disease have different phases. So in the first stage of the disease, you can give treatment to modify the disease and slow it down. We call this stage disease modifying treatment. But at some stage, like in the case of cancer patient or severe heart failure patient, we reach a stage where a medication doesn't work anymore. In that condition, you need to implement palliative care or hospice care. So each disease can be classified in this figure. So disease modifying, palliative care, then hospice care. How do we define chronic diseases? So the chronic disease is a long-term medical conditions, progressive in nature. So if we diagnose it today, we know that it will progress later, especially when the patient will age. It will persist more than 3 months, are not preventable by vaccines, and are not curable by medications. You know, hypertension is not a disease that can be cured. It can be, the blood pressure can drop, but if you stop the medication, the disease will come back. So it's not, we don't have yet a curable treatment. Maybe in the future, we'll have a treatment that can cure the disease and stop it and cure it completely, like vaccines. But till now, we don't have this technology to stop the disease. They often require ongoing medical attention because the risk of progression, and they may limit activity of daily living, so they can affect our daily life. Some of the examples are cardiovascular diseases like heart failure, coronary artery diseases, which are very common, diabetes, cancer, chronic respiratory diseases like COPD or asthma. COPD is very common because smoking is very common, so a lot of smokers will be diagnosed by COPD one day in their life. Chronic kidney disease is also very common because it's associated with hypertension and diabetes, which are also very common. So for sure it will be very common too. So all of these are the most common chronic diseases. We also have the other types like inflammatory disease, rheumatologic diseases. All of these are chronic diseases. So diseases that are present more than 3 months and are not cured by a medication. They can be slowed down by a medication, but they can't be cured by medications. Some type of cancer, you will tell me, yes, they can be cured. Yes, true. Some type of cancer can be cured by immunotherapy or chemotherapy or surgery. Yes, I agree. But a lot of cancer till now, we don't have a specific treatment to say, yes, this treatment will cure this patient. So here is another figure show you another diseases like Alzheimer disease. Alzheimer disease will affect all the patients. They will have memory impairment, memory loss, arthritis, so inflammation of the joints. All of these are like rheumatoid arthritis or ankylosing spondylitis. All of these are rheumatologic diseases that are chronic diseases, can't be cured. Cancer, some type of cancer are chronic kidney disease, chronic liver disease, chronic respiratory disease, especially in smoker, as we said. Diabetes, it's not a curable disease. Heart disease, some like heart failure, when the myocardium or the heart cells dies, we have no way to regenerate them until now. Maybe in the future, someone asked me about stem cells. Maybe we'll be using stem cells, but till now we're not at this stage. Mental health disorder are also chronic disorders. Obesity, also is a disease because it's associated with various type of conditions, but we can slow it down and reverse it. So risk factor of having a chronic disease, you have age, family history, poor diet, lack of exercise, smoking, alcohol consumption, exposure to environmental toxin and pollution, chronic stress, lack of sleep. So you usually have a combination of these things, not just one factor. But some of these risk factors are modifiable and some are non-modifiable. For example, age is not a modifiable risk factor because when we age, we'll have more diseases. So age is not a modifiable risk factor. Family history is also genetic and is also a non-modifiable risk factor. While poor diet, lack of exercise, smoking, alcohol, stress, all of these things can be modified. So we can act on these things, but we can't act on age, we can't act on family history, we can't act on genetics. So, but lifestyle choices, we can act on them to improve the lifestyle of these patients that have chronic diseases. The chronic disease, according to the WHO, the World Health Organization, the World Health Organization said that the chronic diseases can cause mortality, and is the most common mortality and accounts for more than 70% of all global deaths each year. So we have like infections are not chronic diseases. So infections, car accidents, wars, all of these things can cause death, but the most majority of death is caused by non-communicable, so non-infectious chronic diseases. So it's very, very it's a major cause of human death, if you want. So this condition does not only increase healthcare costs, but also will decrease workforce productivity because when the patient is unable to work, have this chronic disease, he will not be able to work. So it will have also economical implication to the society, not just for the patient himself, because that the cost of cancer is expected to be nearly $174 billion by year 2030. And the direct and indirect cost of diabetes are expected to be around 312 billion each year. So we need to try to act before the progression of the disease. You can see here that around 30 million of Americans have diabetes and 84.1 million have prediabetes. And this will cause $237 billion cost each year and $90 billion in lost productivity if patient will not be able to work. Same for hypertension, 78 million Americans are diagnosed with hypertension, $131 billion dollar loss in productivity and 199 billion cost in healthcare costs. And it can lead to deaths. 859,000 will die from hypertension each year. It's a very common cause of death because it's associated with other conditions. So it's a very, very frequent chronic disease. Quality of life in these patients is very important because we're not just looking at survival, we're also looking at quality of life, which is the primary goal of managing chronic illness. And quality of life will focus on physical comfort, emotional well-being, social connectedness, and the ability to perform daily activity. So the quality of life is all of these things combined together. So, according to the WHO, quality of life is an individual perception of their position in life in the context of their culture and value system and in relation to their goals, expectation, standards, and concerns. So, it's a global thing that should be assessed in each patient that have a chronic disease. So, as I said, it can have a physical component, which we call physical well-being. So level of independence, energy, pain management, ability to perform daily activity. So it's very important for patient to feel independent and not always relying on someone else to help them in their daily activity. they should have energy and pain-free to be able to perform, to do their activities. So very important. Also for psychological well-being, mental health is very important, emotional balance, coping capacity, and life satisfaction. So we should always have a psychologist in the hospital to follow these patients, especially for patients that are hospitalized with cancer that stays in the hospital for like 1 month or 2 months. They should be closely followed by psychologists because um, this can really impact quality of life. Because when the patient accepts his condition and adapt to it, in that case, he will feel better. Even if the disease is almost always will lead to bad outcomes, but we can help the patient adapt to this condition. Social well-being is also important. Quality of relationships with the family, with the surrounding, social support, mainly by his family. So family life is very important in patients that have chronic diseases. The patient is always better to feel surrounded by someone he likes, by his family. This will help him improve and respond to treatment. Also, environmental well-being, so safety, financial stability, and access to resources and living condition. All of these factors are very important. So, as we said, all of these diseases have significant implication mainly on economy and on workforce productivity. So, a lot of these patients will be less productive, and the economy will lose a lot of value too. So, how to improve pain and fatigue in patients with chronic diseases? So, pain and fatigue, persistent pain is and fatigue are always persistent and often severe. So, they will have implication on physical and psychological well-being. It's very common in chronic conditions such as heart disease, diabetes, COPD. All of these diseases will lead to fatigue because patient is going in and out the hospital, is taking a lot of medication, is unable to exercise. So all of these conditions will lead to fatigue. It can also be not just the cause of the disease, but it also can be due to treatment of chronic diseases like chemotherapy, for example, or radiation therapy in certain cancers. So chemotherapy and radiation therapy will always lead to fatigue. If you ask all patients that are on chemotherapy, like maybe 90% of them will report fatigue at one stage of their treatment. So we need to act on managing pain by using some medications, so painkillers, physical therapy, and alternative therapies as well. We need to address pain and fatigue early on to prevent complication and improve overall outcomes. So we need to use tools like if a patient is unable to walk, we can give them canes or lifters, especially for patients that are bedridden. Uh, the patient will feel that he has loss of independence, and this will affect a lot of his psychological condition too. Sleep disturbance, like we said in the previous lectures, is also very important. So 7 to 9 hours of sleep. Uh, it can be due to pain, breathing difficulty, especially in patients with respiratory diseases. Frequent nighttime urination for patients with that are on diuretics to treat heart failure. They will go to to urinate a lot, or patients with prostate issues. So this will all also contribute to daytime fatigue and reduced concentration. Psychological impact is also very important. Depression, anxiety, uh, s- stress from disease management. So the patient will be on a list of 20 medication or more. So all of this will cause stress and anxiety. Uh, the patient will feel that he lost his prior lifestyle, so he's unable to work, unable to do exercise. He's in fear of the disease progression, and he's have a challenge of redefining his personal goals. So the patient will find that all his life will change all of a sudden, and he's helpless and unable to do anything about it. Reduce self-esteem, self-worth, especially in chemotherapy patients when they have hair loss, change in physical appearance. So all of this will lead to a decrease in self-confidence. Also, some patients will have cognitive effect, like chronic disease under treatment can affect memory, attention, decision making. So all of this will disturb quality of life. If you can see here, it's a very nice slide. So you can see that diabetes, hypertension, heart disease, dementia, all of these are chronic conditions. They are all associated with depression. And depression on its own can also lead to these diseases. So it's like a cycle. So the medical condition or the pathological issue will lead to depression. Then depression will make things worse and will increase diabetes or increase hypertension or increase heart disease or increase dementia. So it becomes like a cycle. And it's always a relation between all of these conditions. There is a relation. Same here as another study that showed that diabetes can lead to depression because diabetes can lead to stress, due to uncontrolled, for example, blood sugar. Patient will see that his blood sugar is always uncontrolled. It will be stressful. Some patients have tension with their doctors, fatigue, exhaustion, exercising. They are unable to exercise. All of this will lead to uh, different lifestyles. So the patient will be depressed. Depression will in turn cause change in appetite, suicidal thoughts, nervousness, anxiety, loss of energy. This will all will lead to a high level of cortisol and abnormal level of norepinephrine and serotonin. Patient will be eating more, exercising less, so we will have more diabetes. So as I told you, it's a cycle. Here's an interesting study that studied the prevalence of depression among heart failure patients. You can see a lot of countries are included, and you can see that in Denmark, for example, it's the country that have the happiest patient. So just 20% of heart failure patients have some sort of depression. As compared to Greece, for example, Greece, if you can see on the bottom here, 94% of patients in Greece with heart failure have a form of depression. It's interesting that Saudi Arabia participated in this study, and we have data from 1,200 patients, and the rate of depression in Saudi Arabia patients with heart failure is around 67%. So it varies depending on the country, but you will always see depression in patients that have heart failure. Okay. So social impact, patient will feel isolated. Patient will withdraw from physical limitation. They withdraw from their daily activity because of physical limitation. They will start to feel different with their families. They are relying more on family members. They are unable to work and unable to be productive. They are unable to participate in their hobbies, in their daily activities. And also, they will have, like said, change in all aspects of their life. We have some tools to assess quality of life. We have different scores. The most commonly used score is the SF36 score. So you can see it contains a lot of factors like physical function, bodily pain, general health, social functioning. So each score will have different points. For example, physical function have 10 items inside, sub items, and you can give a score. So if a score is between 80 to 100, the quality of life in chronic disease patient will be excellent. It's between 60 to 79 to be good, 40 to 59 to be moderate, and so on. So it's a very helpful score that we can use in hospital in chronic patients. Another score, also will not go in details, but you can see it can have different subgroups like physical health, psychological health, social relationships, environment, and each of these points will get a score. And if you have a score between 16 to 20, it will be very good quality of life. 20 to 15, good quality, moderate, and poor. So depend on the score you get. You have also a score that's interesting for just for heart failure patients to assess quality of life in failure patient. We call it the Minnesota Living with Heart Failure Questionnaire, MLHFQ score. So this score also contains physical dimension points, emotional dimension points, and you will get a total score at the end. If your score is above 60, it's a severe impairment, and if it scores between 0 to 20, it's a very good quality of life in heart failure patients. This score was used in the study that I showed you, um, and they use it to assess some of these patients. Diet is also very important in patients with chronic disease. It can help them have a better quality of life. You know that the Mediterranean and vegan diet are the best diets. They both promote heart health, and the vegan diet can have also positive effect on heart and can decrease mortality because they can have anti-inflammatory and antioxidant effects. They can improve insulin sensitivity. They can decrease the weight, lower the BMI, decrease in obesity. So Mediterranean diet is a diet rich in fruit, vegetables, whole grains, nuts, lean meats, while vegan diet is rich in fruits, vegetable grains, and nuts. So when the patient is on a good diet, he will see that he's losing weight. So this automatically will improve the quality of life of this patient, especially in patients that are overweight. While if a patient is on a high-fat diet or Western diet, which is rich in saturated and trans-saturated fats, rich in glucose, which in all kinds of fats, these patients are at increased risk of cardiovascular disease and are increased risk of obesity. So these patients will be obese, and with their condition, they will tend to have low quality of life. So it's very important to have a multidisciplinary team that follows patients with chronic disease to improve their quality of life. So physician with nurses, with psychologists, with psychotherapists, with occupational therapists, with dietitian, with pharmacists, and social workers should all collaborate for the need of the patient. So we should do regular team meetings to discuss the progress, to see where is this patient going, adjust the plans based on the condition, ensure continuity of care is very important. Should focus on mental health, lifestyle changes, as I told you, social needs to integrate the patient with the family, with his environment. We should encourage patient in active involvement in goal setting. So in the treatment plan, we should involve patient in the treatment plan. We should ask the patient, what do you prefer? Do you prefer this treatment or this treatment? We should explain to him each option. For some diseases, we can have, for example, either do surgery or give medical therapy. We should ask the patient what does he prefer. We should explain the risk of the benefit of each of the condition. For example, a heart failure patient, we should collaborate between cardiologists, nurses, nutritionists, physiotherapists, and psychologists. All of this will lead to better functional outcomes. Rehabilitation is also very important, especially for cardiac patients with heart problems, with pulmonary patients with COPD, chronic obstructive pulmonary disease. We can offer them rehabilitation. So we can ask the patient to, after the hospitalization, for example, for a cardiac surgery, we can send the patient to a rehab center. In the rehab center, the patient will have, they can manage his risk factor, his blood pressure, his cholesterol, his weight. They can help him do daily activities like walking, like doing exercise on a machine. So all of this will help the patient to be more active, to eat better, to quit smoking, to improve his mental health, and to keep an eye on managing his risk factors. So we can teach his patient while doing the rehab. This will improve the quality of life significantly. Same applies for pulmonary rehab for patients with COPD, especially advanced COPD patient, which is the third leading cause of death worldwide. So more than 16 million people are diagnosed with COPD in the US. And by doing rehab for these patients, we can see that they can have increase in exercise capacity, increase in quality of life, and decrease in COPD exacerbation, so decrease in future hospitalizations. We have a lot of challenges because in a lot of countries we don't have the resources, we don't have the money for the healthcare infrastructure, especially in rural areas that are very far from big cities. Sometimes patient are not adherent to complex regimen or have side effects on the treatment, so they become less motivated. Sometimes they also don't understand their disease. That's why we should teach the patient and make them understand about their disease. Yeah, so these are the most important points that are challenging us to improve the quality of life. No, so some patients, we can arrive to a disease point where the patient is DNR, so do not resuscitate. The patient has a chronic disease. Uh, we try to improve his quality of life and to slow down the disease, but at some point the disease will progress and will reach an end stage. So in that case, the patient will be in DNR, do not resuscitate. So the patient will be in a palliative care or hospice care. So let's talk about quality of life and how the nursing team and doctor should act when they see such patients. So it's important for you to know the difference between palliative care and hospice care. So palliative care will focus on quality of life. It can begin at any stage of the illness. So even early on of the disease, we can start the palliative care. It can be given alongside curative treatment. So let's say a cancer patient early on when he's taking chemotherapy. We can start palliative therapy too. It will improve the quality of life, even if we know that this patient can improve and can be cured. So we can start it very early on. Its main point is to manage symptoms and distress and support patient and their families. While hospice care is a more advanced stage, and we use it at the end of life. So we use it when the life expectancy become very limited and we know this patient will die eventually. So in that case, we can use hospice care, which is a bit different from palliative care. Curative treatment are usually stopped. So here we're not giving chemotherapy, we're not giving radiation therapy, we're just managing the symptoms, and we are supporting the dying process. So we give support to the patient, to their families, and towards the environment of the patient, so that the patient can be in a peaceful condition and at his end of life. So even in the end of life, we should not leave the patient, we should implement hospice care. It's very important. What condition can benefit from palliative care? So, like heart disease, like heart failure, advanced valvular disease, cardiomyopathies, even early on in the disease when the patient are symptomatic, COPD, chronic lung disease, cancer at any stage, especially for symptom control during while receiving chemotherapy, radiation, or immunotherapy, neurologic illness like Parkinson disease, stroke patient, multiple sclerosis, they will always benefit from palliative care. Organ failure, chronic kidney disease, liver disease, and other chronic illness like multimorbidity or repeated hospitalization. So all of these conditions will benefit from palliative care. While hospice care will just be attributed to very advanced cases and cases that cannot be cured, like advanced or metastatic cancer. So if, let's say, a lung cancer patient that has cancer spread to his brain or to his liver, this patient usually will not be cured. So in that case, we can use hospice care, especially if the life expectancy is very low, or it's a month or two. End-stage heart failure for patients that have refractory symptoms despite maximal therapy. End-stage lung disease, COPD, pulmonary fibrosis. You know, pulmonary fibrosis is a condition where normal lung tissues are replaced by fibrosis. So it's an irreversible disease. The only treatment for this disease is lung transplantation, but in a lot of countries, a lot of centers, this option is not possible. So at the stage, the patient will arrive at stage at end of life, and we can offer them hospice care. End stage renal or liver disease also, when life prolongation therapy is no longer possible. In that case, we can use hospice care. I'll give you now a case of a patient. So it's a patient, it's a 70-year-old male patient. He has a history of advanced heart failure, so his ejection fraction is very low, so his heart is unable to pump blood correctly. He has also chronic kidney disease and diabetes. This patient have multiple hospital admission in the past year for shortness of breath and fluid overload. You know that heart failure patients tend to have fluid overload because of their heart is unable to pump the blood to the circulation. So this patient is admitted again to the hospital. So after multiple admissions in the past, admitting again with the same symptoms, dyspnea, fatigue, and poor appetite. And despite using the optimum medical therapy, he is always symptomatic. So he's in a very advanced stage. But he's doing well. He's still doing well, but he's symptomatic. He appear anxious and he tell the nurse, so I'm tired of being in and out of the hospital. His daughter also is worried and asks if there's anything else we can do for him. So this is a patient coming on and off to the hospital, having symptoms. He's still doing well, he's still able to live, but he's having a lot of symptoms and a lot of hospitalization, and he's saying that he's tired. His family is asking if there anything else we can do. So what would you do next? It's a question for you. I hope that someone can answer me. So do you escalate the therapy and give additional medical therapy? You focus on symptom control. You explore the patient goals and values. You involve palliative care. You talk with the family. Can someone please answer me? What do you think is the best next step to do for this patient? If you can, just write in the comment, please. So Fatima is saying A, continuously escalating medical therapy. I have an answer from Nawal, which is focus on symptom control, and I have an answer from Ghada that is saying that to involve palliative care. So if you look closely to this patient, more than one option can be true. Uh, if we continue to escalate the medical therapy, but we said that this patient is we already escalated his medical therapy and he's still symptomatic. So there will be no added point if we escalate again his medical therapy. He will have more side effects maybe. But we tried the optimal medical therapy and the patient is still symptomatic. Focusing on symptom control is also possible. It's also part of palliative care. But for me, this patient should be consulted by palliative care team because we said palliative care team is not end of life. It's a symptom control in a chronic disease condition that is we are unable to uh, help the patient by giving him the medication for his condition. So in that case, more than one answer can be correct, but the best answer would be to start palliative care because you can see that this patient is saying that he's tired. He's very tired from going in and out of the hospital. Maybe we can use palliative care and treat him at home to help him and his family feel better. So the challenges are persistent symptoms despite treatment. These are the key point to initiate palliative care. Emotional distress to patient and the family. You can see that this patient, the family member is also asking if we can do something else. Unclear the understanding of the prognosis. The patient is not sure if he's understanding his disease and not sure where he's going. Repeated hospitalization with declining quality of life. So when you see these points, you need to think of palliative care. And this patient have all of these points in the case that I showed you. So we introduced palliative care to him alongside his ongoing treatment. So we don't stop the treatment, we keep the treatment, but we introduce palliative care to him. It will help him optimize his dyspnea, fatigue, anxiety, explore his goals and his values, support the family, and also coordinate the care just to reduce hospital visits. The outcome, so now this patient is his priority is to stay comfortable at home and spend time with his family, and this was the treatment plan that we gave him. The patient is now at home. We're still giving him the treatment for his condition, but the palliative care team is also acting to improve his symptom, home support, and advanced care planning. So palliative care is not about stopping the treatment. You should not stop the treatment, but it's about aligning care with what matters most of the patient. So we should make our patient feel better and decrease the hospitalization and maybe try to have the patient dwell at home. I'll show you now a second case. So I hope also you can be interactive in the comment and answer the question of the next slide. So it's a patient, it's a female patient 82 years old. She has metastatic pancreatic cancer. Okay, so you know pancreatic cancer is a very aggressive cancer, especially when it's metastatic. She has progressive weight loss, severe fatigue, and increasing pain. She came to the emergency department multiple times for fatigue, for pain, despite ongoing treatment. And she's not improving at all. She has metastatic cancer. She's in a very bad condition. She's coming this time with uncontrolled pain and weakness, and when the doctor and the nurse and the team comes to visit her, she's saying, I don't want to come back to the hospital anymore. And the son is asking what will happen if we stop the treatment. So this is a real scenario. You can see a lot of cancer patients in this condition. It's very, very common. So what should be the priorities now? So we have five options. So either we continue disease-directed treatment, we focus on comfort and symptom relief. We discuss prognosis openly. We introduce hospice care, and we support the family emotionally. What do you think is the best or the best answers for this case? Please write in the comments if you have an idea of the answer. Okay, Rada is saying D, Nawal is saying C and D. Fatima is saying B, Abdulaziz is saying B. So you can see we have variety of answers. Maybe more than answer can be true, or maybe we can do both at the same time. So yeah, I agree with you. B and D. B and D are the best next step here. We should also discuss the prognosis. So almost all of these answers are correct except A. So if you say A, it's wrong because metastatic pancreatic cancer is not a curable disease, and it's a disease that have just few months of survival. So continuing the treatment and side effects of chemotherapy and everything will make quality of life of the patient very bad. So we should for sure focus on comfort on symptom. We should discuss prognosis for sure because we need to explain to patients and families that the prognosis is very poor in pancreatic cancer metastatic. But the most important point here is to introduce hospice care. Because we said hospice care is end of life care, we should have the patient feel very comfortable uh, in their last days or last months of life. Yes, C is Hiba is saying C. Yes, C is one of the answers that can be correct, but D is also important here. So myself, if I want to choose, I will go with answer D as the best answer, but B and C also can be correct. So it's very good job, everyone. We got good answers. So hospice care intervention, as a team, discussed this hospice care with the patient and her family, and they focus now on just comfort rather than cure. It's not a curable disease, so there is no reason to continue the aggressive treatment to cure it. And just do symptom control at home and emotional and spiritual support for caregivers and family. So support everyone, including the patient and the family. So now the patient, she accepted hospice care and her pain is battery controlled. Her hospital visits are stopped. She spent the remaining time of her with family and her environment. So she's happy. She has less pain. She's now understanding her prognosis. She accepted it. And she's under medications to help her sleep, to help her live her last few months or weeks. So teaching point is hospice care is not about giving up. We're not saying we should stop everything and let the patient die. It's about prioritizing comfort, dignity, and presence at the end of life. So we should prioritizing comfort for this patient. We should not aim to cure them, but we're not saying we have to give up and let the patient die on their own. We should support them, we should comfort them at the end of their life. So we should always focus on trying to do early hospice referral, not just wait till the last days to do it. We should do it as soon as possible. Because nowadays, usually it's discussed very late during the crisis. So when we know the patient is going to die, we discuss it, but at that point it's very late. We should try to implement it before this stage. We need to have time to prepare, to explain to the patient, to support the patient and his family, and to support them emotionally. So if we apply hospice care early on, this will lead to fewer hospital visits, the patient will feel more understanding of what to expect. He will know that he will not be cured, but he can feel well if we apply hospice referral. And also for the team, for the doctor, for the nurses, for the whole team, they will be able to plan better if they start earlier, and they will not make urgent decision and last minute decisions, because last minute decisions are almost always not good decisions. It's very different between countries because hospice care is not widely available. It's only available in high income countries, but low and middle income countries have limited budget and have often, if they have it, it's often introduced very late in the disease, near end of life. We have limited training for doctors and nurses, and we don't have real uh, hospice and palliative team. So it's often small teams and single providers, unlike big hospitals and Western countries where they have multidisciplinary teams, physician, nurse, social workers, psychologists, so everyone in the team. So it's very variable between countries. What about Saudi Arabia? What about palliative and hospice care in Saudi Arabia? Because I know most of you, almost all of you work in Saudi Arabia. So, what about this condition, palliative and hospice care? So, I read few articles about it. So it started in the years 1990s in tertiary hospitals, but today palliative care is available. In many major public and private hospitals, especially in large cities. And services are mainly hospital-based or home-based. So it can be hospital-based or home-based. We have different type of palliative and hospice care. So around 80 to 100,000 people each year need hospice palliative care in Saudi Arabia. And around 70% of deaths are due to chronic non-communicable disease. As we said, globally it's 70%. In Saudi Arabia, it's also 70%. So most common cause of deaths are cancer, heart disease, and lung disease. So all of these patients can benefit from palliative and hospice care. Cancer also remained the most common diagnosis in patients receive palliative care. So same thing, cancer is globally present. It's also in your country, so it's the same percentage. Hospice care is dedicated to hospice facilities are growing. We're seeing more and more teams doing hospice cares. It's often delivered in palliative units and at home, but it's still being done late. So we should try to do it a bit earlier. And the government is helping this with the Saudi Vision 2030. So we have growing number of trained palliative care physicians and nurses, more doctors coming from everywhere, improved access to essential pain medication compared to many low-income countries. So you're in a very good situation, and you're moving forward very well. There is also challenges because sometimes we have late referrals to palliative and hospice care. So the primary treating doctor or oncologist send the patient to the palliative doctor very late. So this is one of the challenges. Sometimes cultural discomfort. You see that the family will not accept to stop the treatment and just do symptom control. It's very common. It's one of the most common challenges you can see when you're dealing with a patient with cancer at end of life. We have unequal access between urban and rural regions. You can see that big cities have more resources compared to rural regions that have less hospital, less doctors. We also have limited public awareness of hospice care. Not all doctors and nurses and healthcare workers are aware what is hospice care. So, how can the nurse or doctor help the quality of life in these patients? What medication, for example, can we give them to help them, especially if they have pain? And a lot of cancer patients, they can present with diffuse body pain related to their treatment. So the first thing you can give or you think about is morphine. Morphine can be given. It's most commonly used. It's available everywhere. It's not Its price is not very expensive. It can be used for moderate to severe pain. You can have it in oral, IV, or subcutaneous route. Some patients are not able uh, to have oral tablets, so in that case, you give them IV or subcutaneous routes. It's also faster when you give it that way. It can help with the dyspnea because when you decrease the pain, the patient will be able to breathe normally because when he's in pain, he will be hyperventilating, so he'll be dyspneic. You can also use hydromorphone, which is not it's an alternative to morphine. Uh, Especially when the renal function is reduced, you can use it. It can come in forms oral, IV, and subcutaneous too. You can also use fentanyl, which is used IV or transdermal patch. It's a medication used for pain and sedation also. Used well in renal failure or if oral route is not possible. So this medication comes with IV or transdermal. There's no oral route, and we can give it for patients that are unable to swallow medications. A patch is also used for stable chronic pain. So you can use fentanyl patch for these patients if they have chronic pain that is very hard to treat with other type of medications. And the nursing focus should be to assess the pain regularly and give scheduled dose and offer also PRN breakthrough doses. So you can see that sometimes we have medication being prescribed be given systematically, especially in patients that have chronic pain. But we can also prescribe, so the nurse can ask the doctor to prescribe her medication PRN to be given if needed. If the patient is in pain, we can give them like small doses of morphine or hydromorphone or fentanyl if the patient is in need or he has spikes of pain. So we can ask the doctor to prescribe as needed or PRN medications. Nausea is also very common in chronic diseases, especially in cancer patients. So, the first step is to assess the nausea. To ask the patient to rate the nausea from 0 to 10. So, maybe 2 is he's just feeling a bit of nausea, but 10 when the patient feels like he wants to vomit. Uh, so we need to identify triggers. Pain can lead to nausea. Medications like opioids that we give to pain can lead to nausea too. Constipation is very important cause of nausea. We should always check if the patient has constipation or not. If the patient has constipation, we should treat it. Anxiety can lead to nausea. Also, movement can lead to nausea. But constipation really is one of the most common causes of nausea. Some patients stay like 7 to 8 days constipated. Pain also is a common cause. Opioid medication to treat pain can also lead to nausea. What should the nurse do in this case to improve the quality of life of this patient? We should observe the patient for vomiting. We should check if he has poor oil intake. He can't take pills for nausea. If the patient is dehydrated, because if he's vomiting a lot, he will be dehydrated. If he's in distress, this will also worsen the condition significantly. What are the medications that we can use to treat nausea? Any idea? Can someone please tell me in the comments? Do you know any medications that we can use to treat nausea? And if we can give it IV or oral, any idea? Please write them in the comments. Yes, exactly. So ondansetron, metoclopramide, domperazole, Zofran, everything, all this medication can be given. Like metoclopramide, like many of you said, it can be given per os or it can be given IV. So it's a very effective medication. But you should be careful with this medication because, especially in young patients, it can cause what we call extrapyramidal syndrome. So the patient will start shaking, start doing abnormal movements. So when you see the patient doing such movement after using metoclopramide, you should suspect it and you should stop the medication. It's not very common, it's very rare, but you can see it maybe once in a lifetime, but it can happen. Yes, ondansetron is safer uh, as Nawal said. Do you know on which receptor does ondansetron act and metoclopramide? Anyone knows which receptor? Exactly. Hamdan is saying it can act on serotonin receptor. Exactly. That is the ondansetron. And metoclopramide, anyone know on which receptor it can act? Abdurrahman, I think ondansetron is the same class. I don't know this medication, but I think it's the same class of ondansetron. It acts on serotonin. Anyone knows what receptor on metoclopramide acts on? Yes, exactly. Hamdan, very good answers. So you answered both correctly. It can act on dopamine D2 receptor. It's a D2 antagonist. Serotonin is for the ondansetron, and the dopamine is for the metoclopramide. Metoclopramide can come with a 10 milligram dose, and the ondansetron it can come with 4 milligram and 8 milligram doses. Great. Yeah, all of these are good answers. Okay. Yes, Abdurrahman, domperidone can be used to give for nausea and vomiting. You can use it, yes. Okay, so I will continue. It acts also on the D2 receptor, dopamine. So, as we said, ondansetron can be used especially for chemotherapy-related or medication-induced nausea. So, ondansetron is better for chemotherapy-related, better than metoclopramide. Usually, if you want to prescribe something for chemotherapy-related nausea, I advise you to prescribe ondansetron. It's better. Metoclopramide is for nausea related to other conditions like gastroparesis or constipation. It usually acts better in this case, but Zofran or ondansetron is a safer medication to get on serotonin receptor, has less side effects, and is very effective when given with chemotherapy. And some doctors also prescribe it systematically because they know that chemotherapy will induce nausea, so they prescribe it before it happens as a prevention. Also, alloperidol, it's rarely used, but you can use it if the nausea is very persisting. Also, dexamethasone is a steroid, especially used when we have brain metastasis or increased intracranial pressure. You know, a lot of cancer can spread to the brain, and when they spread to the brain, we'll have an increase in intracranial pressure, and increased intracranial pressure will cause brain edema. So you need to use steroids, and steroids will drop the intracranial pressure, and the intracranial pressure, when it drops, the nausea will drop. Nausea is a symptom of high intracranial pressure or brain metastasis. Lorazepam is also can be used, especially if the nausea is related to anxiety. A lot of patients with anxiety they can present with nausea. So, tip for nurses that are, if you're a nurse and you're listening to my presentation, you should always give them medication regularly, especially in cancer patients, and not just as needed, because cancer patient on chemotherapy will most of the time complain of nausea, especially if you know that the medication that you're using will lead to nausea. So always discuss this as a team between nurses and doctor. If the doctor doesn't prescribe it, ask him, please, can you prescribe a medication for nausea? Because I need a systematic medication because this patient is having uncontrolled nausea. So please, if you can prescribe me one of these medications. Also, we have non-pharmacological nursing interventions that we can do. We can elevate the head, will help decrease nausea. We should avoid that the patient lying flat after a meal or after medication, because this will increase the risk of aspiration. And if you, as the patient aspirates, it will lead to pneumonia, and the patient will be deteriorate very fast. Also, we need to reduce the strong smells in the hospital, in the room, keep the room cool and well ventilated. Always give him oral intake food, small but frequent sips. Do not give him everything at once. It will increase nausea. Do not force the patient to eat if he's unable to eat, if he has nausea. Treat nausea first, then tell the patient to eat. Most care is very important to reduce the bad taste, also to reduce the mouth infections, because if the patient has fungus infection in his mouth, the patient will not be able to eat. So you always need to check the mouth condition, especially in immunosuppressed patients or chemotherapy patients. You should always check their oral hygiene and oral infections. You need to reassure the patient, calm them down, slow their movement. Used cold compresses also are sometimes helpful when the patient is very agitated or febrile or any other condition. We need to prevent common causes, like you need to check if bowel regimen is in place, because constipation will worsen nausea. So if a patient is constipated, try to use laxatives, try to use medications to treat constipation. You need to administer pain medication appropriately, because untreated pain, as we said, will lead to nausea. But sometimes the medication to treat pain will also lead to nausea. So it become a viscous cycle. So in that case, always use nausea medication systematically. Also avoid the unnecessary oral medication if the patient has difficulty swallowing. So when the patient especially are in their end of life or palliative care, we can try to stop some of their medication, especially that if the patient has difficulty swallowing big pills or large medications. Dyspnea is also very common, especially in lung cancer patients. So do you know, can anyone tell me what should we suspect when a patient with cancer, not necessarily lung cancer, any patient with cancer presenting to the emergency with acute dyspnea? So the patient were doing well, and they suddenly present to the ER with acute dyspnea and desaturation. What should you expect? What is the most common diagnosis in cancer patients? Not necessarily in lung patients, but in any patient. What condition do you expect? Can you please write it in the comment if any one of you have an idea? Fawaz is saying metastasis. Yes, possible. You can have lung metastasis, but usually lung metastasis will not present with acute dyspnea. It will present a bit with acute, with chronic dyspnea. PE, Fawaz is also saying PE, Ghada is saying PE, Nawal is saying decreased oxygenation. Yes, you're correct. Decreased oxygenation is also a condition, but it's the most common condition is PE, is pulmonary embolism. So any patient with cancer presenting with acute dyspnea that had dyspnea before presents with acute dyspnea. Yes, Dina, correct. P. You should always suspect pulmonary embolism because cancer is a hypercoagulable state and clots can form in the lung, in the extremities and migrate to reach the lungs. So you should always rule it out when a cancer patient that was doing well, has no dyspnea, comes suddenly with a dyspnea. But most of cancer patients, especially lung patient or lung metastasis patient, will have chronic dyspnea. And in these patients, we should use oxygen for comfort. Even if the saturation is okay, is good, we can just put 1 or 2 liter oxygen. The patient will feel better, will feel reassured that there's an oxygen supply to him. We can use opioids sometimes as the patient is hyperventilating and in pain. We can position the patient in a better way, elevate his head, and try to reassure him. Anxiety is very, very common. So in all oncology department, I'm focusing on cancer now because it's the most common cause of chronic diseases alongside heart diseases, but it can also be done for heart failure patients too. You should always have a psychologist working with you and the team if possible. You should recognize agitation versus pain versus delirium, because all of these conditions can lead to anxiety. Can someone tell me what is a very common condition that can cause uh, acute delirium in the hospital? Sometimes a patient is in the hospital, um, he suddenly developed delirium, especially in intensive care patients. What do you think is the most common etiology of delirium or agitation or psychosis? There is a one common cause. Can anyone write it in the chat? Especially in old patients. Yes, long-term drugs could be yes. Infection could be too. If the patient have infection, he has inflammation, this can lead to hypotension, lead to psychosis and agitation, yes. Drug interaction, possible, yes, yes. What kind of drug interaction? Can you tell me something? Do you have something in mind? Actually, one of the most common cause of yes, serotonin syndrome can lead to this, true. And said, actually, one of the most common cause of agitation in the hospital is urine retention, especially in old patients that are unable to urinate on their own. So we always need to do a bladder scan or check if they are in retention, palpate their bladder, see if they have pain. You can, in that case, you can put a urinary catheter, a Foley catheter, and you can see that the patient sometimes can improve very fast. So urine retention is a very common reason of agitation in the hospital, especially in old patients. But all what you said is also possible too. Use of how to treat anxiety, you need to use benzodiazepine, antipsychotics, depending on the stage. Non-pharmacologic calming strategies also can work, like asking the psychologist to talk to the patient, sit next to the patient, explain the condition. All of these conditions can help. As I told you, also oral care and dry mouth are should be done daily for cancer patient and heart failure patient. We should rule out infection, managing um, mouth infection, thrush, dryness, bad taste. Because oral care is comfort care, it should be part of comfort care. Constipation, as we said, is a very common cause of um, decreased quality of life in patients. It's usually due to medications or due to low fiber diet. We should use bowel regimens, so change the diet. We should use like laxatives or medications to treat constipation. Because, as we said, it can lead to pain, abdominal pain, bloating. It can lead also to nausea. We should also recognize signs of active dying. So, as part of the quality of life managing, especially in palliative care or end of life care patients, we should know that the patient is arriving at this stage. How to know? So, patient will start changing his breathing pattern. He will eat less. He'll become less responsive. And we should know how to reassure the family, to explain the condition, telling them that we will give him medication. We don't want him to suffer. We'll manage his pain and all other associated conditions. So care in the last 24 to 48 hours of life is very important. We should stop doing labs and giving medication that has nothing to do with this condition. We should try to decrease the amount of medication we're giving. And what should we focusing on in the last 24 to 48 hours of life of patient is comfort and dignity. Patient should feel well. He should not feel suffering. This is very important. Avoid doing vital signs every 4 hours, every 2 hours. Avoid doing labs every day. Just focus on the comfort of patient uh, and the surrounding and the family. When a patient with a DNR code deteriorates, in that case or the nurse should be trained. What she do? She should inform his primary doctor. Should discuss We should see what medication to give, what not to do, as we said. Do not be very aggressive. Do not measure the vital signs every hour or every 2 hours. Call the family, call the primary doctor, call the oncologist. So it's a teamwork at the end. So here are my references. If anyone is interested, you can check these references about this topic. Thank you so much. This was the end of my presentation. Thank you so much for your participation and answering the question, and also participating in the chat box. If you still have any question, or if I forgot to answer a question, please you can write it down now. We have around 13 minutes before moving to the abstract presentations. We have a few abstracts to be presented. So if you have some question, we have like 10 minutes now to answer them. Or if I forgot something, I'm sorry, you can ask it again. You're welcome, everyone, and hope to see you again in future lectures. إن شاء الله بشوفكم برجع next time بغير lectures أكيد. أكيد شكرا على رؤية المستقبل for organizing this event. It was very interesting. Thanks for the organizer for organizing this nice event, and for everyone attending the events. Fatima is asking if any patient is on last stage, that person has right to know his or her last time through medical law. Yeah, I agree with you. Patient is um, legally and by ethically, if you want, not I'm not talking law, I'm talking ethically. The patient has the right to know the stage of his condition. Even if the family refused to tell him, but the patient has the right to ask about this condition, and even if the condition is very bad, um, he should know. But we should know how to tell him, not just tell him you're going to die in a week. We should try to prepare him and to surround him with people that can help him in this difficult period. But yes, ethically, the patient should be informed. Should not hide these things on the patient. Okay, I will stop sharing. Thank you for the organizer again. I have a question, a last question. نوال is asking دكتور هل فعلا أدوية الكوليسترول تؤدي إلى ألزهايمر أو النسيان وهل لها علاقة بألم المفاصل؟ No, no, الكوليسترول medication هن الستاتين we use them a lot. بالعكس يعني ما عندنا ولا evidence بتقول إنه الكوليسترول medication can lead to الألزهايمر أو البيشنت يصير ينسى. ما عندنا ولا evidence. ما في كتير studies، بس ما عنا evidence انه فيهم يعملوها. no. So my answer is no for Alzheimer and also for arthritis. تسأليني إذا ألم المفاصل يعني التهاب المفاصل or arthritis. No, it doesn't cause this. No. Uh, I have another question. Diabetic can be reversible condition if want to do. Usually, if you treat the condition when it's in pre-diabetes, so we said when the glucose is less than 126, the fasting glucose, usually you can reverse it or even stop it when it's in at this condition. But when it's established diabetes, so the glycemia becomes uncontrolled, it's very hard to reverse. Usually, the patient will stay diabetic, but you can control his glucose and keep his glucose in normal range. But if you stop his medication, the glucose level will go up again. So it's not reversible, but you can slow it down. Same for hypertension. Okay. If no questions, I will. Oh, we still have questions, so we still have a few minutes for questions. Low sodium is good for high blood pressure. Yes, sure. You always need to decrease sodium intake. I said in my presentation, sodium intake should be less than 1.5 gram a day. It's recommended for hypertension patient to drop their sodium intake to 1.5 gram or 1,500 milligram a day. Um, I have other question. Speaking of quality of patient life in case of diabetes, there has been complaints about short-term memory loss. I'm not aware of this issue, honestly. I didn't see any study talking about this. Maybe there are some case reports, or it can be due to it can be multifactorial. Maybe old patients having early Alzheimer disease, or some of the medications can cause it. But I'm not aware that diabetes itself can lead to memory loss. No, I don't. I'm not aware of this. Any more questions, or we can move to the abstract if a presentation if you don't have any more questions. Okay. Thank you, Mary. Thank you. The next lecture is the abstract presentation. We have different abstracts that we present now.
Good evening, everyone. Can you hear me clearly?
Yes, we can hear you.
Okay. Good evening, everyone. My name is Ahlam, and I'm psychiatric nurse. Today, I'll be talking about managing clinic during nursing staff shortage. The nursing staff shortages are a global challenge that directly affect patient safety, workflow, efficiency, and the quality of care. Clinics must adopt practical and flexible strategies to maintain safe and effective service during this shortage. The most common causes increase patient volume, sick leave and burnout, and sick leave, which is the most common causes, limited recruitment or high turnover, expected emergencies. The effective management strategies prioritize patient care based on equity, optimize staff scheduling and task delegation, utilize cross-trained staff and float nurses, reduce non-essential activities, use teamwork and clear communication. About the role of nursing leaders, the nurse leaders play a vital role supporting staff during shortages by ensuring fair workload distribution, providing emotional support, and promoting positive work environment for the staff. The maintaining patient safety, adhere to clinic policies and protocols, encourage incident reporting, monitor workload and fatigue, ensure proper documentation. So this is all about shortage in the clinic. Thank you so much. Any question?
Thank you, Ahlam. It's a nice abstract. I have a question for you. Um, have you ever worked in a period where there is a lot of shortage? And if yes, what was the main challenge you faced in these cases?
Yes, of course, everywhere, but the most common shortage is an inpatient. If there is many patient for admission, and there is no staff available for the work, but sometimes we can manage it and we can ask from outside, and
Yeah,
it's always helpful.
yes, true. Okay,
Thank you.
thank you. Thank you.
السلام عليكم، في صوت؟
ايه، عم نسمعك محمد، عم نسمعك.
الله يحييكم. محمد سليمان الصويان، مستشفى القوات المسلحة بالقصيم. نتكلم اليوم عن دور أخصائي التغذية في إدارة سوء التغذية لدى كبار السن. طبعا تزداد معدلات سوء التغذية مرتبط بالتقدم في العمر في كثير من الدول الغربية، وما ينعكس سلبا على الحالة الوظيفية والطبية وجودة الحياة والبقاء لدى كبار السن. بسبب طبيعة المشكلة وتعدد أسبابها بدنية وطبية ونفسية واجتماعية، يصبح التعامل معها معقدا ويتطلب رعاية منظمة ومتكاملة. تهدف هذه المراجعة المنهجية إلى تلخيص الأدلة حول الدور الفعلي لأخصائي التغذية في إدارة سوء التغذية لدى كبار السن مقارنة ببقية الممارسين الصحيين، وبيان كيف تؤثر بيئة العمل وحدود الأدوار المهنية على جودة الرعاية التغذوية المقدمة. طبعا سوء التغذية لدى كبار السن ليس مجرد نقص في السعرات، بل يرتبط بعوامل متداخلة مثل صعوبة التسوق أو البلع، الأمراض المصاحبة، الاكتئاب، والمعاني الاجتماعية والنفسية للطعام. كما أن العادات الغذائية الراسخة وتعدد الأمراض قد يجعل تغيير النمط الغذائي صعبا رغم الحاجة الطبية. ورغم أن الرعاية متعددة التخصصات هي النهج الموصى به، فإن دور أخصائي التغذية لا يكون دائما واضحا في الواقع اليومي، لأن الممرضين يرون المرضى أكثر، والأطباء غالبا مسؤولون عن القرار العلاجي النهائي. وقد تتداخل الاختصاصات أو تتباين الأولويات داخل الأقسام. أجريت مراجعة منهجية للدراسات التجريبية النوعية والكمية التي تناولت دور أخصائي التغذية بوصفه موضوعا رئيسيا في إدارة سوء التغذية لدى كبار السن، مع استبعاد المقالات والمراجعات والأبحاث التحليلية التجريبية والسببية التي لا تصف الممارسة الواقعية للدور المهني. طبعا تم البحث في قواعد بيانات مثل كرونيك سنترال والويب اوف ساينس والجوجل، باستخدام كلمات محورية حول أخصائي التغذية كبار السن وسوء التغذية. وبعد البحث المبدئي اقتصرت الدراسات على آخر 10 سنوات لضمان تمثيل الممارسات الحديثة. أجري البحث في 12 نوفمبر 2018، وانتهت عملية الفرز إلى تضمين 21 دراسة في التحليل مع تلخيص النتائج عبر تركيب موضوعي. في النتائج أظهرت المراجعات أن دور أخصائي التغذية تأثر بقوة ببيئة العمل، خصوصا نظام الفحص الغذائي، إذ أن ضعف الوقت والمعرفة لدى بعض الكوادر أو غياب سياسة واضحة للفحص يقلل الإحالات ويؤخر التدخل. بيّنت الدراسات أن الفحص قد يكون موجودًا لكنه أحيانًا يمارس بشكل غير منتظم أو غير موحد بين الجهات، ما يجعل اكتشاف الحالات مبكرًا وإحالتها لأخصائي التغذية أقل كفاءة. أكدت النتائج أن أغلب المهنيين يعترفون بأهمية الرعاية التغذوية، لكن هذا لا يعني دائما فهما واضحا لما يقدمه اختصاص التغذية أو أن إشراكه ينظر إليه كأولوية مستمرة. وضحت الأدلة أن النقص المعرفة التغذوية لدى بعض الممارسين قد يقول لاعتماد تقييمات انطباعية بدل أدوات فحص مبنية على الدليل، وقد يسبب إحالات متأخرة تقلل فاعلية العلاج. وأظهرت المراجعة أن ضغط العمل ونقص الكوادر تجعل حدود الأدوار مرنة، فبعض اختصاصيي التغذية يضطرون لتبني أدوار إضافية مثل التواصل والتوجيه والتدريب والقيادة داخل الفريق لضمان تطبيق الخطة التغذوية. وبيّنت النتائج أن نجاح دور اختصاص التغذية يعتمد على التعاون الفعال، لأنه غالبًا يقدم استشارة أو خطة، بينما تنفيذها اليومي يحتاج مساندة التمريض وبقية الفريق. وأكدت المراجعة أن تحسين الوعي داخل الفريق حول متى وكيف نحيل وما القيمة المضافة لاختصاصي التغذية يساعد على تحويل الإرشادات من كونها نظرية إلى ممارسة مستمرة. الخاتمة تشير هذه المراجعة إلى أن دور اختصاص التغذية في إدارة سوء التغذية لدى كبار السن ليس ثابتا في جميع البيئات، بل يتشكل وفق سياسات الفحص وأولوية التغذية داخل الأقسام وحدود الأدوار وضغط العمل. ولتحسين النتائج توصي الأدلة عمليا بتقوية منظومة الفحص والإحالة ورفع وعي وتدريب الكوادر غير المتخصصة ودعم عمل الفريق متعدد التخصصات بحيث تنفذ الخطط التغذوية بانتظام وليس كممارسة حسب الحاجة. أعتذر عن الإطالة وشكرا لكم.
شكرا محمد. Did you publish this article?
السلام عليكم. الصوت واضح؟ معكم عاصم عمر العيسى، مستشفى القوات المسلحة بالقصيم. موضوعنا اللي هو التكامل والتشغيل البيني بين نظم المعلومات الصحية غير المتجانسة ودوره في تحسين جودة الرعاية الصحية. تواجه نظم المعلومات الصحية تحديات متزايدة نتيجة تعدد الأنظمة واختلاف بنيتها وعدم قدرتها على تبادل البيانات بسلاسة، مما ينعكس سلبا على جودة الرعاية وسلامة المرضى وكفاءة الخدمات الصحية. وتهدف هذه المراجعة المنهجية إلى تحليل متطلبات التشغيل البيني بين نظم المعلومات الصحية غير المتجانسة واستعراض المعايير والتقنيات المعتمدة عالميا لدعم تكامل البيانات الصحية وتحسين تبادلها. ويشهد القطاع الصحي تحول رقميا واسع النطاق مع تزايد الاعتماد على نظم المعلومات الصحية مثل السجلات الصحية الإلكترونية ونظم المختبرات ونظم التصوير الطبي ونظم دعم القرار السريري. ورغم الفوائد الكبيرة لهذه النظم إلا أن اختلاف تصميمها وتطويرها من قبل جهات متعددة أدى إلى نشوء أنظمة منعزلة وغير قادرة على تبادل البيانات بكفاءة، مما قلل من الاستفادة الكاملة منها. ويعتبر التشغيل البيني إحدى المراكز الأساسية لمعالجة هذه المشكلات، إذ يتيح مشاركة البيانات الصحية بين الأنظمة المختلفة بشكل آمن ودقيق وفي الوقت المناسب، ويساهم ذلك في تحسين تنسيق الرعاية وتقليل التكرار في الفحوصات وخفض التكاليف وتعزيز سلامة المرضى وجودة الخدمات الصحية، وهو ما يجعل التشغيل البيني محور اهتمام متزايد في الأبحاث الصحية وتقنيات المعلومات الطبية. المنهجية بهدف تبعت الدراسات تصميم مراجعة المنهجية وفق إرشادات جمع وتحليل الأدلة العلمية المتعلقة بمتطلبات التشغيل البيني بين نظم المعلومات الصحية غير المتجانسة. شملت معايير اشتمال الدراسة المنشورة باللغة الإنجليزية والمتاحة بالنص الكامل، التي تناولت تطوير أو تقييم أو تطبيق التشغيل البيني في نظم المعلومات الصحية مع التركيز على متطلبات التقنية والمعايير التنظيمية. تمت عملية الفرز على عدة مراحل شملت مراجعة العناوين وأسفر ذلك عن تضمين 36 دراسة في التحليل النهائي. النتائج أوضحت الدراسات أن غياب التشغيل البيني يؤدي إلى تجزئة بيانات المرضى وزيادة الأخطاء الطبية وتكرار الفحوصات. بينت النتائج أن معظم المشاريع التشغيل البيني تركز على المستوى الوطني بهدف دعم السجل الصحي الإلكتروني الشامل. أكدت الأدلة أن التشغيل البيني الدلالي هو الأكثر فعالية في ضمان فهم ومعالجة البيانات بشكل صحيح بين الأنظمة. ساعد التشغيل البيني في تحسين سرعة الوصول إلى المعلومات السريرية ودعم اتخاذ القرار الطبي في الوقت المناسب. ساهم تكامل الأنظمة في تقليل التكاليف التشغيلية وتحسين كفاءة العمل وتقليل العبء الإداري على الكوادر الصحية. توضح هذه المراجعة المنهجية أن التشغيل البيني بين نظم المعلومات الصحية مثل عنصرا محوريا في دعم التحول الرقمي الآمن والفعال في القطاع الصحي، إذ يساهم التكامل السلس للبيانات في تحسين جودة الرعاية وتعزيز سلامة المرضى وتقليل الهدر في الموارد ودعم التنسيق بين مقدمي الخدمات الصحية على مختلف المستويات. كما توضح النتائج أن تبني معايير موحدة مع التركيز على التشغيل البيني الدلالي يعد خطوة أساسية لتحقيق الاستفادة القصوى من نظم المعلومات الصحية. وتوصي الدراسة بضرورة الاستثمار في البنية التحتية الرقمية وتعزيز التعاون بين على المستويين الوطني والدولي. هذه مشاركتي وعد عن الإطالة. السلام عليكم.
الو السلام عليكم. ان شاء الله معكم الدكتور ناصر الحارثي، بيدياتريك سين ريجسترار من مستشفى القوات المسلحة الأمير سلطان بالطائف. عندي اليوم إن شاء الله هذا البحث طلعت عليه ولقيته يعني interesting, which is Crizrovimab for prevention of RSV disease in healthy infants. As we know that there is among the infant younger, as we know that Balivizumab that used for the children, which is preterm less than 34 weeks, and also with plus they have chronic diseases like chronic lung disease and also congenital heart disease and so on. So I found this study is interesting because it is the efficacy, it was good for the babies. So I will start the introduction. Among infants younger than 1 year of RSV causes an estimated 12 million lower respiratory infection and approximately 2.2 million hospitalization per year worldwide. So RSV, as we know, that a leading cause of infant hospitalization in high-income countries and a frequent cause of death in low and middle-income countries. So also the monoclonal antibody like nirsevimab and also the maternal bivalent perfusion vaccine has been licensed for use in infants. So the new drugs that they implemented was clesrovimab, which is a human RSV monoclonal antibody with 3 amino acids substitution. So also has they found that has high tissue distribution and concentration in nasal compartment. The aim of this study was evaluate the efficacy and safety of a single intramuscular dose of clesrovimab in preventing respiratory RSV associated lower respiratory tract infections, and also the hospitalization in healthy preterm and also full-term infant entering their first RSV season. So they use a multi-center randomized double-blinded placebo-controlled clinical trial conducted in 22 countries across both hemispheres, northern and southern. So the trial was approved by the Institutional Review Board and regulatory authorities in all participating centers across 22 countries. So the primary endpoint of this study was the RSV-associated medically attended lower respiratory infection occurring from day 1 to day 150 after injection. So they did the study with control group and also who received will receive the clesrovimab. So the ratio was 2 to 1 to control group. So also they found the secondary endpoint of this study also RSV-associated hospitalization occurring from day 1 to day 150 after injection. So as we know that we have inclusion criteria in every study and exclusion criteria, so I will pass by this one, but you know that the randomization of this study was the infant who was randomly assigned, as I said before, 2 to 1 ratio to receive either a single dose of 105 milligram intramuscular dose of clesrovimab, and also the other control group was placebo, which is saline injection. So the stratification factor was based on the gestational age, chronologic age, and geographic hemisphere. So the type of intervention, as I said before, was clesrovimab, and for the group, and the control group was saline infusion. So the injection was given intramuscularly, typically in anterolateral thigh, standard site for infant immunization, and also administered before or at the start of the infant's first RSV season, ensuring antibody protection through the 5-month of RSV period. So no dose was adjustment or based on the weight. All the group was the same dose, and the monitoring was observed for injection site reaction, fever, or systemic symptoms during the first few days after administration. So the result, as we know, as the study showed, that significant reduction in RSV-related outcomes, including hospitalization and severe medically attended infection. The overall efficacy ranged from about 60% for general RSV illnesses to over 90% for severe or hospitalized cases, indicating strong and sustained protection throughout the RSV season. Although the confidence interval shows that in the study wider in some groups, but the efficacy in generally consistent across body weight categories. So the discussion of this study was showed high efficacy in preventing RSV-associated lower respiratory infection and hospitalization in healthy term and preterm infant. So the single intramuscular dose of clesrovimab has sustained or provides sustained protection for at least 5 months, covering an entire RSV season. So the efficacy, as I said before, exceed 90% against severe disease and hospitalization, and around 60% for overall RSV-associated illnesses. Safety profile was favorable. The rates of adverse and serious adverse events were similar to placebo group and indicating good tolerability. Results are consistent with other monoclonal antibody, but target a different RSV fusion protein site, which may reduce the risk of viral resistance. So the high conservation of binding site 4 across RSV strains suggests broad and durable effectiveness. Findings support clesrovimab as a potential seasonal preventive option for all healthy infants, including those not eligible for bevacizumab, as we know previously. So the limitation of this study was the follow-up period was limited mainly to one RSV season, which is equal 5 months. So long-term protection and immunity beyond that are uncertain. The study excluded high-risk infants, such as those eligible for bevacizumab, limiting generalizability to that group. The trial included healthy infant only, so results may not apply to infant with underlying medical conditions. Conducted across multiple countries and hemispheres, but seasonal timing and RSV strain variations may have influenced the outcomes. So no head-to-head comparison with narcivimab or other monoclonal antibody was performed. Post-trial data on resistance, mutations, and long-term antibody persistence were not yet available. So in conclusion, a single intramuscular dose of clesrovimab, which is 105 milligram, significantly reduced RSV-associated lower respiratory infection and hospitalization in healthy preterm and full-term infants. Protective effect was maintained for at least 5 months, covering an entire RSV season. Safety profile of clesrovimab was similar to that of placebo, with no safety concerns identified. These findings suggest that clesrovimab provide effective, long-lasting, and well-tolerated protection against RSV disease. Results support clesrovimab as a promising preventive option for healthy infants during their first RSV season. This is the end of my presentation, and thank you for your listening. الله يعافيك، شكرا لك. الله يعافيك.
السلام عليكم ورحمة الله وبركاته. تسمعوني؟ أول شيء الله يمسيكم بالخير. معكم إبراهيم محمد الحساني، أخصائي طب وقائي مستشفى القوات المسلحة بالهدى. موضوعي راح يكون عن تأثير عدد الخطوات اليومية على الصحة العامة لدى البالغين. يعتبر النشاط البدني المنتظم أحد أهم محددات الصحة العامة، إلا أن تحديد الجرعة المناسبة من الحركة اليومية ظل موضوع نقاش، خاصة مع شيوع استخدام عدادات الخطوات. وهدفت هذه الدراسة إلى تقييم العلاقة بين عدد الخطوات اليومية ومجموعة من النتائج الصحية المهمة، وعلى رأسها الوفيات لجميع الأسباب، من خلال تحليل الأدلة المتاحة من الدراسات السكانية. وأظهرت النتائج وجود ارتباط واضح بين زيادة عدد الخطوات اليومية وتحسن المؤشرات الصحية وانخفاض خطر الوفاة، مع ملاحظة أن الفوائد تبدأ بالظهور عند مستويات أقل من الأهداف التقليدية الشائعة. يمثل قلة النشاط البدني أحد عوامل الخطر الرئيسية للأمراض المزمنة والوفيات المبكرة على مستوى العالم، وهو ما دفع الجهات الصحية إلى التوصية بمستويات محددة من الحركة اليومية. ومع انتشار الأجهزة القابلة للارتداء، أصبح عدد الخطوات اليومية مؤشراً عملياً وسهل القياس للنشاط البدني في الحياة اليومية. ورغم شيوع هدف 10,000 خطوة يومياً، إلا أن الأساس العلمي لهذا الرقم ظل غير واضح، كما أن القدرة على تحقيقه تختلف باختلاف العمر والحالة الصحية. ومن هنا تبرز أهمية مراجعة الأدلة العلمية لتحديد العلاقة الفعلية بين عدد الخطوات اليومية والنتائج الصحية، وتقديم توصيات أكثر واقعية وقابلة للتطبيق على مستوى الصحة العامة. اتبعت الدراسة تصميم مراجعة منهجية وتحليل تلوي وفق المعايير العلمية المعتمدة، بهدف تجميع وتقييم الأدلة المتاحة حول العلاقة بين عدد الخطوات اليومية والنتائج الصحية لدى البالغين. تم البحث في قواعد بيانات علمية كبرى شملت بوب ميد وويب أوف ساينس ومجموعة من المواقع العلمية، مع التركيز على الدراسات السكانية التي استخدمت أجهزة موضعية لقياس عدد الخطوات. شملت معايير الاشتمال الدراسات الرصدية التي أجريت على بالغين، والتي قيمت عدد الخطوات اليومية وربطته بنتائج صحية مثل الوفيات أو مؤشرات الأمراض المزمنة. تم استبعاد الدراسات التي اعتمدت على التقدير الذاتي للنشاط البدني. جرى استخراج البيانات بشكل منهجي وتقييم جودة الدراسات، ثم إجراء التحليل التلوي لتقدير العلاقة الكمية بين عدد الخطوات اليومية وخطر الوفاة، مع تحليل الفروق بحسب العمر ومستوى النشاط الأساسي. بيّنت النتائج وجود علاقة عكسية واضحة بين عدد الخطوات اليومية وخطر الوفاة لجميع الأسباب. بيّنت النتائج وجود علاقة عكسية واضحة بين عدد الخطوات اليومية وخطر الوفاة لجميع الأسباب. أظهرت الزيادة التدريجية في عدد الخطوات تحسناً ملحوظاً في المؤشرات الصحية، خاصة عند الانتقال من مستويات نشاط منخفضة إلى متوسطة. أكدت الدراسة أن الفوائد الصحية تبدأ بالظهور وأعداد خطوات أقل من 10,000 خطوة يوميا، خصوصا لدى كبار السن. وضحت النتائج أن تحقيق حوالي 6,000 إلى 8,000 خطوة يوميا ارتبط بانخفاض ملموس في خطر الوفاة مقارنة بالمستويات المنخفضة جدا من النشاط. بيّنت التحليلات أن الارتباط الإيجابي بين الخطوات والصحة كان ثابتا عبر فئات عمرية مختلفة مع اختلاف حجم الفائدة. أشارت النتائج إلى أن زيادة الحركة اليومية حتى بكميات بسيطة لها قيمة صحية حقيقية على مستوى الصحة العامة. وختاما، تؤكد هذه المراجعة المنهجية أن عدد الخطوات اليومية يعد مؤشرا عمليا ومفيدا لتقييم النشاط البدني وعلاقته بالصحة العامة، وأن زيادة الحركة اليومية ترتبط بانخفاض واضح في خطر الوفاة وتحسن المؤشرات الصحية لدى البالغين. وتظهر النتائج أن الفوائد الصحية لا تقتصر على الوصول إلى أهداف مرتفعة، بل تبدأ من زيادات معتدلة وقابلة للتحقق، خاصة لدى الفئات الأقل نشاطا وكبار السن. وتدعم هذه النتائج تبني رسائل واضحة أو رسائل صحة عامة أكثر مرونة وواقعية، تركز على تشجيع الأفراد على زيادة عدد خطواتهم تدريجيا، بل الالتزام بأرقام ثابتة قد تكون مناسبة للجميع. كما توصي الدراسة باندماج عدد الخطوات كأداة بسيطة وفعالة في برنامج تعزيز الصحة والوقاية من الأمراض المزمنة على مستوى المجتمع. وهذا كان موضوعنا، ونعتذر على الإطالة وشاكرين لحسن استماعكم. العفو، يعطيك العافية. الله يعافيك.
السلام عليكم ورحمة الله وبركاته. الصوت واضح؟ معكم محسن هادي السهلي من مستشفى القوات المسلحة بجازان، أخصائي أشعة. موضوعنا اليوم الوقاية من الحروق الحرارية المرتبطة بالتصوير بالرنين المغناطيسي. يعد التصوير بالرنين المغناطيسي تقنية آمنة نسبيا لعدم استخدام الإشعاع المعين، إلا أن الحروق الحرارية الجلدية تظل أكثر الأحداث الضارة شيوعا. وهدفت هذه المراجعة المنهجية إلى تجميع الأدلة المتعلقة بسلامة الرنين المغناطيسي وآليات حدوث الحروق الحرارية. العرض واضح عندكم ولا اختفى؟ وتقديم توصيات عملية مبسطة لأخصائية وتقنية الأشعة للحد من هذه الإصابات. واعتمدت الدراسة على تحليل شامل للأدبيات العلمية والإرشادات المهنية، وانتهت إلى مجموعة توصيات واضحة يمكنها منع غالبية الحروق عند الالتزام بها في الممارسات اليومية. وعلى الرغم من التطور السريع في تقنية الMRI، لا تزال بعض مخاطر السلامة قائمة، وعلى رأسها الحروق الحرارية الناتجة عن ترسيب طاقة الترددات الراديوية أو التلامس مع مواد موصلة للكهرباء. وتشير تقارير الهيئات التنظيمية إلى أن هذه الحروق تمثل النسبة الأكبر من الحوادث المبلغ عنها، مع وجود احتمال لعدم الإبلاغ عن عدد كبير منها. وتكمن أهمية هذه المراجعة في توحيد التوصيات المتناثرة والمتباينة في مصادر متعددة، وتقديم إطار عملي مبسط يدعم اتخاذ القرار لدى العاملين في أقسام الMRI، مع التركيز على الوقاية وتحسين سلامة المرضى. واتبعت الدراسة تصميم مراجعة منهجية وفق إرشادات برسمة، مع تسجيل البروتوكول مسبقا في قاعدة برسبيرو. وشمل البحث قواعد بيانات الببميد والسكبوس SINHL والساينس دايركت، إضافة إلى مصادر الأدبيات الرمادية للفترة من يناير 2010 حتى مايو 2023. واستهدف البحث الدراسات التي تتناول سلامة الMRI والحروق الحرارية، بما في ذلك الأبحاث الأصلية والمراجعات والتقارير الإرشادية ودراسة الحالات. وتم تطبيق معايير اشتمال واستبعاد واضحة، واقتصر الإدراج على المشهورات باللغة الإنجليزية ذات الصلة بالتصوير السريري. وأجري فرز العناوين والملخصات ثم النصوص الكاملة بواسطة مقيمين مستقلين، وجرى استخراج البيانات وتحليلها موضوعيا لتجميع التوصيات المتشابهة مع تقييم خطر التحيز باستخدام أداة مناسبة لطبيعة الدراسات المدرجة. وبينت النتائج المراجعة أن الحروق الحرارية هي الأكثر شيوعا بين حوادث السلامة في الرنين المغناطيسي، ومعظمها يمكن تجنبه بإجراءات بسيطة. وأكدت النتائج أن أهم خطوة وقائية قبل الفحص هي إزالة أي مواد موصلة معدنية غير ضرورية من على جسم المريض لتقليل احتمال حدوث تسخين موضعي. وضحت الأدلة أن عزل الجلد جيدا باستخدام فواصل أو تبطين مناسب ومنع تلامس الجلد مع الجلد يقلل تكوين دوائر قد ترفع الحرارة موضعيا. وبينت المراجعة ضرورة منع تلامس جسم المريض مع جدار الجهاز أثناء التصوير، لأن الاحتكاك أو القرب الشديد قد يزيد خطر التسخين. أظهرت النتائج أن التعامل الصحيح مع الكابلات والملفات وتثبيتها جيدا وعدم تكوين حلقات من أهم عوامل خفض الحروق المرتبطة بالأسلاك أو التوصيلات. أكدت الدراسات أهمية الانتباه لوضعية المريض داخل الجهاز بحيث تكون مريحة وثابتة لتقليل الحركة ولمنع أي تماس قد يحدث أثناء الفحص دون ملاحظة. وضحت المراجعة أن التواصل المستمر مع المريض خلال الفحص وسؤاله عن شعوره بأي سخونة أو لسعة أو ألم يساعد على الاكتشاف المبكر وإيقاف الفحص قبل تطور الإصابة. توصلت النتائج إلى أن تطبيق مبدأ الإزالة والعزل والتواصل كنظام عمل ثابت يمكن أن يمنع حوالي 97% من الحروق الحرارية المرتبطة بالرنين المغناطيسي. وفي الختام تؤكد هذه المراجعة أن الحروق الحرارية المرتبطة بالتصوير المغناطيسي ليست حوادث عشوائية، بل يمكن الوقاية من معظمها عبر الالتزام بإجراءات سلامة واضحة ومبسطة. ويعد تطبيق نهج عملي قائم على إزالة المواد الموصلة غير الضرورية وعزل المريض بشكل مناسب والتواصل الفعال أثناء الفحص خطوة محورية لتحسين سلامة المرضى. وتبرز النتائج أهمية التدريب المستمر للعاملين في أقسام الرنين المغناطيسي وتبني سياسات مرنة قائمة على تقييم المخاطر الفردية بما يساهم في رفع جودة الرعاية وتقليل الأحداث الضارة. والسلام عليكم ورحمة الله وشكرا لكم على استماعكم.
السلام عليكم. معكم فواز صالح, Senior Registrar Radiologist. Okay, our topic today is efficiency of low-dose radioiodine therapy in patients with low and intermediate risk of differentiated thyroid cancer. Next, please. Okay, as we know, thyroid cancer is the most frequently occurring endocrine cancer, and its incidence has been increasing worldwide during recent decades. Most cases are differentiated thyroid cancer, which is associated with 10 years cancer-specific mortality rate of less than 10%. The principal standard treatment for this patient include total or near total thyroidectomy, followed by radioactive 131 iodine ablation, and lifelong thyroid hormone suppressive therapy. As per American Thyroid Association, remnant ablation is not necessary in patients with microcarcinomas. Microcarcinomas, which is less than 1 centimeter, if there is no high-risk features or no remnant or metastasis. And it is recommended if there is residual or metastatic diseases. Next slide, please. Unfortunately, there is uncertainty regarding the dose of the iodine 131 required for thyroid remnant ablation. For patients with low-risk features, the recommendation from the American Thyroid Association is that the minimal activity, usually between 11,000 or 3,700 megaberkel, necessary to achieve successful remnant ablation should be utilized. Previous work have shown that a low dose of iodine 131 is as effective as a high dose for ablation of thyroid remnant in low and intermediate risk patients. Additionally, compared with high dose radioactive iodine therapy, low dose radioactive iodine therapy is less expensive, and also it avoids hospital stay and causes fewer side effects. Next, please. Our objective in this study were to determine the response rate based on American Thyroid Association using a low-activity radioiodine ablation in patients with low risk and intermediate risk differentiated thyroid cancer. Next. Regarding our research, we use a retrospective study including low and intermediate risk thyroid cancer patients who underwent thyroidectomy followed by low dose of radioactive iodine 131 ablation therapy. Usually the dose is 30 millicurie. We conducted our data from 2018 to 2021. This is the most of the patient using this dose regarding the ablation. And ablation therapy response was assessed based on ATA guidelines, as we discussed previously. All these patients were on TSH suppressive doses of levothyroxine. Also, we monitored the structural response based on ultrasound, biochemical response based on TG and anti-TG levels, and functional response based on scintigraphic WBC. Various factors including age, gender, histology, thyroid stimulating hormone level, pre-ablation and post-ablation, also serum thyroglobulin and anti-TG antibodies. Neck ultrasound and wide body iodine 123 scan finding recorded and analyzed to assess low dose iodine 131 therapy response as well. Next, please. As we discussed, all patients were assessed from January 2018 until January 2021. 47 patients did post-operative radioactive iodine therapy. 5 patients have been excluded due to lack of TG follow-up, and 42 have TG follow-up. Most of them were females, about 85%, with mean age of 45.74 years. Histopathology result of 47 patients shows 30%, which is papillary, as we know it's the most common, 5% which is papillary with lymph nodes, and 17% follicular, and 1% and one case which is 2.1% oncocytic and Hurther cell as well. Out of 42, 37% patients have completed biochemical response. Only 5 patients shows incomplete biochemical response based on suppressed TG level. 2 of these patients show structural and scintigraphic complete response. 3 showed structural incomplete response and scintigraphic schedule. 12 patients show structural incomplete response related to ultrasound remnant. 5 of these patients had correlated wide body scan, which shows complete resolution of the remnant, including scientific complete response. 2 out of these 12 patients biochemical incomplete response and follow-up WBC scan scheduled. 3 out of 43 patients had raising anti-TG. However, all of them shows scintigraphic complete response. The raising anti-TG, one of the independent predictor factor indicating residual functional remnant or lymph node or distal metastases. However, in our data set, all 3 patients with high anti-TG showed complete structural response in ultrasound and TG value and WBC as well. Next, please. Our conclusion that a low dose of 131 iodine ablation was sufficient for reaching a complete response at 6 to 12 months of follow-up in the majority of patients with DTC. Thank you. And next, please. This is our references regarding this research. And thank you for your time.
السلام عليكم. الصوت واضح؟ فهد حسن عيسى عسيري، مستشفى القوات المسلحة بنجران، فني تمريض. تحقيق التوازن بين الواجب والمخاطرة بالعاملين الصحيين في الخطوط الأمامية أثناء الطوارئ الصحية. تهدف هذه الدراسة إلى تحليل التوازن بين الواجب المهني والمخاطر الجسدية والنفسية والأخلاقية التي يتعرض لها العاملون الصحيون في الخطوط الأمامية أثناء الطوارئ الصحية، مع التركيز على دور السياسات الصحية والدعم المؤسسي في تحسين سلامة الكوادر وجودة الرعاية. يمثل العاملون الصحيون خط الدفاع الأول في الطوارئ الصحية، حيث يتحملون مخاطر جسدية ونفسية وأخلاقية عالية نتيجة طبيعة العمل في البيئات عالية خطورة الحجم. التحديات المرتبطة مرتبطة بنقص الكوادر. أبرزت جائحة كوفيد الموارد وطول ساعات العمل والضغوط الأخلاقية والصحية لتقديم الرعاية الصحية أثناء الأزمات. اعتمدت الدراسة على مراجعة نوعية منهجية شملت الأدبيات من 2016 إلى 2023 الأدبيات العلمية المنشورة خلال فترة 8 سنوات. تم البحث في 3 قواعد بيانات علمية رئيسية: بوب مايد وسكوبس وويب أوف ساينس. مصطلحات بحثية مركبة مرتبطة أكثر من 10 استخدامات بالعاملين الصحيين والطوارئ الصحية بإدارة المخاطر. دراسة أولويات استخدمت أكثر من 10 مصطلحات بحثية مركبة مرتبطة بالعاملين الصحيين والطوارئ الصحية وإدارات المخاطر. تم فحص ما يزيد عن 120 دراسة أولية استبعد منها 58% لعدم استيفاء معايير الجودة والمنهجية. شملت العينة النهائية 50 دراسة محكمة ركزت على المخاطر الجسدية والنفسية. استخدمت التحليل الموضوعي لاستخلاص 4 محاور رئيسية: المخاطر الجسدية، الضغط النفسي، التحديات الأخلاقية، والدعم المؤسسي. أظهرت النتائج أن العاملين الصحيين شكلوا ما يقارب 14% من إجمالي إصابات كوفيد عالميا. سجلت أعراض القلق لدى نحو 45% من العاملين الصحيين خلال فترة الطوارئ الصحية. بينت نتائج انتشار أعراض الاكتئاب لدى ما يقارب 30% من الكوادر الصحية. تجاوزت معدلات الاحتراق الوظيفي 20% خصوصا في أقسام الطوارئ والعناية المركزة. ارتبط نقص معدات الوقاية الشخصية بزيادة الإصابة بمقدار الضعف في بعض البيئات عالية الخطورة. ساهمت برامج الدعم النفسي والتدريب المؤسسي في خفض معدلات الاحتراق الوظيفي بنسبة تراوحت بين 35 إلى 20%. 25%. تؤكد الدراسة أن حماية العاملين الصحيين تمثل ضرورة أخلاقية ومهنية لضمان استخدام الأنظمة الصحية، وتوصي بتعزيز الجاهزية المؤسسية وتكامل الدعم النفسي وتوسيع استخدامات التقنيات الصحية والحديثة. آسف على الإطالة.
السلام عليكم. الصوت واضح، تسمعوني؟ بسم الله، معكم سيف الشهراني. اليوم بتكلم عن اتجاهات الطلب المتزايد على التمريض في أقسام الطوارئ بالمملكة العربية السعودية. تهدف هذه المراجعة المنهجية إلى تحليل اتجاهات الطلب المتزايد على التمريض في أقسام الطوارئ بالمملكة العربية السعودية، مع التركيز على التحديات المهنية والتنظيمية ونقص الكوادر التمريضية، وأثر ذلك على جودة الرعاية الصحية في ضوء التحولات الصحية الوطنية ورؤية المملكة 2030. أقسام الطوارئ من أكثر الوحدات الحيوية تعقيدا في الأنظمة الصحية الحديثة، نظرا لطبيعة الحالات الحرجة والتدفق المستمر للمرضى والحاجة إلى استجابات علاجية فورية عالية الدقة. ويعد التمريض العمود الفقري للعمل داخل أقسام الطوارئ، حيث يطلع الممرضون بمهام أساسية تشمل الفرز السريري، التقييم السريع، تنفيذ التدخلات العلاجية العاجلة، والمتابعة المستمرة للحالات. شهدت المملكة العربية السعودية توسعا ملحوظا في خدمات الرعاية الصحية خلال العقدين الماضيين، متزامنا مع النمو السكاني وارتفاع معدلات الحوادث والأمراض المزمنة، مما أدى إلى زيادة الضغط على أقسام الطوارئ وارتفاع الطلب على الكوادر التمريضية المؤهلة. المنهجية اعتمدت الدراسة على منهجية المراجعة الأدبية التحليلية، حيث تم تحليل أكثر من 25 دراسة علمية محكمة وتقارير رسمية منشورة في قواعد بيانات معتمدة خلال الفترة من 2000 إلى 2022. ركزت عملية التحليل على 4 محاور رئيسية شملت مستويات التوظيف في أقسام الطوارئ، نسب التمريض إلى المرضى، الرضا الوظيفي، ومتطلبات التعليم والتدريب المستمر. أظهرت المراجعة أن متوسط نسبة الممرض إلى المرضى في أقسام الطوارئ تتراوح بين 1 إلى 8 و1 إلى 4 حسب المنشأة الصحية. مع استخدام أسلوب التحليل المقارن لاستخلاص الاتجاهات العامة وتحديد الفجوات التنظيمية والتحديات المشتركة. كما تم تحليل أثر السياسات الصحية الوطنية بما في ذلك رؤية المملكة 2030 على استدامة القوى التمريضية وجودة الرعاية الصحية. النتائج أظهرت النتائج وجود نقص يتجاوز 30% في أعداد الكوادر التمريضية العاملة في أقسام الطوارئ في عدد من المنشآت الصحية، خاصة في التخصصات الدقيقة. كما بينت الدراسات وجود علاقة مباشرة بين انخفاض كثافة التمريض وزيادة فترات الانتظار بنسبة تتراوح بين 20 و 35%، إضافة إلى ارتفاع معدلات الأخطاء الطبية وانخفاض رضا المرضى. وأشارت النتائج إلى أن أكثر من 40% من الممرضين أفادوا بتعرضهم لمستويات مرتفعة من الإرهاق الوظيفي نتيجة ضغط عمل وطول ساعات المناوبة. في المقابل، أظهرت برامج التوطين والتدريب المرتبطة برؤية المملكة 2030 تحسنا ملحوظا في معدلات الاستبقاء الوظيفي بنسبة تقارب 15% خلال السنوات الأخيرة. في الخاتمة، تؤكد الدراسة أهمية تبني سياسات مستدامة لدعم التمريض في أقسام الطوارئ من خلال تحسين بيئة العمل، الاستثمار في التعليم والتدريب، وتطبيق نماذج توظيف قائمة على الأدلة. كما تسهم هذه الإجراءات في تعزيز جودة الرعاية الصحية وضمان استدامة خدمات الطوارئ وتحقيق مستهدفات التحول الصحي ورؤية المملكة 2030. وشكرا لكم.
السلام عليكم ورحمة الله. عبد الملك الهوتي، مستشفى القوات المسلحة بالقصيم. واضح الصوت؟ موضوع دور أنظمة الدواء الإلكترونية في تقليل أخطاء الأدوية داخل المستشفيات. تمثل أخطاء الأدوية أحد أبرز التحديات سلامة المرضى داخل المستشفيات، وقد دفعت هذه المشكلة العديد من الأنظمة الصحية إلى تبني أنظمة الدواء الإلكترونية كبديل للأنظمة الورقية التقليدية. وهدفت هذه الدراسة إلى تقييم مدى فعالية أنظمة الدواء الإلكترونية في تقليل معدلات أخطاء الأدوية والضرر المرتبط بها لدى المرضى المنومين، إضافة إلى رصد الأخطاء الجديدة المرتبطة باستخدام هذه الأنظمة. واعتمدت الدراسة على مراجعة منهجية وتحليل تلوي للأدلة المتاحة، وأظهرت النتائج هذه الأنظمة تساهم في خفض معدلات أخطاء الوصف الدوائي وإعطاء الدواء، بينما لا يزال تأثيرها على تقليل الضرر الفعلي للمريض أقل وضوحا، ويعتمد على خصائص النظام وطريقة تطبيقه. تعد أخطاء الأدوية من أكثر أسباب الضرر القابلة للوقاية داخل المستشفيات، وتشمل أخطاء في الوصف أو التحضير أو الإعطاء، وقد تؤدي إلى مضاعفات خطيرة تطيل مدة الإقامة وتزيد معدلات المرضى والوفيات. وفي إطار الجهود العالمية لتعزيز سلامة المرضى، أطلقت منظمة الصحة العالمية مبادرة الدواء دون ضرر بهدف خفض الأضرار المرتبطة بالدواء بشكل كبير. وقد شجعت هذه المبادرة على التوسع في استخدام أنظمة الدواء الإلكترونية مثل أنظمة الوصف الإلكتروني وأنظمة إدارة إعطاء الدواء، لما توفرهم مزايا كتحسين وضوح الوصفات وتقليل الأخطاء الإجرائية ودعم اتخاذ القرار السريري. ومع ذلك فإن فعالية هذه الأنظمة في تقليل الضرر الفعلي للمريض ليس فقط عدد الأخطاء ما زالت محل نقاش علمي، وهو ما تسعى هذه المراجعة لتوضيحه. شملت معايير الاشتمال الدراسية التي قارنت معدلات أخطاء الأدوية قبل وبعد تطبيق أنظمة الدواء الإلكترونية داخل المستشفيات، أو قارنت بين أقسام تستخدم الأنظمة الإلكترونية وأخرى تعتمد على الأنظمة الورقية. تم ضمن الدراسات التي قيمت أخطاء الوصف الدوائي وأخطاء إعطاء الدواء والضرر المحتمل أو الفعلي للمريض. واستبعدت الدراسات التي اعتمدت فقط على تقارير الحوادث التي طبقت في تداخلات إضافية بالتزامن مع النظام الإلكتروني. أجري تقييم جودة الدراسات باستخدام أدوات تقييم منهجية معتمدة، وصنف الدراسة إلى ضعيفة ومتوسطة وقوية الجودة. وعند توافر بيانات قابلة للدمج من 3 دراسات أو أكثر، تم إجراء التحليل التلوي باستخدام نماذج التأثيرات العشوائية. وضحت المراجعة أن تطبيق أنظمة الدواء الإلكترونية ارتبط بانخفاض واضح في أخطاء الوصف الدوائي في أغلب الدراسات المشمولة، وظهر التحليل التلوي انخفاض ذات دلالة إحصائية في أخطاء إعطاء الدواء في تطبيق الأنظمة الإلكترونية. أكدت النتائج أن تأثير الأنظمة على تقليل الضرر الفعلي للمريض كان غير ثابت، حيث لم يظهر التحليل التلوي انخفاضا واضحا في معدلات الضرر المرتبطة بالأدوية. وضحت الدراسات أن جودة الأدلة كانت متفاوتة مع قلة الدراسات ذات الجودة العالية التي قيمت الضرر الفعلي بشكل مباشر. سجلت بعض الدراسات ظهور أخطاء جديدة مرتبطة باستخدام النظام الإلكتروني، مثل أخطاء ناتجة عن واجهة الاستخدام أو إعدادات النظام. بيّنت النتائج أن الأنظمة المزودة بدعم قرار سريري متقدم كانت أكثر فاعلية في تقليل بعض أنواع الأخطاء مقارنة بالأنظمة الأساسية. أشارت الأدلة أن التدريب الجيد وتكييف النظام مع سير العمل يقللان من الأخطاء المرتبطة بالنظام ويحسنان من الاستفادة منه. وفي الختام، توضح المراجعة المنهجية أن أنظمة الدواء الإلكترونية تلعب دورا مهما في تقليل معدلات أخطاء الأدوية، لا سيما أخطاء الوصف وإعطاء الدواء، مقارنة بالأنظمة الورقية التقليدية. ومع ذلك فإن الأدلة الحالية لا تزال غير كافية للجزم بتأثير ثابت لهذه الأنظمة على خفض الضرر الفعلي الذي يتعرض له المرضى، وهو ما يعكس تعقيد قياس هذا النوع من النتائج. وتشير النتائج لأن فاعلية أنظمة الدواء الإلكترونية تعتمد بدرجة كبيرة على مستوى دعم القرار السريري المدمج، وجهود التصميم وطريقة التطبيق والتدريب المستمر للمستخدمين. وتوصي الدراسة بإجراء دراسة مستقبلية عالية الجودة تركز على قياس الضرر الفعلي للمريض وتحديد خصائص الأنظمة الأكثر فاعلية، بما يساهم في تعظيم فوائد هذه التقنيات وتحسين سلامة المرضى داخل المستشفيات. والسلام عليكم، وآسف على الإطالة. شكرا.
السلام عليكم. الصوت واضح؟ نتكلم اليوم عن الأدوار المتكاملة في مسار رعاية جراحة القلب والصدر. تهدف هذه المراجعة تكاملية لتحليل الأدوار المتداخلة والطبية والأخصائية الاجتماعية وهيئة التمريض في مسار رعاية مرضى جراحة القلب والصدر، مع إبراز أثر التكامل متعدد التخصصات على سلامة المرضى وجودة النتائج السريرية. تعد جراحة القلب والصدر من أكثر المجالات الرعاية الصحية تعقيداً، إذ تعتمد جودة النتائج على التنسيق الفعال بين الرعاية التمريضية والدعم النفسي والاجتماعي والتنظيم الإداري عبر مسار الرعاية الكامل. اتبعت الدراسات منهجية المراجعة التكاملية وفق إطار بهدف دمج الأدلة الكمية والنوعية والمختلطة لتقديم تحليل شامل لمسار رعاية جراحة القلب والصدر. أجري بحث منهجي موسع في 6 قواعد بيانات علمية رئيسية هي جوجل سينس ديكريت وسينس شانل، ويشمل الدراسات المنشورة خلال فترة من 2020 إلى 2025. أسفرت استراتيجية البحث عن 1236 دراسة أولية، وبعد إزالة التكرار تم فحص 742 عنوانا وملخصا، وخضعت 39 دراسة للتقييم النصي الكامل وفق معايير الاحتمال والاستبعاد المحدد مسبقا في ضوء تقييم CASP الجودة المنهجية باستخدام أدوات JBI النوعية وأدوات الدراسات الكمية والمختلطة. تم تضمين 8 دراسات عالية الجودة في التحليل النهائي، واقتصر التحليل على الدراسات المصنفة بجودة متوسطة إلى عالية. أظهرت نتائج المراجعة أن التمريض المتخصص في جراحة القلب والصدر يمثل العامل الأكثر ارتباطاً بتحسين النتائج السريرية وسلامة المرضى، وقد بيّنت الأدلة أن تحسين نسبة الممرض إلى المريض ارتبط بانخفاض معدل الوفيات داخل المستشفى بنحو 14%، إضافة إلى تقليل معدلات المضاعفات بعد الجراحة، بما في ذلك العدوى واضطراب النظم، وتقليص مدة الإقامة بالمستشفى بمعدل يتراوح بين يوم ويومين. كما أوضحت النتائج التدخلات النفسية الاجتماعية بما يشمل التقييم النفسي المنهجي، الإرشاد وإشراك الأسرة في خطة الرعاية. أسهمت في خفض مستويات القلق والاكتئاب لدى المرضى بنسبة تراوحت بين 20 إلى 30%، من تحسن ملحوظ في الالتزام ببرامج إعادة التأهيل القلبي. وعلى مستوى النظام الصحي، أظهر التكامل بين التمريض والأخصائيين الاجتماعيين والكوادر الإدارية تحسنا في استمرار الرعاية وجودة التواصل، إلى جانب تقليل التأخرات الإجرائية. في الختام، تؤكد الخاتمة أن نموذج الرعاية التكاملي متعدد التخصصات يعزز السلامة وجودة الرعاية في جراحة القلب والصدر. شكرا لكم لاستماعكم.
السلام عليكم ورحمة الله وبركاته. واضح الصوت؟ معاكم أخوكم فهد الشريف، أخصائي أول مختبرات طبية مستشفيات القوات المسلحة بالهدف. نتكلم عن البروجكت اللي هو Advancing Quality of Life through Colorectal Cancer Screening. Background and local problem. Colorectal cancer, CRC, is a significant health concern in Saudi Arabia due to various factors, including genetics, diet, lifestyle, and aging. The incidence has been rising, making it the most common cancer in Saudi males and the second most common in the females. Challenges in early detection and screening contribute to the problem with the limited test and delayed follow-up. In April 2023, only 16% of the average risk population was being screened, leading to delays in the managing positive results and hindering early CRC detection. Effective screening and prevention strategies are crucial to address this issue. The project aims to boost colorectal cancer screening rates among individual age 45 to 75 for 60% screening rate with the 6 months, and with the MODH KPI target of 66% within the same period to improve early detection and reduce associated morbidity and mortality. The method. The intervention was implemented targeting 15,637 individual age 45 to 75. The intervention including patient-centered, personalized WhatsApp alert, and education of patient about the importance of screening, a cross-function agreement with the clinic, colonoscopy appointment with the 2 weeks of a positive fit test with the laboratory department to ensure enough supply to do mass screening. Intervention. The strategy focus on enhancing patient awareness and facilitating rapid access to screening and diagnostic procedure. These interventions were targeting toward achieving a screening rate of 60% of the target population with 6 months. The results. Post-intervention, the screening are reaching over 67% in the 5 months, and diagnostic and treating 3 early cancer and 6 precancerous condition. This was attributed to the effect use the WhatsApp alert and for near colonoscopy appointment, demonstrating a significant improvement in screening, uptake, and early detection rates. Conclusion. The intervention effectively increased colorectal cancer CRC screening rates using WhatsApp and rapid access for screening and follow-ups, suggesting potential benefits across MODH hospital. Second, communication and collaborative health approach, enhancing CRC screening effectiveness. Moreover, it is sustainability is ensured through an adaptable framework, including a registry system for consistent patient engagement and follow-up. This is robust infrastructure make the project available model for other screening service. Thank you very much. يعطيكم العافية. شكرا لكم.
السلام عليكم، الصوت واضح؟ شكرا لك. أخوكم حمدان الراجحي، استشاري الطوارئ بمستشفى القوات المسلحة بجدة. Today I'm presenting this case series of disk battery ingestion, a single event with different outcomes. Can you please zoom in into the introduction part? Okay, so infants usually and young children are known to explore their surroundings by touching and tasting. This will lead most of the objects to end up, thank you so much. This will lead most of the objects to end up in their GI tract. And as you know, recently disk batteries have been more prevalent in houses for the last 30 to 50 years. So disk batteries are becoming more common and common in their presentations to the ED. Since they are shiny and small as well. The complications of disk battery ingestion can range from very simple URTI-like symptoms and dysphagia to more severe outcomes like esophageal burns and fistulas as well. Most complications can be minimized by early detection and prevention as well. We have two cases. One of them is a benign case and the other one is, let's say, the malignant case. Can you please move to the cases section? Thank you so much. So I will give you a summary of case one. This is a 2-year-old girl presenting to the ED with 2 days history of fever, drooling, coughing, dysphagia, cyanosis, tachypnea. So the first thing that will come to your mind as a health practitioner is this is most likely either URTI, pneumonia, or abscess, peritonsillar abscess. However, with workup and X-ray, can you please move down to the X-ray? سامحني بتعبك معي شوي. شكرا لك. ممكن تسوي زوم على الصورة اللي في اليسار؟ أيسر صورة. أيوة اللي في اليسار مرة. ممتاز. So as you can see in the AP film on the left, there is a round object with 2 lines. إذا قدرتوا تشوفون دائرتين. So this is called the double ring sign, which is the pathognomic sign for disk battery objects. So a diagnosis was made for this patient with disk battery ingestion. So this patient was admitted to the ward. So this patient was admitted to the ward, and can you please go back to the section of the cases? فوق شوي. Yeah, so after admission and antibiotic, the patient has undergone esophagoscopy. منظار للمريء. Esophagoscopy has showed circumferential esophageal burn on the edges of the disk battery. The battery was carefully removed, and thankfully there was no local complications. So there was no pneumomediastinum or fistula. The patient recovered gradually, and she was moved to the ward. She was NPO, she was given IV fluids, histamine blockers, and IV antibiotics for 5 days. Then she was discharged and followed on monthly basis for frequent assessments for dysphagia or drooling if there is. But thankfully the patient did very well and no complications were noted. So this is one example. Moving to the second case. The second case is around the same age. She is 15-month-old girl presenting again with dysphagia only. So the presentation here is better and more benign than the presentation of the first case. And the disk battery was also found on the X-ray as in the first case. The patient was admitted, endoscopy was done, which showed a more severe features this time. The esophagoscopy and swallowing tests showed deep esophageal ulcer with gangrenous tissue and bleeding, suggesting prolonged impaction. So the impaction was for long that it caused ulceration and perforation as well. Although the symptoms were simpler, dysphagia only. So never rely on the degree of the initial presentation. The patient was admitted to PICU as well when she developed stridor later on. She was admitted there for 5 days in supportive therapy, and she was having multiple episodes of choking and cyanotic episodes. The CT chest with oral contrast showed no pneumomediastin. The patient managed conservatively with monitoring and, as I said, antibiotics and TPN. Then she was undergone an endoscopy that showed a tracheoesophageal fistula, which is an extra tract مسار زائد بين المريء والقصبة الهوائية. And that is related to the severe impaction that caused perforation and fibrosis that led to the extra tract, the tracheoesophageal fistula. So she underwent a surgical repair without going into details. She was discharged and then she was followed up on a monthly basis. And unfortunately, she developed more frequent dysphagia that needed frequent dilatation by the esophagoscope on the later visits, until 6 months when she did well and she was discharged from the clinic. Can you go down to the last part, the discussion part? طبعا هذه الاكس راي زي ما انتم شايفين الليك او الفستولا اللي صايره بين الاسوفجس والتراكيا. So in summary, foreign body ingestion in children is a common issue, with around 80% occurring between 6 months to 6 years. So the golden number is 6 to 6. 20 millimeters 2 centimeter disc battery carry the most risk. فكل ما كان الديسك باتري أقرب لل 2 سنتيمتر كل ما كان خطره أكبر. With nearly 12% of children suffering severe or fatal injuries. So of every 100 patients with disc battery ingestion, 12 patients will have severe complications, according to research. Theories behind the damage that is exerted by the disc battery, they have 3 theories. The first one is simply the direct pressure. البريشر اللي الديسك باتري تسببه هو اللي حيسبب الضرر. فهذه أول نظرية في أسباب الضرر الناتج عن ابتلاع البطاريات. Second theory is mercury release اللي هو انحلال أو تسرب المادة اللي بداخل البطارية. And lastly electrical circuit conduction المرور الكهربائي أو التيار الكهربائي بين القطب الموجب والسالب هو اللي يسبب المشكلة. As well, this is the most likely theory, the electrical circuit conduction. Diagnosis may be delayed due to viral illness symptoms, as we saw in the second case, when the patient had only dysphagia, but in esophagoscopy, we found that there is a perforation due to prolonged impaction. For operative medical therapy is controversial, and endoscopy should be performed to rule out early complications. A primary prevention is crucial as in any disease, especially in this pediatric age group, and parents should educate their children to create a safe environment at home. This was my presentation. Thank you so much for listening. يعطيكم العافية. And thank you for the moderator as well. To receive any questions if there is. Allah يعلم.
السلام عليكم ورحمة الله. الصوت واضح؟ معكم سامي مهدي القحطاني، بنتكلم عن القيادة التمريضية والرعاية المرتكزة على المريض. تهدف هذه الدراسة إلى تقديم تحليل علمي لدور القيادة التمريضية في دعم وتطبيق مبادئ الرعاية المرتكزة على المريض داخل المؤسسات الصحية بالمملكة العربية السعودية، مع التركيز على أثر أنماط القيادة المختلفة في تحسين جودة الرعاية ورفع مستوى رضا المريض وتعزيز سلامة الخدمات الصحية. تعد القيادة التمريضية أحد المكونات الرئيسية في تطوير الأنظمة الصحية وتحسين مخرجات الرعاية الصحية. ومع التوجه العالمي نحو تبني نموذج الرعاية المرتكزة على المريض، برزت الحاجة إلى أنماط قيادية فعالة تعزز التواصل المهني وتمكين الكادر التمريضي وتدعم بيئات العمل التعاونية داخل المنشآت الصحية، حيث اتبعت الدراسة منهجية مراجعة أدبية تحليلية، حيث تم تحليل الدراسات المنشورة في مجلات علمية محكمة ضمن قواعد بيانات معتمدة كما تشاهدون، بهدف استخلاص الأدلة العلمية المتعلقة بأنماط القيادة التمريضية وتأثيرها على تطبيق الرعاية المرتكزة على المريض. وأظهرت نتائج المراجعة وجود علاقة إيجابية بين أنماط القيادة التحويلية والديمقراطية والخادمة وبين تحسن رضا المرضى وتحسين جودة التواصل بين مقدمي الرعاية والمرضى، إضافة إلى تقليل مستويات الإرهاق الوظيفي لدى الكادر التمريضي وتعزيز جودة بيئة العمل الصحية. وتشير نتائج الدراسة إلى أن تبني أنماط قيادية وتشاركية يسهم في تعزيز ثقافة العمل الجماعي ويدعم التطبيق الفعال لمبادئ الرعاية المرتكزة على المريض، في حين أن الاعتماد المفرط على الأنماط السلطوية قد يؤدي إلى تقليل المشاركة المهنية والحد من الابتكار في الممارسة التمريضية. ختاما، تلخص الدراسة إلى أن الاستثمار في تطوير القيادات التمريضية وبرامج التدريب القيادي يمثل عاملا محوريا في تحسين جودة الرعاية الصحية ودعم التحول الصحي الوطني وتحقيق مستهدفات رؤية المملكة العربية السعودية 2030. شكرا لكم ونعتذر على الإطالة.